Hello. Very good afternoon to one and all present here. Welcome to the DRS, the session organized by DRS. Today, we come together to explore the latest innovations in diabetes, that is diabetes in 2024. As we embark on this journey of knowledge and inspiration, I'm thrilled to introduce our esteemed chairperson, Dr. Complication, Dr. Kalpesh Shah, and Dr. Jimmy Sriram. A prominent figure in this particular field of diabetes. Please join me in welcoming them to the stage. Respected players, we will take you on the session from here. Thank you very much. Hello. Yeah. So welcome everybody. So let's start today's afternoon session. So it will be discussion on diabetes in 2024. So first speaker will be Dr. Chakravarti, Anil Chakravarti. He will be speaking on sitagliptin, the legacy of sitagliptin and what in the future ahead. Good afternoon, everyone. It is such an exciting feeling to be the opening batsman of a hall. So the scoreboard must go on ticking so that the entire show goes well. So my topic would be sitagliptin, the legacy continues. Can I have it full screen? Full screen. Yeah, thank you. So, yeah, at the outset, I must declare the commercial interest, but I also tell you that only science will be discussed here. I always carry two thank you slides with me. The first of all, obviously, goes out to the organizers, right from delectable delicacies to exciting deliberations. Dr. Chawla and his team has done a wonderful job. And Chairperson, thank you for introducing me, and sponsors, thank you for providing a platform for discussion. Now, the flow of the presentation in the next 30 minutes will be such that we will be talking about why gliptins at all among babies are still relevant, and why specifically among that family, sitagliptin deserves special mention. Now, this is the flow of the presentation. Specifically, we'll talk about the renal effects, the upcoming in hepatic compromise. How do we look at it as far as CVOTs are concerned? Because that is actually the take home message for everybody. One is such that suppose I'm walking down in my car to somewhere like this. I go to a roadside dhaba and I'm just enticed to eat something here because of the neatness and cleanliness. And suddenly, instead of going to the washroom, I bump into the kitchen of them and see something like this. My entire appetite will disappear. So this is exactly what happens in diabetes as well. If you see a patient who's had say 2 years diabetes on sulfonylurea and metformin has an HbA1c of 6.8. Is this figure excellent? So are you happy with this lovely HbA1c? Obviously not. People now in today's 2024 will be talking about severe risk burden, renal risk burden, mortality risk burden, etc. Fair enough. So diabetes management is not only glucocentric as it was, the shifted vitamin package, though patients often do not understand this. Dr. Saab, मेरा से sugar कम कर दीजिए. But this part we are actually forgetting as we are progressing with fancy molecules like SGLT2 inhibitors and GLP-1 receptor agonists. Let us talk about how times have changed in recent times. This is the Statue of Liberty, and what is this? A modified version. Statue of too much liberty. So people are eating more, leading to problems, hence we are invoking GLP-1s and SGLT2 inhibitors to say, okay, they are the products to be consumed in the market. So these things maybe are going down. When I was doing my DN residency 10 years back at Kolkata, so I could have chosen any of the 6 classes of drugs without any bias and prejudice after metformin. So it may be sulfonylurea, thiazolone B1, DP4, SGLT2, anything you can choose. So it was just like as you like it from Shakespeare. But now things have changed. In the last few years, if you move along any algorithm, you will see you have to scratch your head and understand whether the patient has ACD, propensity to heart failure, needs to lose weight, has hypoglycemia problem, and other issues, obviously. So it is the diabetes plus something that is actually determining the choice. And gradually the focus is shifting away from the diabetes management. I believe you are tempted already, but you must remember that if you hold a rose in your hand, everything doesn't become rosy. There is a chance of being pricked by the thorn and chance of bleeding. That doesn't stop us from falling in love. We obviously give a rose to our beloved. So we need to understand if we start with a molecule in diabetes management, why it should be looked in, that has to be understood. Many of the side effects that we actually can have at the very outset actually breaks the confidence of the patient. Suppose the patient lands up in genital mycotic infection, some dizziness, some breathing issues, some urinary tract infections, etc. So starting molecules should be such which gives you a very smooth cruise along the journey of diabetes. If you look at the non-CV safety data of SGLT2 inhibitors, what are the data from the RCD? I've just pinpointed here. We need to understand that the use of SGLT2 inhibitors were associated with higher risk of infection, osmotic diuresis, volume depletion, renal-related adverse events as well. But this gets drowned with the going gaga with the CV issues which we discussed. So we only show like an advertisement. Only the good things are shown. The other aspects are actually brushed under the carpet. This we should remember. If you talk about HBS-specific issues, obviously gliptins and issues work better. We know that because of the enzyme expression. Secondly, in a place where I practice, some districts go beyond 45 degrees in West Bengal. So what we do from April to June, often we have to actually remove SGLT2 inhibitors, decrease the dose of diuretics, decrease the dose of antihypertensives as well. So these are problems which need continuous movement of clutch and gear while you are driving. So it is something like, the mic has gone. So it's something like investing. Hello? Awas? Okay. So it's something like investing in a share market vis-a-vis a fixed deposit. If you want a bumpy ride like this, then maybe you will choose something like SGLT inhibitor or a GLP-1 which can lead to pancreatitis, vomiting, patient will say, I cannot take this medication anymore, etc. But if you are investing something like a fixed deposit, well, you will give the drug and just forget. The patient may come after 1 year, 6 months, it will not lead to much problems to you. So you have to choose your way, on which side you will go. We have enough evidence for verified trial as well, though it is not dealing with sitagliptin, but gliptin as a family. But if we start with the early combo, that is also a feasible thing to do in today's world. Now coming to the individual things. These 5 brothers have just welcomed a newly born sister in their family. They are born of the same biological fathers and mothers, and but obviously they have something in common and something different. Coming to the 5 molecules that we have at our disposal, I have removed gliptin from here. Isn't that agenda CVOT generally is a good drug, but still many people are not convinced in CVOT world. Satva has gone into derivative for various reasons. So we will talk of Sita versus linagliptin. So all gliptins are good, they are potent, effective, they address the core defects of diabetes, they partner well with conventional medications, can be administered any time of the day, meal independent, very good. No excess hypoglycemia, no weight gain. Now, sitagliptin has been an experience for 18 years in the Indian market. It was launched in 2006. So we see enhanced efficacy in us, but there are some differences between the gliptins as well. So that may be a selectivity profile, the renal metabolism, the hepatic metabolism, concern of heart failure, etc. We'll just dissect another 7 minutes on that. So the story of development of DPP inhibitor not only is about identifying the most potent inhibitor, but also the most selective inhibitor. Just look at the first and the last line, Sita versus linagliptin. If you give a dose, 97% inhibition occurs as soon as you give a liquid concentration of the food. Now, we have crests and troughs with the dose. Immediately before the next dose, what is the level of DPP4 inhibition? It is more than 80% for sitagliptin. So it is a truly DPP4 inhibitor. That part is established. Now, is it only DPP4 that is inhibiting? That also needs to be understood. That means whether there is some collateral damage, other enzymes are also getting affected. So obviously these are other enzymes. We know that if they are inhibited, they can lead to some side effects like nasopharyngitis, arthralgia, etc. Because these are expressed almost ubiquitously in different parts of the body. We know that fat fibrillous activating protein has role in malignant progression of tumors, level. So maybe we need to understand this graph as well. If the ratio is more than 2000, it is said it is jolly well enough for DPP4 selectivity. So both Lina and Sita are doing well. The Lina has numerically more effectivity in selection of the drug. But in FAP inhibition, obviously linagliptin doesn't score so much. So if you're talking about a good DPP4 inhibition and a truly specific DPP4 inhibition, it comes to sitagliptin. So minimizing off-target inhibition in the various tissues, as I mentioned, including the cardiomyocytes, is obviously on the anvil. Now, huge volume of data because we have the oldest gliptin. Is Sita and cardiovascular outcomes. I got 308 for Sita and 116 for Lina. This is just recently taken. And then comes the most interesting part. Everybody says linagliptin is the best thing to do in renal compromise. See, when I choose this, 73 results came out for Sita and 62 came out for Lina. Why? I will tell you in the course of the discussion. So Sita was approved much earlier, so it is already ahead in time. And just as when there is a problem in the village, everyone goes to the village mukhya or the most wise person. Everyone gliptin scores over other gliptins. Coming to a very important clinical point, if you are treating diabetes with tuberculosis, many drugs are there where there are drug interactions. And you know, once you treat tuberculosis, there is a lot of chance that your sugars will actually go haywire and fall off the edge. Whereas you use sitagliptin because it is not being affected by the cytochrome enzyme metabolism by rifampicin, it is one of the safest drugs that can be chosen. So if you look at it, only metformin and sitagliptin minimally metabolized, and Sita, Vilda, Empa, Depa do not have much drug-drug interaction. So Sita is common between both of them. Coming to the two next important things, in CLD, many people have this idea that when the liver is crying for help, you are actually selecting either insulins or linagliptin in category C of childpox score. But actually, I will today break that jinx and tell you on what basis that was said. This was basically based on this study. I found this out from British Journal of Clinical Pharmacology, where only 32 patients were selected. And on that, this guideline or so-called perception came. And this level of evidence is so small, with 33 patients on board, you are just going around the globe and saying that linagliptin is safe in childpox score category C. So I'm not very much convinced about that. I cannot give a green signal based on this small data. So this should be remembered. When the kidneys cry for help, almost there is a monopoly for linagliptin. Everybody will say, no, no, linagliptin. I'll just quote something like this. When you face a bumper on the road, you need to adjust your clutch and gear. You need to slow down. That is exactly what you do. When there is a kidney bump in the diabetes mellitus treatment trajectory, this is exactly what you do. So I quoted this from endocrine clinics of North America, published way back in 2014. And this was given that according to EGFR, you can actually modulate the dose and use it jolly well without any much problem. It is just akin to driving a scooty which has no clutch and gear, like linagliptin, or according to the road conditions, you drive a bike with sitagliptin. So it is not that sitagliptin cannot be used. So this thing should be driven home very emphatically. And also, this is important, what happens to the efficacy? These are three categories of patients that pick up this: 100 versus 50 versus 25. The efficacy does not reduce reducing kidney function. That means sugar control is there and harmful effects is not there. So both are actually cherry on the cake for sitagliptin. Coming to the most important part now is TCOS trial, because everybody is now interested in the cardiovascular outcome. So I put this as a summary. These are two of my seniors who published this from Calcutta. They said TCOS was a picture perfect trial pulling along the other drugs in this group towards the positive side and ruling out the fear of class effect as far as the adverse effects were concerned. So what are upsides of this trial? It was a large trial. Considerable duration of follow-up was there, and it was very well designed. That means as it should be done without suppressing anything. There was actually no allocation concealment. It was registered, appropriately powered to understand the outcomes, and CV outcomes were pre-specified, adjudicated, and clinically relevant. These are very important terms in statistics as far as clinical trials are concerned. An intention to treat analysis as well as per protocol analysis were performed for the primary composite endpoint. This is a very important, pivotal point for any good clinical trial. Coming to the heart failure subgroup, this was quite interesting. About 2,500 odd people with prior heart failure, it was seen that there was no increased risk of heart failure among those treated with sitagliptin. So overall, the group observed no difference in total heart failure events or mortality among patients with at least one hospitalization for heart failure in the sita-treated arm. Now question is, Saxa behave differently. Why is sita like this? A beautiful article is this one. Anybody can go through it. This is a postulated mechanism, not proved, but this registers to the mind very well. They said DPP4 inhibitors tend to increase the risk of heart failure by sympathetic nervous system activation as a class effect. That means everybody does that. But sitagliptin may not have done so because it inhibits the sodium hydrogen exchanger 3 in the proximal tubule, because it is excreted in the urine, whereas Saxa does not reach that site of action, so it cannot prevent that. So Saxa differs from sita. Do not just paint everybody in the same color. Sita is different from Saxa in this regard. Lastly, coming to the CKD analysis, this is very important. What this showed actually, the last paragraph is important. Over about 3 years of follow-up, CKD participants assigned to sitagliptin had rates of eye disease, neuropathy, renal failure, malignancy, bone fracture, pancreatitis, and severe hypos, similar to those treated with placebo. So CKD arm, sita arm, non-sita arm, placebo arm, both behaved similarly. There was no difference in their consequences. Coming almost to the end of the presentation, doctors always have dilemmas. I will present something, somebody in the next room will present something. What do we choose? So we need to understand that guidelines treat diseases, but we as doctors treat patients. We do not follow any mathematical algorithm, because if you do that, AI is no different from human intelligence. We must remember that this glycemic legacy that we talked about when we were in medical schools, that karma is a bitch. Whatever you do today, you will reap the benefits or the side effects maybe years later. But problem is, it is the diabetologist's karma that will haunt the patient 10 years down the line. That means once you treat the patient well today at the beginning of diabetes, he will reap the benefits much later. So do not defect to give a drug which actually does good glycemic control. How can we forget that every 1% reduction can bring down all these indices? So that part has to be remembered. So lastly, sugar reduction is important. The central part is the sugar reduction. All the peripheral sugars are the fancy products that you have in the market. You can concentrate on them, but please don't forget that glycemic control is important. So those can be cherries on the cake, but the central part, the cake should be tasty. Lastly, in the din and bustle, hue and cry, so much noise in the market about fancy molecules, we should not lose the main focus. We should not miss the wood for the trees. Summarily, sitagliptin is a good molecule, durable, efficacious, can be combined with even SGLT2 inhibitors, because we know the hyperglucagonemia can be taken care of by giving a DPP4 inhibitor along with that. My last slide. So it is an 18-year-old journey. When somebody turns 18, what do we say? He's an adult. So he's moving from adolescence with cuts and bruises, errors and omissions, trials and tribulations. It is just close to adulthood. It will bloom and blossom, and I feel Gapton legacy is going to continue. Now, issue is, before you clap, the issue is treating diabetes is just like a chessboard. How you will treat your research, whether you treat as a king, queen, or a horse, that entirely depends on you. Thank you.
Thank you for your
cherry on the cake. The cake and our satiety center, all these with carbohydrates in our meals. So carbs, carbs, carbs is what Indian diet is made up of. And that ultimately will lead to postprandial excursions of blood glucose. So I'll be talking about the importance of controlling this postprandial excursion. So this is my agenda. So how postprandial means hypoglycemia is different in Asians and Indians. Importance of addressing this and role of AGIs in controlling and these complications of PPH. So as we know, this was a landmark study done by Dr. Shashank Joshi, the STAR study, which showed that, and it's very practical, we just imbibed that it was there on paper, but we all know our Indian diet is so much carbs, with very, very poor amount of proteins and fat. So almost 62% of the Indian amount of proteins and equal amount of fat as well. I mean, we are not following a proper balanced diet. And to complicate the matters further, our Asian body, Asian phenotype, which is high in the visceral fat, we have a poor glycemic or the insulin response to these carbs or food in the abdomen, because there is a delayed response of insulin secretion in our gut, which we need the Indian patient to hyperglycemia. So another important thing from and people who consume, how can I point? How can I point? Is there a pointer available? Okay. So if you, in the right bar graph, what you can see is, if there is a less amount of carbohydrate input, there will be less expulsion in the PPG. So almost a difference of 20 to 25 milligrams of real reduction in the PPG when the carbohydrate intake is lower. This was another study from UK where the Asian Indian population, Caucasians, were seen for the glycemic response of our routine meals, our sweet meal biscuits that are nutritious, which is like they call it as a digestive or a diabetic biscuits, which is so much high in sugar and the maida. So you can see Yeah, the sweet meal biscuit is all that maida in that and the sweet. So you can see the excursion as compared to the Caucasians and the green ones were the Caucasians with the same amount of meal. Asians had excursions. Then we all know that in Asian patients, the contribution of PPG is to HbA1c is more as compared to the Caucasians. Maybe our phenotype, we don't know, but it is more of the phenotype of the Asians as compared to the Western population, which contributes to this PPG being contributing more to the HbA1c. If we talk about the time in range, time in range is now very important as beyond HbA1c control, time in range, if there is no time in range controlled by that drug or the therapy, there is no point treating that patient because most of the time in range is because of, most of the time out of range is because of the postprandial peaks. If you see, there is a meal here, breakfast, lunch, dinner. The excursions will be post that. So we need something which will take care of that postprandial peaks. So to keep that sugar levels in range. Now this is a hypothesis which has been postulated when there is a postprandial surge. When we eat something, that surge of inflammatory markers is driven by hypertriglyceridemia. Hypertriglyceridemia is like a surrogate marker for insulin resistance. So when there is post-meal hypertriglyceridemia, there will be antioxidant consumption, LDL oxidation, release of factor 7, and there will be oxidative stress leading to endothelial dysfunction. Over and above that, if there is hyperglycemia, there will be a wave of this inflammatory response. So wave after wave, breakfast, lunch, dinner. If the patient is snacking in between, that too like a small wave. But ultimately, it will be a wave of inflammatory response caused post meal. So all this was confirmed in a lot of studies. We know the famous DECODE study, which has seen that 2 hours postprandial hyperglycemia is an independent risk factor for CVD. Pacific and Indian Ocean study, because this study is very important because the Pacific Indian Islanders are high in insulin resistance. So increased 2 hours PPG could double the mortality. Then there was the Framingham Open Offspring study, which showed that post-challenge hypoglycemia is an independent risk factor for CVD. Stop NIDDM, this was a study wherein acarbose was used to, impaired glucose tolerant patients to see the results. So it showed that reducing the PPG, there was a 2.5% absolute risk reduction in CVD. So this statement that postprandial hyperglycemia should be addressed and it is a risk factor for CV events was recommended by IDF in 2014. So that's how, and that's why important postprandial, taking care of the postprandial hyperglycemia is. So once we take care of the postprandial hyperglycemia, we decrease the total cholesterol, TG, LDL, increase HDL cholesterol levels. There is decrease in the blood pressure. There will be decrease in the hypercoagulability stage and the inflammatory markers. Ultimately, this reduced inflammation will be seen in our arteries. So there will be slowing of the carotid intima media thickening, and even it may be partially reversed. So specifically talking about the wonder drug which is targeted only towards postprandial hyperglycemia, that is AGIs. AGIs like acarbose, miglitol, voglibose, it delays the absorption of of the consumed carbohydrates by it competitively inhibits the alpha glucosidase in the enterocyte brush borders. The particular importance of this molecule or this class is in the Indian setting where we, as I was talking, that it is carbohydrate rich diet. So this can be used as a first line drug in early type 2 diabetes and in combination with any of the OADs and insulin. And since this action is insulin independent, it is devoid of hypoglycemia effects. Acarbose, now almost more than 2 decades of experience, we all have that. So it is approved, it was approved in 1997 for type 2 diabetes. It can also be used along with insulin for type 1 patients as an adjunct. For example, if the person is snacking in the evening, maybe a high carbohydrates, instead of giving a small dose short acting insulin, we can try a small dose or a dose of acarbose or a AGI. 2006, it was approved for IGT. In across the world, it has been approved over the years since 1990, and it has been used in more than or approved in 117 countries. So wide range of experience. So why is what is the specific mechanism of acarbose? Since acarbose it has to be taken along with the first bite of the meal. So what it does, it stays in the abdomen. It delays the absorption of carbohydrates right from the duodenum, jejunum, ileum. So the commonest side effect of flatulence. So this will cause low postprandial hyperglycemia, which will lead to lesser need of indigenous insulin. So this has a specific insulin sparing action. Then it improves the insulin sensitivity, and carbohydrate is lower in the intestine. It facilitates the GLP-1 release in the gut, improving the symbiosis of the gut. So as an insulin sparing mechanism, it reduces, it will lower the risk of hypoglycemia, obviously, and because there is low insulin in the circulation, it will also lead to reduce weight gain. So this is the specific mechanism. It is released, the GLP-1 is released from the first part of the duodenum till the last part of the ileum. So there will be decrease because of the glucose, I mean the acarbose, there will be reduction or there will be decrease in the absorption of carbohydrate right from the duodenum to the ileum. So more amount of carbohydrate is present right up to the ileum. So GLP-1 is slowly released into the circulation. So that is what this study has shown. Slow release of GLP-1 into the circulation, and thereby less of hypoglycemia. So when we talk about efficacy of acarbose, there is a 0.8% reduction in HbA1c as compared to the placebo, which will also involve a fasting blood sugar reduction and a postprandial hypoglycemia reduction. And this has a specific action on the Western diet, Western population, because maybe because of the diet itself, or maybe because of the phenotype of the Asian population. Then this was one study wherein a lot of Indian patients were involved, that is glucose VIP study, which showed that there was a reduction in the mean postprandial glucose. More than 80% patients received acarbose of 150 milligrams per day. There was a mean reduction of HbA1c of 1% and significant change in fasting PP levels from baseline. So acarbose increases reversion to normal glucose tolerance and delays the progression to diabetes. So there is 25% reduction of patients developing type 2 diabetes. This is the STOP NIDDM study. So 25% reduction of patients not developing diabetes, and there is reversion to normal glucose tolerance who are already having IGT. So more than 35% are reversed to normal glycemia. Another observation study from around 10 studies which showed that the mean reduction in weight. So though this is non-insulin dependent drug, so there will be some effect on the weight. Cargos, it has shown to reduce weight, greater body weight reduction, and seen with higher baseline body weights. So another network meta-analysis of around 11,000 patients showing acarbose was superior to DPP-4 inhibitors. So that is a contraindication to Dr. Chakravarti's talk. So it is just meta-analysis. So we can't say it is superior or just from meta-analysis, but there are a lot of studies which show that. So acarbose and DPP-4 have similar glucose lowering effect. But when there is a optimal dose of acarbose used in an overweight or an obese patient, then the benefits from acarbose will be more. Another important Indian study, the real-world glucose observation study for efficacy and safety in treatment for type 2 diabetes, showed that there was a 80.2 milligrams per DL reduction in PPG, postprandial glucose, up to 2.8% HbA1c reduction with acarbose metformin. So I'll rush through these slides. So another important thing is the MAGE, the mean excursion of blood glucose. So when combined with allogliptin, there was a reduction in the excursion of post-breakfast and post-dinner blood glucose. There is no CVO2 trial as far as AGIs are concerned, but another two real-world evidences show that there is a significant lower risk with acarbose metformin for hospitalization due to ischemic stroke, atherosclerotic events, and myocardial infarction. So this also looks promising. Another Asian study showed that acarbose users have a low incidence of MI events and all-cause deaths. So to summarize, the START study, which was the very phenomenal study showing that we as a carbohydrate eating country have a high load of postprandial blood glucose, and postprandial blood glucose is a strong predictor of CV events. Acarbose or AGIs reduces these PPGs and improve the beta cell functions with improvement in the hypoglycemic symptoms and weight gains. Acarbose is most efficacious in Asian diet versus the Western diet, and it has shown, some studies have shown that it reduces weight in Indian diabetic patients and delays the progression of diabetes. Glycemic excursions are also reduced in the patients who are on AGIs like acarbose, thereby reducing the micro and the macrovascular complications, and by benefiting the surrogate markers of CVD, that is the triglyceride, and reducing the secretion of insulin postprandial, it may be a useful drug for reducing the CVD events. Thank you.
Thank you, Dr. Bensley, for your insights on acarbose. We'll move on to the next lecture. The next lecture is on insulin, bridging the gap between physicians and patient. For this, I would like to invite Dr. Rahul Bakshi. Dr. Rahul Bakshi joined Bombay Hospital in 2019 as an honorary consultant diabetologist. He completed a post-doctoral fellowship in diabetes from CMC Vellore. Previously served as an assistant professor in medicine at Nayar Hospital, Mumbai, and also has authored textbooks and chapters published in various international journals. Over to you, sir.
Thank you, sir. Good afternoon, everyone. And I'll be speaking about this important topic, bridging the gap between patients and physicians regarding insulin. First things first, diabetes occurs when pancreas does not produce insulin, we all know, or if there is insulin resistance. So that does not mean that there is a one-size-fits-all solution, that not everybody requires insulin. We'll look into further study. Typical A1C reduction, battle of the titans. So we all know different drugs have different efficacy in terms of A1C reduction. If you look at sulfonylurea, 1.5 to 2%, SGLT2 inhibitors, 1.5%, glitazones, meglitinides, AGIs, DP4 inhibitors. But insulin, it does not have any target. You know, insulin, you get A1C of 14, 15, 16. You get the A1C down with insulin. Of course, one important thing which is not mentioned here, which I would like to mention, is the role of diet and exercise. You know, even that is equally important, which we should not forget. So the last point here is important. Primary care physicians deliver clinical care to approximately 90% of individuals with type 2 diabetes. We must not forget this. Not all patients can be seen by specialists. You know, the number of diabetes in India is so large that our primary care physicians have to handle the bulk of it. Adherence, consistency is the key. So type 2 diabetes management has become increasingly complex, and many patients can eventually require insulin therapy, and they must adhere to it. They must be consistent with the insulin to achieve appropriate results. Need to improve adherence. 67% of patients taking insulin are not at glycemic goals. So even though we start insulin, we start most of the drugs. No, the in-depth study also has shown that not a lot of patients do not achieve the HbA1c target of 7%, HbA1c goal of 7%. And more than 50% of patients taking insulin are non-adherent to the regimen. So compliance becomes the key. So a real life example we'll look at. We all know these two famous cricketers. Kapil Dev once said, Sachin Tendulkar is an example of talent plus hard work. And if you are talented but not hardworking, you might go to the Vinod Kambli way. Consistent Tendulkar. Similarly, to achieve success, one must be consistent with insulin therapy for our patients. Evolving role of primary care in type 2 diabetes, minimizing the risk for hyper and hypoglycemia, facilitating lifestyle changes, navigating multiple medication classes, managing cardiovascular risk, and addressing comorbid conditions. Non-adherence to insulin. So a survey revealed 1/3, that is 33% of patients reported being non-adherent to insulin for at least one day during the previous month. 100% of patients with multiple daily doses had at least one deviation from the insulin prescription, and 33% of patients reported missing insulin at least once per month, or on average 3.3 days per month. Reasons for non-adherence. This again is important. When we understand the reasons, only then we can address it. So patients were too busy or traveling or skipped a meal, stress and emotional related problems, embarrassing to inject in public, challenging to take it the same time every day, forgot to take too many injections per day, avoid weight gain. Doctor, I've started insulin, I've gained 3 kg weight. Regimen is too complicated. You know, patient is on basal bolus regimen, 3 injections at particular time, 1 basal at particular time. Injections are painful. Out of these two problems, embarrassment to inject in public and injections are painful, both can be injected by newer insulin pens. And all of these, challenging to take at the same time every day, not to take too many injections, avoiding weight gain, regimen is too complicated, can be addressed by using basal insulin. Insulin pens. Patients with diabetes are happier using insulin pens than the vial and syringe technique, according to the ADA's current standards of care. These pens allow more simple, accurate, convenient delivery when using a vial and syringe, thereby improving adherence. What I do with this is, I keep all the devices on my table. When I see a patient and I have to offer insulin, I will keep the insulin pen, the syringes, the vial, everything on my table, and show to the patient that this is what is available. Because when you talk about insulin, the first thing that strikes the patient mind is the old-fashioned big injection which a doctor used to inject, or the vial and the syringe. That's not the case. Of course, we do use vial and syringe in some patients where cost may be an issue, cost may be a factor, because not all patients will be able to afford our pen devices. But I think just showing them the pen device, that how simple it looks, showing them the small needle, that can also, have a good effect on the patient, and they'll be more receptive to our advice and willing to take insulin. This is what insulin and its parts are. Basal insulin, of course, we know we can start and it should not be delayed. Many times, the timing of starting insulin is also a key factor in achieving glucose control, achieving good glycemic control. And many times I feel starting on the right time, we may be able to stop insulin, when glycemic control is achieved, and delaying the insulin for some reason or the other, patient inertia, physician's inertia, many times then, patient comes back with raised creatinine or retinopathy or some cardiac event. That is when it becomes difficult to stop insulin. So another factor which I emphasize to our patients is that if I started on the right time, A1C is high, we are working on diet, exercise, we are giving some good oral agents also. Starting on the right time, we have a good chance of stopping it, not in all patients, but a good percentage of patients. So that also makes the patient more receptive to start initiate insulin. Basal bolus concept. So we have to offer different regimens which are available. One could be just basal insulin, other is basal plus bolus insulin, premix insulin, co-formulation, explaining the patient again, what all insulins are available, what is suitable for a patient at that point of time, whether he requires only basal when he's on sulfonylurea and some other drugs, or the patient requires mainly we are talking about type 2 diabetes, or you want to go for a premix or co-formulation, not give them 3 to 4 times a day injection, and so on. So bolus insulin gets you where you want to be. Basal insulin keeps it there. Everyone's basal needs are unique, and sleep and growth factors are a major influence. And most important point, individualization and fine-tuning is a must. No two people are alike. If I give a patient a premix insulin, it works, doesn't mean all my patients will do well on premix. Talking to the patients regarding their lifestyle, regarding the job, doing night duty, night shift, doing alternate night shifts and day shifts, what their diet and appetite is like, whether the patient is, which part of the country is the patient is from, are they eating heavy dinner or heavy lunch, or what kind of meal they are having. Many patients will have only breakfast and only dinner and skip lunch and so on. So what kind of diet they are on, how the renal function is, how old the patient is, how prone they are to hyperglycemia, all these factors will decide which type of insulin we have to use. Hesitation to initiate an advanced insulin. So, as I mentioned, patient inertia, clinical inertia, and inertia at our end, at doctor's end. So, from patient's perspective, impact on social life, perceived lack of benefits, lack of time, forgetting doses. From doctor's perspective, time constraints, titration too complex for the patient, and lack of supporting resources. And clinical inertia, hypoglycemia. This is one most important factor which I feel, which can deter patients as well as us doctors from usage of insulin. So we have to be aware. It's simple. Basically, just spend some time with patients, just 3 to 4 minutes. Tell them what hypoglycemia is. Tell them the symptoms. Tell them how to treat it. And tell them to expect it. When I start insulin, or even sulfonylureas for that matter, I'll tell them that hypoglycemia may happen. These are the symptoms. And if that happens, I want something in your pocket or in your bag which can treat it. And if you're at home, monitor your sugars or check it with a glucometer. Just telling them this, it makes them very, very satisfied from that perspective. And if at all it happens, they will not stop the drug, but treat it and then report to you. Potential solutions, diabetes education, very, very important. Many of us don't have enough time to give to the patients. So a diabetes educator can become a very important part of, our team, because we need to talk to the patients. We need to explain to them regarding different types of insulin, types of injections, needles, site rotation, and other things. Addressing misconceptions. Doctor, insulin will damage my kidney. This is what I've heard. Doctor, if I start insulin, I cannot stop it lifelong. I have to continue lifelong. These are all misconceptions. These are all myths. So addressing them can, make the patient more receptive and make our job more easier in achieving the glucose target. Less burdensome regimens of combination therapy, nurse or pharmacist-led management, insulin pens, dose titration, written instructions. Written instructions again are very important. Documentation is important from medical legal point of view as well. So these are some of the potential solutions. Customized care, written instructions, using insulin pens, structured glucose testing, and recognizing and treating hypoglycemia. Most important, as I mentioned, hypoglycemia can be a very, very important deterrent. A patient who will have hypoglycemia, he may stop insulin. He will not come back to you again. I've seen doctors who say, if I propose insulin, patient does not come back to me. So it's important to explain to them so that they understand we are doing the right thing from the patient perspective, and they become more adherent to the treatment. Overcoming patient barriers to insulin therapy. Weight gain. So patients believe it is a major side effect of insulin. Of course it is, but the newer analogs, the newer insulins cause much lesser weight gain compared to the older insulins available. So we have to explain this, we have to tell them to expect it. But again, sometimes preempting hypoglycemia, patients start eating proactively. They eat more than what usually they do. That can lead to weight gain. Appropriate diet and exercise is very, very important. We have to emphasize that. Failing oral therapy. Many patients believe that we are starting insulin, which means the oral treatment has failed. Of course, secondary sulfonylurea failure is the term, is something which happens after 5 to 10 years of usage of insulin, but it does not mean that tablets are not going to work. In fact, many times we see when you give insulin for some period of time, when there is glucotoxicity, after that, the oral agents start working much better. And that is when, as I mentioned, in some patients, we may be even able to stop insulin in such patients. Needle phobia. So fear associated with early experience. because we've seen patients, they've seen relatives or somebody in the family injecting with needles. So of course, as I mentioned, I keep needles, pens, everything on my table, show to them how small and how minute they become, the newer needles, and that usually takes care of their anxiety and apprehensions. The regimens can be complex and inconvenient. Patients perceive insulin therapy is complicated and inconvenient. So explaining to them new and easy to use injection symptoms are discreet and convenient. Once a day basal or twice a day pre-mixed or co-formulations can improve the adherence regardless of the lifestyle. Perception that insulin is not effective. Sometimes they've been told that tablets are effective, insulin can harm, insulin is not effective. Again, there's not much truth in that. And once you tell them and explain to them, it's up to them to believe and make a decision. Sense of personal failure. This again is a very important point. So we have to explain to the patient that insulin is a natural hormone. It's something which is produced in our body, and it does not mean that you have failed or your treatment has failed. It's required at this point of time, and we should give time for the patient to get the optimal glucose control and take it from there. Injection sites should be shown and explained. That's one step ahead, because just writing down insulin twice a day, writing down the dose 10 in the morning and 8 in the evening does not finish the job. We have to explain them the sites. We have to explain them the importance of changing the site, what we call a site rotation. Many patients can have lipohypertrophy. We examine the sites when the patient comes, because many times they're injecting at one point only or at 2 points around the umbilicus. Yes, I'm rotating, but morning here and evening here. Even that doesn't work. Lipohypertrophy is important. So site rotation, different diagrams are available which you can show to the patient. 1, 2, 3, 4 over the abdomen. Different sites. Many patients don't know they can cover whole of the abdominal wall. And these small diagrams so make these images stay in patient's mind, and they take it appropriately in that case. Needle change is another problem we come across very often. Many patients do not change the needle. You talk them when they changeable, such that pura pen khatam ho jata tab change karte hain. This is very common. So talk to them about needle change. I have this diagram on my iPad when I showed to my patient that this is a new needle, how it looks like, and this is a real needle after 2 to 3 times. That because to the naked eye it appears very clear, very normal, like the new needle is appearing. But in microscopic examination, it looks like this. So these needles, when the patient just presses 1 or 2 drops of insulin come out, and then we don't get the appropriate result. And what then we do? We just keep on increasing the insulin doses. So whenever I see 30 units, 40 units, 50 units of insulin, usually I go back and check these things. The site rotation, lipohypertrophy, are they changing the needle enough or not, apart from diet and exercise, and that's where the answer lies. Answer doesn't usually lie in increasing the insulin doses. Shared decision making. So of course, take the patient into confidence. Explain to them about insulin when you week first also, even though they may not be starting insulin at that point of time. Explaining them is again important, so that when they come back again and if you don't achieve the target, they are more open to it. Okay, so you had mentioned about insulin, how about it? Can we start now or not? So team members, patient education and training is important as well. Raising awareness with novel types of education. Patient barriers, of course, we discussed hypoglycemia, weight gain, needles. All of these challenges can be addressed by insulin pen or basal insulins. So global barriers to initiation of insulin therapy include poor healthcare infrastructure, insufficient patient education, misconceptions, and socio-economic factors, and access to and cost of medication. Cost is very important. I should not start an expensive insulin with a patient who cannot afford it for a long time. Explain them the cost, tell them the monthly cost per pen or per vial, and let them take a decision. It's not that the other insulins don't work. So that's again important, because patients will start, but they may not continue. And that is specific to our region includes skepticism about Western medication, greater influence of therapy traditions, peers, and unverified social media reports. So long-term solution, enhancing education, integrating care systems, improving insulin access, and barriers to patient acceptance and personalized strategies are important. Personalized care is very important. Thank you.
Thank you, Rahul, for the session. So our next session was supposed to be taken by Dr. Ritul Goklani. As he is not available, who better to talk on CGM than Dr. Amit Gupta. He is from Noida. He is a friend and speaker at various national conferences, fellow of various associations, including ACP, RSST, and he has been actively involved in modern diabetes technologies. So over to you, Dr. Amit.
Thank you. Thank you for the nice introduction. I'm really sorry that Ritul is not here to present this, but I would take this opportunity to present it on his behalf. I have made a slide changes because I received the slide in the last minute, and I am presenting my slides set, not the Ritul's slide set. So just want to make it clear to everyone.
I'm just waiting for the slides to come. Okay. Can we have the slides, please? Yes. So, to start with, we need to understand what are the current challenges in diabetes care. And we all know the major challenge in diabetes is to achieve a good glycemic control. There is always a challenge that you want to, whenever we are having a stricter control, we will always fluctuate between seesaw between hypoglycemia and hyperglycemia. This is something which we want to achieve in a good way in our patients with minimum glycemic variability. So we want the swing to be more balanced, not swinging up and down. So we don't want glucose levels to go up and down. We want them to be more and more stable. So what is the basic difference between a glucometer and a CGM? So for all practical purposes, you can believe that a CGM is a video your glucose recording, while a glucometer is a snapshot. But sometimes the snapshot can be very, very beautiful when Dr. Amit Rajput is sitting here. He is a very well-known photographer, and he will also take photograph of some of us in this meeting also. So CGM is more like a video, and we know that a video gives you a continuous recording. And this is and just slide will just show that consider this patient who has monitored his blood glucose level with a glucometer. And, you can see the glucose readings landing in at different times, the wake-up, lunch, dinner, and that time. But once you replace it with a CGM graph, you will find that how these readings are happening. You will find that the patient is experiencing hypoglycemia as well as extreme hyperglycemia during the same day. So this is something which cannot be picked up by a SMBG. It can only be picked up by a glucometer. Before we move on to the CGM, it is again important to know that humans are not created equal, all humans are not created same. Similarly, all HbA1c are not created same. So some of us in this hall has come from Delhi, some of us has come from Mumbai, and the other parts of the country, but net result is that we are here. So we know that we are in Mumbai at WCPD, but how we have reached there, nobody knows. So this is the CGM can actually tell you that what does, even if an HbA1c of 7.5 can be having a totally different trajectory in two different patients. So this is something which we need to understand. This is why the concept of glycemic variability becomes more and more important. It is not just HbA1c, we need to look into the glycemic variability also. If we just go into the terminology, I think this is Mumbai, and many people, I believe Mumbai is one of the cities where the use of CGM is maximum in India. Even I believe it is more than Delhi. So still, I would like just to tell you that there are two types of CGM which you can say. One is the professional CGM and one is the personal CGM. There is the RT CGM or the real-time CGM, and there is the intermittently scanned CGM or the flash technology. So these are the different CGM devices which are available globally. And the two most common devices which we use in India now is one is the Libre, that is the Libre device, and it is a convenient and discreet and easy to use device. Another important device which has just come to India over the last 2-3 months is the ICANN CGM, which is the real-time CGM. And I will tell you what is the difference between the intermittently scanned CGM and the real-time CGM. For all purposes, there are different glycemic targets and different timing range for different populations. They may vary for people with type 1 diabetes, type 2 diabetes, in pregnancy, and pregnancy with type 1 diabetes and with gestational diabetes. But for all purposes, we may believe that most of the time we want to have a good timing range that is more than 70%, except in older individuals, or those high-risk individuals, where you may want to have a less tight timing range, and even range of 50% may be acceptable, but that with very less incidences of hyperglycemia. So, area defines CGM into two categories. One is the real time, one is the intermittently scanned CGM. So, one of the most basic difference is that real time CGM doesn't require any scanning. So, data comes automatically to your device. Whether it is a smartwatch, whether it is a smartphone, your computer, laptop, the data comes automatically, and no scanning is required to capture the. An intermittently scanned CGM is a device where you need to scan the sensor either with a mobile application or either with a reader, only then you will be able to get the data. So this is the basic difference between a real-time CGM and the intermittently scanned CGM. So where can we use CGM? So earlier, when the CGM was new, there was always a debate that we should get the benefit of CGM, and unanimously globally it was accepted that CGM is for people with type 1 diabetes, and it was not very well accepted for people with type 2 diabetes globally. Now, in 2024, there is not a single condition where CGM cannot be used. You can use CGM in type 1 diabetes, you can use CGM in type 2 diabetes, GDM, pregnancy. People are using even for the reversal of diabetes. There are many people who are deploying CGM just to understand their glycemic profile and using it in pre-diabetes for the prevention of diabetes. The data may be robust in some of the cases, data may not be there at all in some of the cases, but this is how the use of CGM is happening globally. So some of the indication which I would like to give you is that you can use CGM in a people, in a person who is having hypoglycemia unawareness. For example, a person may come to you with type 1 or type 2 diabetes, multiple daily insulin injections, may be experiencing repeated hypoglycemia. Just because of repeated hypoglycemia, patient may be having this condition called hypoglycemia unawareness. So, person is not able to detect the symptoms of hypoglycemia, develop the symptoms of hypoglycemia, glucose levels are going down. This can be very dangerous for that person because person may suddenly skip into neuroglycopenic symptoms, and this can lead to even deterioration of the health and coma as well. So in this condition, it can be very useful to detect hypoglycemia unawareness. Sometimes we get a patient where you find that HbA1c is not correlating with the SMBG data. SMBG is showing that there are very good readings in the glucose chart, but this HbA1c is either too good or too bad. So either way, so how to identify that this what is the glycemic control in this patient? So CGM can be handy here. Nowadays, a lot of young people, especially those who are recently being diagnosed with diabetes, they are very aware about this technology. And they may simply come and ask you that they want to use this technology to understand their glycemic pattern, modify their lifestyle, and change their lifestyle as well as the behavior. So this becomes another indication. Sometimes a person may not have, we have total aversion to finger stick. They may not at all want to test their glucose level by pricking themselves. So CGM can be a very good option at this point of time. And in some people, there can be very rapid rise and fall of glucose levels. So even these patients, they will benefit from the use of CGM. So I will not go into the details of these, but these are the CGM systems which are cleared by the US FDA. So you have Libre for 14 days, you have a Dexcom sensor, you have Guardian Connect sensor 3, you have an Eversense sensor. Only one sensor, that is the Eversense, is an implantable sensor. So this is an implantable sensor which can be implanted subcutaneously, and this can lead to, and you can monitor glucose level up to a period of 6 months. Now the latest ever sensors which are being tried, they can actually capture the data even for a year. So I will skip these slides again. And just to make you understand that how does an AGP report look like? So those who have not used CGM before, they want to use CGM, they need to understand certain terms like time in range, time above range, and time below range. And also what is the AGP? AGP is the ambulatory glucose profile, and how this ambulatory glucose profile is interpreted and what are the daily views. So if you look at the metrics and the targets, you will find that most of the time we want our patients to be in a particular range, and this is called time in range. This range is defined as a target range of 70 to 180 milligram per deciliter. If the glucose levels are below 70, you can say it is time, the amount of time a person spends below 70 milligram, that is time below range. And the amount of time a person spends above 180 milligram, you can say time above range. You can adjust these time above range and time below range and time in range based on the patient's own personal profile. If you look at the middle graph, this is the AGP, and this is the concentrated plot of all the 14 days of the reading. So all the 14 days of the reading, if they are plotted in one single graph, so this is the graph which you get. And the blue line, the dark blue line you get in the center is the median. So this is where the most of the 50% of the readings of the patient will be falling, and the light blue zone is the outer 25%, and the inner blue zone is the glucose targets within the 75% of the median. And here you can see the individual of the daily graphs. These daily graphs can be obtained by real-time CGM as well as these can be obtained via intermediary scan CGM also. So if you look, just for an example, if you look at this graph, you will find that this patient is having periods of hypoglycemia, especially during from the midnight to the early morning hours. And then this patient is having glucose excursions during the lunchtime, dinner time, and almost everywhere. So we don't want such kind of graph. What kind of graph do we want? We want a graph which is more flat. So the target range, so our goal is that more green and less red. So we want to increase the green component on a AGP chart, and we want to decrease the red component. And one important takeaway from this slide is that whenever you are seeing a AGP graph, if you find that the red is more, red means hypoglycemia. So whatever therapeutic intervention you are going to make, it should focus on reducing the hypoglycemia risk. So first, rather than going, for example, in this patient, we don't want to go jump and treat the hyperglycemia first. We want to minimize the hypoglycemia first. So your treatment strategy should be designed in a way that you are minimizing the risk of hypoglycemia. And FNIR is the term which is flat and narrow in range. So you can see the graph like this one, where you will find the almost a straight line. Most of the part is in the green zone. So this is how you define a flat and narrow in range CGM graph. And daily views are something they are also very helpful, because this allows you to understand the lifestyle of the patient, the food intake of the patient, the impact of the food, as well as the day-to-day adjustment which patient may be doing or you may require to do, especially if the patient is on insulin. This is very, very important slide, and this is a very frequently asked question that many people, they don't trust CGM. And the reason for not trusting the CGM, this is true for the healthcare providers as well as for the patient as well. And the reason for not trusting is that they believe the CGM readings that don't match with the SMBG data or the glucose reading. So this slide tells you in a very diagrammatic way that what happens. So when the glucose levels are almost stable, for example, in the range they are within a very narrow range, for example, 120 to 130. So whenever you are doing a finger stick and CGM analysis, at this point of time, you are very likely to find a very good relation between the CGM readings as well as the SMBG readings. But what happens when the glucose level is rising very fast in the blood? So this will take some time to rise in the tissue. So this is just like a truck where the front part is already over the hill and the back part is still lagging behind. So it will take some time before the tissue glucose level approaches that level. So when a patient is experiencing a sudden surge in the glucose levels, you will find a large difference between the tissue glucose level as well as the blood glucose level. Similarly, when there is a rapid drop in the glucose level, you may still experience this wide gap between the tissue glucose and the SMBG data, because the glucose levels will fall rapidly in the blood, but they will not fall so rapidly in the tissue. So this is how it is important to understand and see this change that what is happening, and to make the patient understand, we need to understand this concept also. So what are the advantages and disadvantages of the CGM? So advantages of the CGM is that it provides comprehensive picture of the glucose variability. Readings are never missed. It provides matrices to individualize treatment. It is simple to use. No daily finger stick required with pre-calibration. Disadvantages is that it is relatively expensive, more complex and requires training, high level of compliance and interaction needed, may require multiple finger sticks to calibrate with SMBG, sensor always on the body, so sometimes this can be a potential for contact dermatitis, and sensor requires replacement. So these are the some of the advantages and disadvantages of the CGM. Though I have only 1 minute left here, so still I would like to show you some of the cases. Only one case I would like to show. This is a case of a doctor from our own fraternity. Just like all of us, ignorant of his own health, always busy in the OPD practice and the clinics. So no time to monitor. HbA1c of 10.5%, already had CAD, pedal edema, renal dysfunction with the eGFR of 50. I think there are multiple issues, and already patient is on premix insulin. So with the glimepiride, metformin, vildagliptin, telmisartan, amlodipine. So we will not go into the details of the treatment, but if you look at in this patient, the readings have been taken by a sensor. You will find that there are large variations, and the only timing range was only 68%, but very large, wide fluctuations. But if you see the other slides, you will find that over a period of time, when you adjust the treatment adjustment maybe you would like to shift the patient on modern insulins, you would like to add a GLP-1 agonist also. You would like to modify the diet, motivate the patient for the exercise and the other things. So you are able to get a flat and narrowing range kind of graph as well. I will not, because of the lack of the time, I will not go into the details. Maybe I think we will have some workshop also on the CGM. Conclude by saying that CGM can help us in improving glycemic control. It can help in improving the quality of life. And it is also is a concept of collaborative care. So the patient can share the data in real time with their health care providers. And you can look at the data and provide the feedback whenever it is required. And this is all I wanted to say. Thank you very much.
Thank you, Dr. Amit, for this excellent presentation of CGMS. We'll have a group photo with all the speakers. Yeah.
So if the patient is of congestive cardiac failure and he happens to have interstitial edema, then your CGMS will not work. See, if you are implanting it even on my abdomen or on my hand, and it happens to be edematous, then again your CGMS will go.
Yes. For all practical purposes, we need to understand that right now there are some trials which are conducted in hospitalized patients also. Those patients who are admitted in ICU, there are trials which are talking about use of CGM even in ICU setting. So sometimes the glucose can be variable. The edema is not really highlighted as one of the challenge or one of the main reasons for any getting faulty readings of the CGM. So this is not mentioned as a cause of erroneous readings of the CGM because it is still placed in the subcutaneous tissue. And if certainly if a patient is having high dose of vitamin C, patient is also having a lot of edema as we're talking about a full-blown congestive heart failure, CGM readings can sometimes be erroneous. But we are talking about patients who are stable, who are not admitted to a hospital, who are not having any such clinical complications.
So the interval, the time gap is between 30 to 40 or 20 to 30 milligram per cc.
My take on this is that we need not to look at all this gap. When you put the patient on CGM, the idea of putting the patient on CGM is that to to avoid the finger stick testing again and again. So the only reason you do the finger stick testing is that your CGM is telling either too low readings, either your CGM is showing too high readings, and whenever there is a doubt that you have displaced your sensor may not be giving the right readings. So these may be some of the reasons that you are doing the finger stick injury. Otherwise, sensor like Libre, ICANN, they are factory calibrated. They don't require calibration with the finger stick. So second thing is that some sensors like the Dexcom, for example, the electronic one, it requires calibration. Even the implantable level sensor, it requires calibration twice a day. So in those sensors, we are already doing the calibration. But these factory calibrated sensors, you don't need to compare them with the glucose SMBG readings at all, unless and until there is a compelling indication to do that.
Thank you so much. So you can take the mic.
If you're not exercising or you're not taking a meal, not taking insulin or any drugs, in a steady level, the time lag is 5 minutes between the tissue glucose and the blood glucose.
5 minutes.
5 minutes
5
on an average.
Okay.
But when the sugars are changing rapidly up or down, the time lag can go up to 15-20 minutes, sometimes half an hour, 40 minutes.
Okay.
Depends on
I understand.
Yeah, it is just same bus. If you are from Mumbai, you know, अंधेरी वेस्ट से अगर बस निकला है 10 बजे तो अंधेरी ईस्ट में 11 बजे पहुंचेगा. It is the same concept.
I understand.
Thank you.
Thank you.
Yeah.
Question. Thank you so much for your lovely lecture. For us coming practitioners, it's very informative. Sir, we come across these patients, Libre Pro versus Libre Pro 2, etc. Now there are these AGVs which show the data of the patients as well on their Bluetooth app. So personally, what do you prefer? It should be single blind?
No, I think it is very, very important for the patient to see the data, because this is where the concept of the behavioral intervention or the lifestyle modification comes in. Because this can be a tool for motivation for the patient also. Especially if patient is not able to see the data, I think this is my personal experience since after the launch of these real-time CGM and the intermediary scan CGM with the availability of the dashboard, the data, if the patient is able to see, there is nothing like that.
So, but then they revert back to their old lifestyle and habits once that data is.
See, this is a human nature, and that is why the prevention people, they are all talking about that, how to sustain the prevention, how to sustain the control. So every time a patient comes to you, it is not just for the HbA1c or the fasting BP level. We need to start from the scratch, educating again regarding the diet, lifestyle, exercise. So this circle and the cycle goes on and on for the life.
We will end the session due to the lack of time. I'd just like to call upon all the speakers on the stage for a group photo, and just we'll move on to the next session later on.
Thank you.
So for the next session, I would like to call upon stage the chairperson, Dr. Yash Patel, and I think Dr. Anirudh Makhesha and Aparna Mithil on the stage to chair the next session.
Good afternoon, everyone. Please. It's indeed pleasure to be here on DRS and WCPD conference and to make the sessions in timeline in integrity. Let's take them to the communication symposium. And we have the first speaker, Dr. Sefali Karkhanis. Yeah.
Dr. Shefali ma'am, as we all know, is a very experienced practitioner. Hello. Is a very experienced practitioner, practicing mainly in Thane. She's a consultant diabetologist, founder, co-director of Karkhane Super Speciality Hospital, Thane. She has a gold medal in fellowship in diabetes. She is also certified in treatment of obesity and has various publications in RSSBI drug series as well. Members of various organizations like CID, AD, RSSBI, etc., and speaker and faculty in various national conferences. She's also conducted numerous CMEs for doctors and awareness programs and camps for public. Now, please welcome you to this wonderful. We all are eager to hear you, ma'am.
The topic is language matters in diabetes. Yes.
So, namaskar. In the Arapal Kaga, Dr. Manoj and Dr. Purvi ke and Mandra Nandri, in the Manatai, Abhidana Nadambatake, DRS of the team ke another Nalvaitika. Now, so the people who understand Tamil must have instantly connected with me. But the people who do not understand Tamil probably disengaged after I said Dr. Manoj's name. So that is why language matters in diabetes, and that is why it is so very important that we know what we are talking about. And I'm very thankful to Dr. Manoj and Purvi for giving me such a wonderful talk, and I'm wishing them all the best for the wonderful conference. So language matters in everyday's life, and it matters more so in diabetes, because language is very humanizing. It is one thing in which we can communicate very easily, but it differs in the world. There are so many dialects, so many types of languages, so many places, depending upon the place, depending upon the society. So it just goes on varying with every probably 10 kilometers, 15 kilometers, as we all know. In the words of Ursula Le Guin, words are events. They do things, they change things, they transform both the speaker and the hearer. They feed the energy back and forth and amplify it. There are sides to communication of diabetes care. The first and foremost, what do you communicate? Imagine a newly diagnosed diabetes patient is coming to you and the doctor tells you, okay, it's a case of hyperglycemia of islet cell dysfunction with touch of hepatic resistance and following excessive adipose tissue deposition. Now here's your prescription and go. So this medical jargon is a waste as far as the patient is concerned, because he will not understand what you're trying to communicate. Hence, what you're trying to communicate has to be in the language of the patient. Second, how do you communicate? The tone of the voice, the inflection of the voice, the volume of the voice, all makes an impact. And third, and the most important, which probably all us physicians forget, is did you manage to communicate it? So has the message gone across? So imagine a nice Shakespearean play in Nita Ambani Cultural Center, and it is attended by a village simpleton. And what is he going to understand? He doesn't even understand normal English. शेक्सपियर इंग्लिश देख के तो बस एक ही बात कहेगा, भाई तुम कहना क्या चाहते हो? This is what happens many a times in our profession as well. Language is power, and with great power comes great responsibility. Language is a principal vehicle for sharing knowledge and understanding. Words are immediately shaped into meanings. Now, these meanings are different for different people. I may say the same words, but it will form a different meaning for each one of you. And these meanings are what affect the person to change himself or herself and to view the doctor as well. Those in the world of Google Babas are very confident with their knowledge about diabetes. I'm sure about that. All of us have many patients like this. But doctors often fail to acknowledge this, that they have some amount of information. They often fail to address this information. And that is why the patient immediately disengages from the healthcare profession. So now we need to step beyond doctor knows best, because it's no longer about treating the numbers and targets, but it's about treating the person in front of us. Non-verbal contact is also very important. Eye contact, a smile, a frown, a tap on the back, a handshake, all of this has an impact on the patient every time the patient comes into the clinic. In the world where we are busy filling all data in the EMRs on our computers, we hardly have time to actually look at the patient's face. But the moment you turn towards the patient feels like you are listening to him. And that is what makes all of a difference. Small changes in the way that we talk or act make about a big implication in the health of an individual with diabetes. Small changes will eventually land up with huge results. Because language lies at the core of attitude change, social perception, personal identity, and stereotyping. And the words have the power to elevate or destroy, especially when you're dealing with patients in diabetes. How does the power of language come into picture? So for the very first time, there is an engagement between the HCP and the patient. The patient then conceptualizes what his disorder is all about, what his condition is all about, and how he has to manage it. The HCP and the patient can then form a management plan, which is, sort of agreeable to both himself as well as the doctor. And then the treatment outcomes will fare upon depending upon how the first 3 steps have been done. If the treatment outcomes are good, the psychological well-being of the patient also improves. And this is one of the ways that we can deal with diabetic distress, which is so commonly found in our patients. That is why there's a global movement in language awareness, where all across the globe, people are talking about what to say, what words to say, how to put forth your communication so that you use words which are not stigmatizing, which are promoting respect, which are promoting self-motivation, and which will have an impact, a positive impact on the behavior. Experts all across the globe are agreeing with this. The first slide about the expert advice I'm putting it is the statement made in ADA 2017 in the Standards of Medical Care in Diabetes. The statement says, a patient-centered communication style that uses active listening, elicits patient preferences and beliefs, and assesses the literacy, numeracy, and the potential barriers to care in order to optimize the healthcare outcomes as well as health-related quality of life. This statement is beautiful. It's one of my favorite statements because every word here has a message. Every word imparts an impact. First, foremost, patient-centered. Second, communication. Third, style in which that communication is done. Fourth, active listening, which most of us do not follow. Elicit patient preferences and beliefs. This, I think, is one of the most important factors which is missing in Indian public because we just tell them that you have to do this. Whether it is feasible for them to do it or not is not never asked, which is, I think, a shortcoming on our behalf. Assessing the literacy, where the patient understands that he has to take, at what time he has to take, whether we need to simplify the prescription. The numeracy and the potential barriers, which include the social barriers, the economic barriers, etc. The list just goes on. But if we can spare 5 minutes to talk about the patient, I think we can expect a lot better outcomes in our patient's life. Again, Canada Diabetes, IDF, all of these have endorsed the use of correct words so that the people who have diabetes will not feel stigmatized. There are 5 evidence-based informed recommendations. Use language which is neutral, non-judgmental, which fosters collaboration between the HCP and the patient. It is patient-centered, free from stigma, and it's strength-based, respectful, inclusive, and hopeful. Instead of saying what will happen, we can substitute it with saying what we can avoid. So many times I have heard junior doctors saying that if you don't control your sugars, you are going to go blind. You are going to go on dialysis. That's it. Your foot is going to get amputated. But instead of this, if you say that if you manage your sugars well, we can actually avoid having dire consequences in your life due to diabetes. We can keep your organs safe, and that is what we want to do. This will have a positive impact on the patient, and that is what we are attempting to do. So the various organizations have recommended avoiding the use of words like diabetes or diabetic or disease or control or failed. Instead, go for better words. Like, for example, people living with diabetes. Or instead of saying disease, you can probably say condition. Instead of saying well controlled, not controlled, say management or monitoring. Or whether instead of saying you cannot have this, we can always say it's best to avoid. See whatever you can do. It is better that you avoid it. If you just say this much, it will make a different impact. Languages actually is a challenge, and more so in vulnerable populations, because if as I started my talk, if the language barrier is there, the patient does not understand 90% of the things that are going on. And the mistrust amongst the doctor and the patient increases. So this is a beautiful study which shows that this study was a cross-sectional study which was done in Latino patients, rural Latino patients. So they found that patients who had a Spanish-speaking doctor fared much better in their outcomes as compared to patients who had non-Spanish-speaking doctors. So this suggests the importance of language per se when you're treating the patient. Another study, which is the INTRO-DIAD study, this is a global study where they recruited about 3,628 patients, and they had a survey where they subjected the patients to a self-report. And this self-report was whatever they could remember as to what conversation they had at the time of diagnosis with their health practitioner. So it proved that higher PPCQ, that is patient perceived communication quality, was much better when the HCP was using encouraging words and collaborative words. And it was much lower when they were using discouraging words. Similarly, the patients who had a higher PPCQ actually remembered more of what their healthcare professional had told them at the start rather than the people who had lesser PPCQ. Similarly, this is another study which was conducted in Singapore. This included 2,289 English-speaking patients, vis-a-vis 885 Tamil-speaking Indians in Singapore. And what they found was the prevalence of type 2 diabetes was much higher in the Tamil-speaking Indian group as compared to the English people. This probably was because all the health policies and the health interventions, all the information disseminated was in a English language, not in the Tamil language. So the patients who were only speaking Tamil did not really understand what is going on. And that is why the prevalence of diabetes as well as its complications was much higher in them. This particular study, the objective, this was again a beautiful study, which had the objective of understanding how adults with diabetes experience the words which are used in diabetes care. So this was a qualitative study. It was guided by the critical theory, and there was the responses were gathered from 68 focus group members. And what they identified were several themes. Now, this theme, the first and foremost of these themes was body language and tone of the doctor. Second, oversimplification or directive by the doctor. Without understanding what the patient is going through or is facing back in his life, he was just told that you have to do this. For example, a person, I live in Thane. So a person who's traveling every day from Thane to Goregaon, you cannot expect me to tell you that, okay, spend 2 hours in the morning in the gym, because it's not going to be possible. So you have to understand the patient's perspective as well. A lot of misunderstanding and misinformation, thanks to the social media and all various so-called experts who give all nuskas. Fear and anxiety of both developing diabetes and developing complications of diabetes. Stigmas and labels, which is very common. I tell a lot of my patients that you should not fear saying that you're a diabetic, you're a patient with diabetes, because you need to monitor your sugars that well. You need to have a specific amount of diet. And you can probably set a trend saying that if it's my birthday, I'm going to give a party only of savory. There'll be no cake and no chocolates. So it should not be a stigma anymore. And last but not the least is judgment. Judgment by the society and by the doctor as well, because they feel that if the sugars are not under control, it will be my fault and the doctor will shout at me. So all of these things must be taken into consideration. Empowerment through language has to be a strength-based communication. There has to be a resilience. There has to be a supportive encouragement which should be given. And through this, there will be a lot of behavioral changes with the patient, which will actually influence the outcomes well. Similarly, cultural sensitivity is very important. Tomorrow, people are starting pollution. If I tell them nothing doing, you have to eat carbs, you have to eat this proteins, you have to eat non-veg, it's not going to be possible. So you have to actually look into the people's cultural belief as well as the sensitivity. Linguistic accessibility we've already spoken about, and community engagement is also just as important. There needs to be an empathetic language. There needs to be an individualized approach. There needs to be a shared decision making so that the treatment plan and the management can follow through. And this is what will develop the trust. Walk the talk, my dear colleagues. Talk about the risk, not about the inevitability of developing the disease and its complications. Talk about the possibility of delaying diabetes and its complications with good lifestyle interventions. Talk about scientific advances which allow the people to live longer, and not just longer, but live healthier, even if they do develop diabetes. Language cannot be separated from thought and experience. It's an integral part of all of us. Every word that is spoken creates a meaning, and from these messages that we hear, we create these images, and these images are what will shape our life. Words which encourage and induce a positive attitude will produce. Non-verbal communication is also important. Speaking in patient's own language imparts better understanding and compliance. What is spoken, how it is spoken, and the vernacular in which it is spoken makes a difference. The concept of language matters is no longer an adjunct to optimal diabetes service delivery, but very much at the core of good empathetic care. I end my talk with this. This is a small muscular organ. It is definitely a problem, but it can be a solution as well. So, Zaban Sambhal ke. Thank you.
Wonderful. So thank you for the wonderful talk, Dr. Shefali. We can take it to the next session. We have Dr. Santosh Malpani, and he is talking about pre-module communication.
Thank you.
For the dynamics of OHS.
Thank you very much.
Dr. Santosh.
Can I have my slides, please? डॉक्टर साहब क्या गोली दी हमने आपको, हमने कि भाई 100 पाव 1000 पाव की गोली दी है, और
वो गोली पानी पेट में पचती नहीं, वैसी बाहर गिर जाती। कभी कभी कोई गोली आप देते हैं पेशेंट को तो यूरिन में खुजली होती है, उसको पहले हम लोग बोलते नहीं। दैट टाइम it happens that due to miscommunication the patient stops the tablets medications, and this happens with more and more of the oral anti-diabetic drugs, particularly newer anti-diabetic drugs which we are using, and that can lead to non-adherence of the medication, and that can lead to the increase in the glycemia. And I thank Dr. Chawla's for organizing this very good event, which is based on prevention of the complications of diabetes. And for prevention of complications of diabetes, it is very essential that the patient should adhere with the medications. Unless and until he adheres with the medication, it is very difficult to achieve the glycemic control. So adherence is a problem when there is miscommunication. You don't tell the patients what side effects or what adverse effects the drug is going to create. Not my slides.
Can
These are any
One
slide.
slide.
So adverse effects and side effects are two different things. But the insert in the box which comes with the medication says that there are two types of effects. One is the severe adverse event and the other is the
Just a minute, sir. Dr. Santosh. Excuse me, the jockey. Can you change the slides to the Dr. Santosh Malpani's slides?
Yes, finally we have it.
Yeah,
I think,
please.
thank you so much.
Can you share to LED?
share the screen, please.
Yep.
Thank you.
So adherence to medication regime is crucial for achieving glycemic control. Yet patients' concern over the side effects and the adverse events remains one of the largest barriers to the patients taking medication appropriately. Which drug is to be taken before food, after food, with food? All these are the jargons which are to be explained to the patient. An effective communication style, as told by Shefali, combined with clear explanation of medication benefit, side effect, and potential adverse event can improve adherence. Term side effect and adverse events are often mistakenly used interchangeably, and that should be avoided as far as the side effects are concerned. See, every medication has got a potential side effect, which may be common, unwanted secondary effect of the medication. For example, a metformin tablet will be bitter in the taste. Suppose it is kept for a longer time in the mouth. Side effects are more common and usually are very mild. They can be avoided by educating the patient. Adverse events are unintended consequences that occur from taking the medication, and these are not that frequent as compared to the side effects, but they are somewhat severe as compared to the side effects. So it is very important for the patient to read, because nowadays more and more patients are reading the drug package which are inserted inside the box, and they are getting confused with the terms side effects and the adverse events. It is important to discuss the side effects and adverse events with the patient, especially when initiating new medication. Like suppose we are hiring a new place for our practice, we are going to see how far it is from the railway station, bus stand, how it is approachable, whether the rainwater enters the premises or not. All these things we see. Likewise, the patient has got every right to see whether this medication is good or not for his health. Patient who understands what to expect is less likely to discontinue medication prematurely, and this prematurely discontinuation is more common with the size of the tablet. And when we explain the patient, one should be very numerical. Percentage wise, we can explain, or numerically we can explain. Like common is 1 in 10 people. I'm sorry. Uncommon is 1 in 100 people. Rare is 1 in 1,000 people, and very rare is 1 in 10,000 people. So likewise, we can explain the patient that metformin can lead to gastric upset, and the chances are rare or common or very rare. So with this, let us try to see some cases. My tablet comes out in the stools. I thought it doesn't work, so I stopped it. This happens with the metformin prolonged release, sustained release, extended release tablets. I have itching over the penis. I went to all skin specialists, but it is not getting cured. the patient must be prescribed dapagliflozin. And I am losing weight after I started the treatment, and so I stopped all the treatment. This can happen with the wrong choice of the patient. The gliflozins can be started to a lean and thin patient, and he can lose weight. My stomach gets upset with the medication, so I stop the tablets. Acarbose and Oglivose can lead to these problems. And the list goes on and goes on. And the last and the most important thing is 1000 milligram metformin tablet, which appears very large. And one should explain the patient that this is a basic medication for the patient, which is going to benefit as far as the basic pathophysiology of diabetes is concerned. So these are the side effects of metformin: GI upset, diarrhea, nausea, vomiting, loss of appetite, and metallic taste. And the methods to minimize are: he should take the tablet with large amount of water, take on full stomach or with food, start with low dose and titrate very slowly. Suppose the patient is getting side effects, and use ER or PR formulation or SR formulation, which are better tolerated by the patient. When the patient takes metformin for longer duration, say more than 4 to 5 years, and he complains of tingling, numbness, and some neurological symptoms, then one should assess the vitamin B12 levels also. Lactic acidosis is not that common with metformin, but one should avoid use of metformin in critically ill patients and the dehydrated patients. Alpha glucosidase inhibitors have got the notorious problem of flatulence, diarrhea, abdominal pain, and for that matter, start low and go slow is a strategy. Assure that the patient takes the pill with the meal, and assure the patient that these side effects are going to decrease with time. The SGLT2 inhibitors are notorious to produce the increased frequency of urination, and particularly in the older people, when the person is having benign hypertrophy of prostate, one should be very cautious while starting this tablet in rainy season. Reduction in blood pressure, urinary tract infection, genital mycotic infection are also common, and one should advise the patient to take the tablet in the morning so that the frequency of urination increases during the daytime. Maintain proper genital hygiene, particularly in city like Mumbai. Suppose the patient is wearing jeans tight pant during the summer season, this can lead to the mycotic infections more, and the person should increase the water intake to avoid the dehydration, take blood pressure frequently, and avoid the use of loop diuretics along with SGLT2 inhibitors. Suppose the patient is hypertensive. Adverse events are euglycemic ketoacidosis. Proper diet management is to be advised to the patient. Increases of risk of amputation, that is doubtful, but necrotizing fasciitis of perineum is common in our area. That should be addressed and that should be told to the patient. Again, GLP-1 receptor agonist use is getting more common and common with the advancement of oral therapy. Abdominal pain, diarrhea, nausea, vomiting, and reduction in the appetite, these are to be explained to the patients that some of you are going to get all these symptoms. Eat smaller meals throughout the day instead of 2 large meals. That is the first thing which one should tell to the patient. Decrease meal size by 50% when starting or titrating the dose, and stop eating as soon as you feel full. That is the thing which will avoid the vomiting sensation. Minimize greasy and high fatty acid, fat content foods, and extend time period on lower dose until the patient tolerates, and don't go to the higher dose till the patient says that I am okay with this dose. So start with a low dose and go on the higher dose. The other adverse events are pancreatitis, retinopathy due to diabetes control is there actually, and in SUSTAIN 6 it was observed that the retinopathy increases, but that can be attributed to the acute control of glycemia. Caution should be exerted in chronic kidney disease, and we should not be used with the history of medullary carcinoma, the MEN type 2 pheochromocytoma, and hyperparathyroidism due to adenoma or hyperplasia. The DPP-4 inhibitors have got the minor problem of headache and nasopharyngitis. In my area, I have found that peliliptin can lead to more and more symptoms of nasopharyngitis, and that should be addressed because most of the patients, they will start consuming the cough syrups and they will go on consuming the cough syrups to decrease all these things. Methods to minimize the side effect are discussion with the patient and clinical vigilance. These are the two things which can be done for DPP-4 inhibitors. The rare adverse events are pancreatitis, peripheral edema, exacerbation of the heart failure symptoms with sexagliptin, alogliptin, though the mechanism is not known, and severe arthralgia can be there in some patients. Again, the renal complications, the renal failure is the subjective contraindication for these three things. And SUs, they are notorious to produce the hypoglycemia. Use of SUs with sensitizers and insulin can produce hypoglycemia. Avoid skipping meals, that is the first thing which it should be told to the patient. Small frequent feeds. Advise appropriate glucose monitoring when the patient is started on OHS, particularly SUs. And choose later generation or ER formulation things which can lead to decrease in the symptoms of hypoglycemia. And maintain consistent exercise routine. Most of the patients in our area, they go for exercise on empty stomach. So ask the patient to take a small caloric carbohydrate calorie before they go to exercise, and monitor hypoglycemia and provide instructions to the patient how to monitor the hypoglycemia. Adverse events are, sometimes you can see that there are some times which can say that there is adverse event of increased cardiovascular mortality, but that has been disproved by the Carolina CV trial, and contraindications are advanced chronic kidney disease. Metazones, the use is less, but that is increasing day by day nowadays with the lesser dose of tablet. Side effect and edema, this should be avoided in patient who are having heart failure. Lowest possible dose should be used, and whenever the patient complains of breathlessness, he should report to the physician. Increased bone fractures, so it is not to be used in postmenopausal women. Myalgia, a small risk of bladder cancer, which is controversial, is there. Elevated liver enzymes which are not observed, particularly with low dose of pioglitazone, and NOAH class 3 or class 4 heart failure is a contraindication for these tablets. Before starting the new medication, suppose the patient is on 2 or more antidiabetic drugs, discuss with the patient about the reports. Ask his opinion whether the reports can be controlled with his efforts or not. Suppose the patient says that I am going to try all these things for a month, like diet, exercise, all those things, and I will come back to you, let him come back to you, and then start the medication, the compliance increases. Ask the patient how they feel about starting new medication, like whether they are fearing of side effects, they are fearing of cost, and according to that you should plan the medication. Address the patient's reluctance about additional medication, that is cost, the side effects, all those things. Educate the patient about initiating new medication, what it is going to do to your sugar, how it is going to control your sugar, what are the possible side effects that is to be told to the patient. And lastly, ask the patient to come for follow-up so that you can monitor whether that drug is acting properly for the patient. And these are some examples which I do in my clinical practice. Before starting the oral semaglutide, I draw this diagram that this drug is going to act like this. You have to take it on empty stomach with 150 ml of water, 45 minutes. You should not eat anything. And suppose the patient is having the gastrointestinal symptoms after giving metformin, then I write on the file that the patient can have the gastric upset on metformin, so that I am not going to use it again and again. So like this, we can plan the patient's side effects, we can educate the patient about side effects, and suppose the patient is told well in advance about the side effects, it increases the compliance of the medication, and that will lead to the control of the sugar, and that will lead to decrease in the complications, which is the motto of this conference. Thank you very much.
Really appreciated how the communication is, where it gets access to the actions out there. Thank you, Dr. Malpani. And it is our pleasure to be on time, and he completed in bonus. So let's make it to the next session. If anyone has a question, then we can take
Any
it.
quick question, anyone?
So let's make it to the next session, where Dr. Anubhav Verma Srivastava will take on the talk of structured SMPG conveys a lot and need for monitoring. Dr. Anirudh will introduce us. Please.
She's a professor and in charge Endo Unit MLN Medical College Prayagraj UP. She's 4 gold medals and 22 certificates of honors in MBBS, ACP Wellness Awards in 2021, Dr. S.S. Rastogi Memorial Award, ICN Award in 2021, Investigator of the Year 2018 in ISH and BPCon 2018. Many more accolades to ma'am. Welcome so much, and we give you the dash. Thank you.
I would like to thank the audiences, thank the DRS team, Dr. Purvi, Dr. Manoj Chawla for inviting me. We've been hearing, I think all the audiences were there when we talked about CGMS. Dr. Amit talked. So I'll be talking on the opposite spectrum. Standing in Mumbai, where we say it's a hub for the technology, I will go back to the roots because we people living in a second and a third tier city still rely on this. How many of our patients do actually afford? The technology is definitely developed, but then there is still the need to talk on the basics. So next few minutes, I'll be talking on the monitoring, specifically the structured SMBG. So monitoring is one of the five most important aspects of diabetes. So this monitoring of diabetes is essential to identify the changes in the blood glucose level, to achieve the desired targets. And the monitoring is essential because we are talking on the communication symposia. So interpretation of these the glycemic targets and the values, and therein the changes to be made in the diet and medication has to be communicated to the patient. I would like to congratulate Dr. Shefali for a wonderful session on to begin the symposium on communication. Yes, talking on the another leg for the monitoring of the blood glucose. Yes, SMBG is refers to the whole blood glucose testing for people with diabetes, people living with diabetes. Okay, so this not only help us to detect blood glucose level at different points of the day and provide a feedback on the result of lifestyle and pharmacological treatment. SMBG can serve as a useful adjunct to other measures of glycemia. It's the only way to confirm and appropriately treat hypoglycemia. अगर आप नापोगे नहीं तो जानोगे नहीं. So the blood glucose more than 400, the patient is asymptomatic. I think most of us would agree to that. So this is an important tool, especially in the situation waiting for the A1C every 3 monthly. It would be very difficult for the assessment and the target of the patient to be achieved. And where the fallacies of A1C are there the SMBG will hold true. So we are very well aware about the procedure of glucose monitoring using meters which are available, the methods or the glucose measuring strips using the a glucometer with various machines are available. So why patients are not motivated? Let's talk on the certain issues rather than the medical one. They are not taught. We don't have time for the patient where you can tell them the instructions, how and when to test. I primarily work in a government sector where you don't have time for the patient. The residents are also very busy. So they don't know how to, what are the instructions to be given. Cost is definitely one of the issue. The pain, the discomfort, the inconvenience. Hyperglycemia, as I told, is asymptomatic. हमें तो कोई symptom ही नहीं है, हमें तो कोई दिक्कत ही नहीं है, हम टेस्ट क्यों करते हैं? Not sure if they do test, where to jot down, how to jot down, what inference you are going to take out, and what to do with this information. They're not even able to, you have not able to comprehend it, that if this level is higher, you need to titrate the dose of the insulin which we are taking. So somewhere as a physician, we are lacking. So as I was talking, it is definitely the lack of time and reviewing and discussing the glucose number with them, which is the one of the essential reasons what to do with the SMBGs. So why clinicians don't utilize SMBGs? This is a problem. They will not bring the charts. If they do have incorporated, or sometimes they will not even the machine. The machines today they can actually use, or the mobile apps where you can store the data. But yes, the data is difficult to assess. They don't bring meters, they don't bring logbooks, patient checking infrequently, not enough time to analyze the data, difficult to analyze, and uncertainty about the treatment choices. So this is an issue. So SMBG is a tool, not an intervention. Teach patients to monitor with a meaning. I always use the word मैं आपको डॉक्टर बना दूंगी. So that I want to do, because if you don't train them, if you don't talk to them, if you don't explain about the hypoglycemia, or you have to monitor it, you have to reduce the dose, or you have to stop the medicine and hence come over the next day. So we are very well aware. I'll be talking on the SMBG when the monitoring of the techniques is there. So this SMBG presents information about the current glycemic status. if we define it, it is a methodological approach which enables the patient and clinician to understand the blood glucose pattern throughout the day so that the appropriate therapeutic adjustments can be made. So various situations where the regular SMBG should be advised when the patient is on MDI, various multiple doses of insulin, especially in type 1 patient, or strict glucose monitoring required for the disease with the complications. Patient may be on insulin pump, or when the requirement may be not on insulin, but there is a high glucose variability, though you don't have SMBG, CGMS, but still SMBG can help to detect hypos and hypers. Some patients, they are still in the post-COVID era where the steroid-induced hyperglycemia is an entity, where and all the critical care conditions where the monitoring should be done, where once or twice daily SMBG may be helpful. So the increased frequency can be required when there is hypoglycemic, drug-induced hypoglycemia. My previous speaker talked about the various complications or about the drugs when monitored. So whenever there is a chance, you can consult them to actually that these patients may require strict monitoring to avoidance of hypoglycemia. If they still have hyperglycemia not meeting the glycemic target, you can still ask for the SMBG. Newly diagnosed diabetes, especially in gestational diabetes, where the patient you want to keep on MNT, or when you are treating with lifestyle or oral agent meeting the glycemic targets. It can be a regular monitoring, 6 times, 7 times a monitoring, or be testing in pairs. Maybe you can individualize and customize into the patients where the strict control is required, like in GDM or patient early in the therapy, you may need the monitoring of his behavioral and his sugar levels. The recommendation, now what the other society says, the EDA recommends SMBG should be done when the patients are using multiple injections. The less frequent insulin injection, non-insulin therapy, or MNT alone, SMBG may then also be helpful. Where the PPG is still not under control, you can also be appropriate to monitor it. The HbA1c is high, the faster is normal. Most of the patients consider the fasting blood glucose as the main target. The HbA1c is still higher. So these are the patients you can order them to monitor PPG. When prescribing SMBG, ensure that patient receive initial instructions in routine follow-up evaluation of SMBG technique and their ability to use data to adjust therapy. So very essential to educate and train the patients. Otherwise, monitor kar lijega, bolne se kuch nahi hota. So we talked about the CGMS. Yeah, they may be supplemental to SMBG in those hypoglycemic unawareness, and frequent hyperglycemic episodes may be there. The ideal recommendation in non-insulin patients. So the SMBG can be advised to impart knowledge, skill, and willingness to incorporate this monitoring into the treatment armamentarium. This should be considered at the time of diagnosis, every time to facilitate treatment initiation, and they can be considered as a part of ongoing diabetes management education. The CDS guidelines also, they have a class A, B, C recommendations. But for all individuals who are on insulin therapy, SMBG should be used. For others, for type 1, at least 3 times a day with pre and postprandial glucose. In those with type 2 diabetes on once-a-day insulin, at least once a day at variable time is recommended. And type 2 not receiving insulin therapy, individualization of therapy can be done. You can ask for multiple testing in a week or a weekly testing. Make Sunday as a testing day, because हमारे पास PPG करने का time नहीं मिलता. This is one of the answers for a working people we do get. So those we have just talked about various guidelines telling about the indication where the SMBG use. If you can see in a broader spectrum, all persons with diabetes can benefit from SMBG. And so all patients with diabetes should maintain blood glucose levels as close as to normal, and definitely for the type 1 SMBG is very helpful. Whenever we talk on a podium in a conference, there has to be some data supporting it. I'll just quickly go through some of the data. So this is one of the St. Carolo study, which was a prospective randomized clinic-based intervention study, a 161 diagnosed type 2 diabetic patient with HbA1c of 6.6 and a 12-month duration. Here, they were followed for 1 year, and it was shown higher rates of diabetes regression on metformin and remission was achieved in the SMBG-based group than the intervention group as compared with the only HbA1c control group. And the same study, there was significant greater increase in the lifestyle score in SMBG. Not only the lifestyle score, the increased physical activity, consumption of vegetables, nuts, high fiber cereals. So the behavioral changes can also be assessed by day-to-day monitoring, enhancing the monitoring in the for the patient. So this SMB-based structural, educational, and pharmacological programs empower patients to achieve nutritional and physical activity goals and encourage physicians and patients to use SMBG to optimize therapy. Another study, which was a structured testing program study, which was a 12-month prospective cluster randomized multi-center study on a 483 poorly controlled patient, insulin type 2 patient in US. They were divided into the active group and the other were the structured testing group. So you can see there was significant great mean reduction amongst the two groups, and this was more significant where the structured group showed definite reduction in the all other parameters. So programmatic structured SMBG contributes to significant improvement in glycemic control. So the real world data, another 6-month real world study on 273 non-insulin treatment patient. Here the one patient, as usual, 1 blood glucose per month, like maybe 3 months if they are coming. Here the patient was asked to have 1 blood glucose profile every 2 weeks, though we prescribe much more than that. And what is was shown that these patients had a better control when they were advised or given the SMBG, the blood glucose monitoring was done, and they have a significant response in the two groups. So there are various studies which shows the conclusion comes out to be the same. The structured SMB should be available as a part of self-management processes for people with suboptimally controlled type 2 diabetes, those not on insulin therapy. But we have definitely seen the guidelines, the insulin therapy, they should be the patients of choice to go. But as these real world data, they also show the uncontrolled diabetic patient not on insulin therapy can also be given the options, the choices, and the benefits of structured SMBG. So the various meta-analysis of RCTs confirm the benefits of structured SMBG of a non-insulin type 2 diabetes patient, and certain algorithms can also be helpful in educating the patients and managing their own blood glucose levels. So this was another study which structured testing group showed improved glycemic control with routine testing groups. So here, this was a randomized control that controlled the structured testing with the routine test, and definitely the patient scored better when their relationship with the food, their control, their monitoring were better. There are certain factors or interferences which can be operational errors, environmental factors, exogenous interferences, and the endogenous changes, which was also seen in CGM as he showed. So there are errors. मेरा capillary blood glucose अलग आता है, मेरा venous plasma अलग आता है, 20 से 30 का अंतर होता है. So there are so many falsies. They will bring the glucometer and sit with you. Then we have to need to explain that there can be changes at same point if the patient is targeting it. So the 5 steps to effective blood glucose monitoring, it has to be structured, results easily displayed, they have to be trained. What has to be looked for? What have to be done? If it comes to 50, what you have to explain to him. So the training has to be done. And they should know how to share the data to your healthcare providers. The reviewing of the data has to be done by us, and they should know to look patterns and make treatment changes if possible. And treatment changes need to be evaluated. So the real-time feedback can be done, detection of glycemic excursion as an educational and motivational tool. The responsibility of the patient in order to perform an appropriate, interpret and act upon SMBG. So training should be essential. The chamber training, the explanation has to be done. Along with the prescription of the medication is essential. So various commercially available glucometers are there. And with this, I would like to thank you for your patient hearing.
Wonderful. So like SMBG, it's like taking the car with the speedometer, and SMBG is the speed to indicate. And when you counsel them, it is now structured SMBG where documentation plays real evidence in upcoming time when AI is added to. So wonderful talk. If anyone has any question.
Anybody for some questions, quick questions?
So thank you. I'll ask every speaker to hold on to the end of the session to for the photos. Yeah.
Thank you,
So,
ma'am.
In the communication symposia, when we have all served in well and the cherry is missing, and that's where the cherry is now going to be presented with Dr. Amit. He had been, I don't know what word I can put forward to his introduction, but the one introduction which he put forward was he is a wonderful photographer. So that's where now unique way in patient communication and connect, how overcoming the limitation could be possible with this session. Yes, to Mr. Amit.
Can we have the slides, please?
Sorry.
For Dr. Amit Rajput. Is it on?
Yeah.
So can you share it to LED?
We have it now, yes, sir. Thank you.
Good afternoon, everybody. I'll be speaking upon the topic unique ways towards patient communication and connect. So when we see our patients in OPD, too often we underestimate the power of a touch, a smile, a kind word, a listening ear, an honest compliment, or the smallest act of caring, all of which have the potential to turn a life around. For usual patients' complaints against doctors don't listen, doctors are arrogant, they are always busy, they see more patients in less number of time, and they want to mint money. A doctor's version is, I don't have enough time, and I cannot afford to waste time on communication. But the effective communication is crucial for accurate diagnosis, treatment adherence, and patient satisfaction. And if you are good with words, you can be pretty persuasive. So the communication with patient begins from the waiting room itself. So we can create a welcoming and comfortable clinic environment to reduce patients' anxiety. We can offer free Wi-Fi charging stations for the phone, display informative, engaging health-related content on the screens, keep the area clean, well lit, with natural color and soothing colors. Which mean natural light and soothing colors. We can offer complimentary water, coffee or tea, play calming background music, and most importantly, appoint a polite staff. If a patient is waiting for a long and once he enters the consulting room, our first instinct is to apologize. But instead, one can say thank you for waiting. Apologizing starts the conversation in a negative way. Thanking the patient is much more positive, and it is harder to get a negative response
to you after you thank them and allows your meet to start on a fresher note. Avoid a serious I am important face. A smile helps to break the ice. Smiling and greeting people warmly gives the signal that you are humble and friendly. But of course, smile can be used as per the situation. One can also use a smile in a serious patient. Attire is definitely important. The physician's attire isn't necessarily a reliable indicator of his skill and competence, but this is not always how the patient thinks. Patient associate professional attire with honesty, knowledge, high quality care. So it might not make much difference to a senior reputed doctor, but for younger physician, it is definitely an important factor. Non-verbal communication, Dr. Shefali has already mentioned that your tone of voice, facial expressions, posture, use of pauses between the sentences, hand gestures, full body movement, and good eye contact, all are important. So avoid technical jargons such as words such as hypertension, myocardial infarction, dyspnea. You can use simpler words such as high blood pressure, heart attack, and difficulty in breathing. Simple gesture like a handshake or a pat on the back can create a sense of reassurance and connect. Blood pressure, currently we outsource it to our waiting area, staff to the waiting area. But if you make a habit to take blood pressure yourself, it gives you more accurate readings. Secondly, it connects you better with the patient. Empathy is the ability to understand and share another person's feelings and emotion by stepping into their perspective. It is a crucial communication skill in medicine. Sympathy is to acknowledge that someone is in distress, but empathy is to actually understand how someone is feeling. So most doctors do sympathize with their patient, but very few can empathize, and they are a better physician. There are studies which shows doctors who empathize better with their patient show lesser HbA1c and LDL levels. Doctors who have treated their sick parents or their sick near relatives make better physicians. Experience is the teacher of all things, and for doctors, personal experience with illness in loved ones can teach empathy, patience, and the true art of healing. Communicating with patients and the relatives, physicians interrupt patients within about 20 seconds when they start speaking. So hear them out, don't interrupt. It will take only few extra minutes. Give them time. Always give patients the opportunity to ask questions. Ensure that they fully understand the information, offer encouragement, and conclude on a positive note. Listen to learn. That is the true story of patient's illness, but more importantly, learn to listen. Communication with our surgeon colleagues is also important. For example, even in 2024 year, surgeons still say, अगर urine sugar positive है तो मैं operation नहीं करूँ. So you need to dedicate time for special situations like type 1 diabetes, preconceptual counseling, GDM, OHA, insulins, HbA1c, CGM, pumps, alternative medicines, various complications of diabetes. Everything needs time. While explaining brittle diabetes, we must explain the patient that while controlling sugar, we are not looking for perfection, but we are looking for optimization. Elderly patients, we need to discuss the concept of sarcopenia, balance, proprioception, prevention of falls, strength training, and in every visit, we need to compliment them, which skyrockets their confidence levels. Use humor appropriately to his tension and build rapport with the patients. Erectile dysfunction, it is a sensitive talk, so we need to ask leading questions to set the ball rolling, and then patient comes up with more information. So there was this particular patient, he came to me with ED, I treated him, thankfully he responded well. He was so happy, he came back to thank me. He said, Doctor Saab, आपने तो जादू कर दिया, आपके ट्रीटमेंट ने तो बहुत अच्छा काम कर दिया. लेकिन समाज में ये प्रॉब्लम इतने लोगों को है, उनको पता ही नहीं कैसे अप्रोच करना है। मैंने तो एक काम किया, आपका नाम शहर के सब टॉयलेट, पब्लिक टॉयलेट्स में मैं लिख के आया। So yeah, sometimes the joke is on us. So things not to do during clinical consultation, turning away from the patient and looking at the computer. You must maintain face-to-face interaction. You should not appear rushed. You should never downplay patient's concern and avoid dismissing issue like weight pain or neuropathy. The matter could be trivial to you, but not for them. You should never assume superiority. Don't act like you know the patient better than they know themselves. You should not focus only on the numbers. Treat the person and not the numbers. For example, a patient might be uncomfortable at BP lower than 150, but you cannot go by the guidelines in such person. You have to keep BP a little bit higher and never criticize other doctors in front of the patients. So if you want to be a better doctor, you must practice empathy and time. So each one of us have some unique approaches while dealing with the patients. I think we have a little time, so I'll share my experience. This is diabetes and hearing impairment. So when a patient with hearing impairment, diabetes and hearing impairment enters the OPD, patients with hearing loss they appear disoriented, they have lack in confidence, they are depressed, they are shy and are unable to communicate and express themselves directly to the doctor. Later, they tend to avoid follow-up visits as they are not able to communicate freely. So communication is difficult in such patients. So the options we are left with are talk to them in a loud voice, or talk to the relatives for the details, or ask the patient to write the symptoms down on the paper. Why this topic is important? Diabetes and hearing loss. People with diabetes are twice as likely to have hearing loss. They have anxiety, social isolation, and depression. There is increased risk of dementia that is almost 3 to 5 folds. Diagnosing and treating hearing loss prevents cognitive decline and progression towards dementia. Gait and balance are affected due to vestibular involvement, and falls and fracture are almost 3 times more common. And treating hearing loss with hearing aids improve balance function, and it slows down the progression towards dementia. And ears are like muscles. If we don't use them, we lose them. Hair cells in the ear are like beta cells in the pancreas. Once they are damaged, they cannot regenerate. Even after knowing these facts, these are the standard textbook of diabetes. None of them have a chapter on diabetes and complications in ear and hearing loss. Forget about the chapter. Even in index pages at the back, hearing loss is not mentioned. You attend so many conferences, you hardly ever come across topic on hearing loss in any of the conferences. So this is internal ear. It looks like a complicated structure, but to make it simple, just imagine it as a single tube. It is filled with fluid. The fluid is called endolymph, which is rich in potassium, and the inner lining is lined by specialized cells called as hair cells. So towards the right, this is the structure, coil structure. It is a cochlea, which is associated with hearing, and towards the left is vestibular apparatus, which is associated with gait and balance. Diabetes is microangiopathy. So once the blood vessels are damaged, they damage cochlear nerve and all the structure associated around the cochlea. And unlike retina, it is virtually impossible to examine the cochlea as it is deeply embedded in the temporal bone. We don't have a cochlear equivalent of fundus examination. So there comes the role of a stethoscope. Stethoscope, this is not a medical term, we have coined it. You just have to reverse your stethoscope, and a patient has earpieces in his ears, and we have to speak in the diaphragm. This technique works wonderfully because patients with diabetes have mild to moderate hearing loss. So when patient understand the words of doctors clearly for the first time, the emotions on their faces are invaluable, creating a stronger connect between a doctor and a patient. Patients no longer feel neglected. Complex instructions can be conveyed clearly. Regular follow-up visits become more likely. This also results in better management of diabetes and associated comorbidities. Relatives can use the stethoscope for communication at home. And it also encourages people to consider hearing aids, which otherwise is a taboo. So the key takeaways are hearing impairment is an under-recognized complication of diabetes and warrants better recognition. Hearing loss in diabetes involves microangiopathy and the damage of associated structures in cochlea. Detecting and treating hearing loss early is an important intervention to prevent cognitive decline, dementia, and depression. Diagnosis is by audiometry, and hearing aid also improves balance function and reduce falls and fractures, especially in elderly people. Stethoscope technique improves doctor-patient communication in OPDs, ensuring regular patient follow-up and better management of diabetes. So people will forget what you said, people will forget what you did, but they will never forget how you made them feel. So after listening to a couple of talks, consultants have started using these techniques in their OPDs. These are various consultants in their OPDs. I think some of you are sitting here. These are happy faces, not just of the patients, but the consultants as well. So I encourage you all to use this technique in your OPDs and experience the magic.
Wonderful.
Thank you.
Wonderful. I say the heart of innovation is the intent of innovation from the heart. Thank you.
Thank you.
And
Thank you.
looking forward to the stethoscope, how we use it in future. So
Thank you.
I'll invite all speakers to come on dais and have group photo, please. And I'll invite the next session's chairpersons also to be around to get onto the stage to take proceedings further for the next symposium. Dr. Chawla, you can also join on the dais for the photo.
I'm getting one chance to take comments.
Maybe it is better. So let's make it to the next session rather than, yeah. Can you introduce the next session?
Good afternoon, everyone present here. It is my honor to welcome esteemed chairperson to the stage. Their leadership and expertise are invaluable to our discussion today. Please join me in giving one round of applause as we invite Dr. N.K. Singh, Dr. Subrati Bhattacharya, and Dr. Manas Save to share their insights and guide us through the next symposium. Thank you so much.
Hello. Good afternoon. So this is a special consideration in diabetology. I think our chairperson is here, Dr. Supratik Bhattacharya, and I have great pleasure for the first talk to him. Higher risk of seniors in diabetes, time to protect. I think it is well known all across India in all conferences. I don't think there is need to formally introduce you. So you can please start.
Thank you, Chairperson, sir, for your kind words of introduction. And a big thank you to Dr. Manoj Chawla, Dr. Purvi Chawla, Dr. Bansi, and the entire team of DRS and WCPD for this invitation. And it's a pleasure to see all of you here. So can we have the slides, please? I'll be talking about a newer concept. When we talk about it, I think the awareness grows, and this is about adult vaccination. So we have an entire dedicated session coming up on adult vaccination, which is going to be taken by Dr. Panda after a while, but I'll be talking specifically about a lesser known topic, one of the adult vaccinations. And just give me a second before we have the slides on board. All right. Can we have it in the full view mode, please? So shingles and diabetes. So this is something that is of concern. We know that diabetes is not only a state of pro-inflammatory state, but at the same time, the immunity level in diabetes goes down. And because of that, the diabetic individuals are predisposed to many infections. Now, we know that diabetes and chronic kidney disease are currently the leading cause of disability globally and increasing cause of mortality. And we also know that anyone with diabetes and chronic kidney disease have the increased risk of severe outcomes in terms of having more number of infections, vascular diseases, self-harm, cancers, etc. Coming to herpes zoster in patients with diabetes mellitus. There is a very strong association between diabetes mellitus and herpes zoster. And if you see here, there are a number of studies that has been done, which has shown that if you consider 1,000 personal years, or even those at higher risk of herpes zoster infection, those living with diabetes, it is significantly higher than those with diabetes versus those who do not have diabetes. Similarly, the post-herpetic neuralgia is significantly higher than those with diabetes versus those who do not have diabetes. Patients with diabetes have a higher incidence of herpes zoster compared to healthy individuals, as you can see in here, and all age brackets, starting from 50 to 60, 60 to 70, or even those who are more than 70 years. What is the impact of herpes zoster in diabetes patients? So we know that herpes zoster can contribute to a glycemic deterioration. So after an episode of herpes infection, 24% of the well-controlled patients with diabetes who had an HbA1c of 6.5% had increased A1c after a herpes zoster infection. Not only that, there are high chances of hospitalization, the length of hospital stay increases, the number of medications, including insulin, goes up, and if you look at the risk of herpes zoster in different comorbidities, obviously it's increased in diabetes, as we said,
because the immunity is low, but so is the case with other conditions, especially like SLE, rheumatoid arthritis, and even in cardiovascular diseases. So you will need to screen for these individuals who are at high risk. And, these are the people who might benefit from vaccination. And we need to have that conversation about adult vaccination early rather than later. So multiple comorbidities in Herpes-Zoster, patients with multiple comorbidities are associated with a higher risk of Herpes-Zoster. So for example, those who not only have diabetes, but along with that have a cardiovascular disease or a cardiac condition like heart failure or COPD, they have much higher chances of a Herpes-Zoster infection as compared to those who only have diabetes. What about the quality of life impact on Herpes-Zoster? So it's more than just a rash. Herpes-Zoster can be debilitating to daily life. So what are the kind of impacts that we have on the quality of life? It can be relations with others, going back to work. It can affect the mood, general activities, enjoyment of life. All of these can be affected by Herpes-Zoster infection. And not only the infection per se, but there is a significant high incidence of post-herpetic neuralgia that negatively impact the health-related quality of life. So impact of Herpes-Zoster on health-related quality of life, as you can see here, can affect the mobility, self-care, usual activities. The pain level goes up. Similarly, if somebody has got post-herpetic neuralgia, again, the mobility is an issue, self-care, activities, and it's related to a significant amount of pain. So efficacy of Shingrix, which is the vaccine given for Herpes-Zoster in patients with diabetes mellitus, and we'll talk especially about that. And it has got two components. One is the antigen component, which is a glycoprotein E, and another one is the adjuvant, which is the ASO1B. The reason why we have an adjuvant is that it's designed to induce a strong and sustained anti-GE immune response. Without the adjuvant system, the response wouldn't have been so profound and long-lasting. So as you can see here, because of the adjuvant that is mixed, you see that there is a rapid and transient activation of the innate immune system. So both the T as well as the B cells are activated, and early and transient response is followed by a high and durable varicella-zoster specific response. So without this adjuvant system, you see the response is quite less as compared to those who had the adjuvant in particular. Now these are the trials. Zone 50 and Zone 70 are the trials that were done in those who are more than 50 years versus those who are more than 70 years. And the primary objectives was to look at the post-herpetic neuralgia efficacy in more than 70 years and Herpes-Zoster efficacy in more than 70 years. So the results were quite profound. It was seen that Shingrix delivered more than 90% efficacy against shingles in patients who are more than 50 years. So the efficacy was very, very high when it came to the age bracket who are more than 50 years, with almost 97% efficacy. Similarly, anyone between 50 and 59 years, it was close to 97%. And not only those who are in the 50s, but it also was significantly helpful for those who are more than 70 years. And we saw the efficacy in those who are more than 70 years was still more than 90%. So Shingrix significantly reduced the risk of post-herpetic neuralgia and other complications related to shingles in both the age cohorts who are more than 50 years and more than 70 years, more efficient than those who are more than 50 years. So we need to be aggressive and counsel those patients who are more than 50 years and living with various comorbidities, including diabetes and related disorders. And you will see that the vaccine efficacy is more than 90% in both the brackets. In terms of preventing post-herpetic neuralgia and vaccine efficacy against the Herpes-Zoster related complications. Shingrix efficacy against Herpes-Zoster for people with medical conditions at enrollment. As you can see in here, post-hoc analysis of Zone 50 and Zone 70 showed that it was efficacious in the older adults with diabetes and also with those with various comorbidities like hypertension, diabetes, coronary heart diseases, etc. So numbers of side effects, deaths were very similar in the vaccine arm versus the placebo arm. There was no safety concerns that were specifically identified. So Zone LTFU, which was an 11-year follow-up data, overall vaccine efficacy of herpes zoster vaccines for those who were vaccinated at the age of 50 or more years, have shown very convincing results that it was efficient and there was no specific safety concerns. Adverse reactions reported post-vaccinations were usually mild to moderate, and it could be just the pain at the vaccine site, redness or swelling, and there were certain solicited systemic adverse reactions to show that the vaccine was working, for example, fatigue, fever, headache, nausea, etc. Safety results supported the favorable benefit risk profile of Shingrix in everyone aged more than 50 years, and it was comparable to placebo in overall incidences of side effects, as we just mentioned. So what about the vaccine schedule? So Shingrix is indicated for prevention of herpes zoster and also post-herpetic neuralgia, which is really bothersome in adults more than 50 years. And it's given as the vaccine schedule is you give the first dose and the second dose is usually after 2 months. And general instructions is that it should be refrigerated and make sure that you're not freezing it. So store in the refrigerator anywhere between 2 degrees to 8 degrees Celsius. And after reconstitution, Shingrix is stable for 6 hours when kept in the refrigerator. And it's to be given as an intramuscular injection only, and it's not indicated for prevention of primary varicella infection or chickenpox. Data supports co-administration with the following vaccines, which are also part of the adult vaccination schedule, like influenza vaccine, which is given yearly, or pneumonia vaccine, like pneumococcal vaccine, and Tdap as well. And the co-administration is generally well tolerated and no safety issues raised. So this is my this is done in my clinic. So all three are usually given together. You can see in here the Shingrix vaccine for herpes zoster, and then you see the influenza vaccine as well as the pneumococcal vaccine. All three given on the same day, and then you have the adult vaccination card, which you can sign after the vaccination. And finally, this is another, the newer version of the adult vaccination card. Once the vaccination has been done, you give them a certificate saying that you have completed the vaccination, and this is usually very encouraging for the patient as well. So Shingrix is currently approved in 51 countries and 92 million doses has been distributed. And so we have a very robust data coming in with Shingrix. So just in summary, it's efficient in more than 90%. Across age groups, anyone more than 50 years are eligible, especially those living with diabetes or other comorbidities. 11 years long-term protection is seen. Recombinant adjuvant vaccine non-live is given, which gives a profound immunity. Approved for use in adults who are more than 50 years and is generally very well tolerated without any concerns. Vaccination recommendations against the herpes zoster in patients with diabetes mellitus. Again, in patients with diabetes, vaccination may help to protect against serious consequences and infectious diseases, and thus we need to talk to them about it. Vaccine recommendation has been given by various authorities like CDC, ACIP, STIKO, and majority of them has said that it's efficacious for anyone who is more than 50 years. Similarly, Indian consensus guideline recommendations for shingles in adults say that anyone with 50 years should be receiving at least 2 doses 2 months apart. Same from RSSDI and Indian Society of Nephrology. Just to mention the vaccine schedule. So the first dose is given, as we had seen, intramuscularly, and the second dose can be given anywhere after 2 months, starting from 2 months all the way to about 3, 4, 5, 6 months. So you have a long window period when you can give the vaccine, second dose, without any concerns. vaccination guidelines for patients on immunosuppressive therapy. So many of your patients who might be on immunosuppressive therapies or steroids, there are certain considerations that you have to make. So those who are on rituximab, for example, immune-mediated diseases treated with rituximab, they might have to be deferred by about 5 months after the last dose. And those on corticosteroids with more than 20 milligrams of prednisolone equivalents, they might need to defer the vaccination till the prednisolone dose has been tapered to less than 20 milligrams. Waiting period to get Shingrix after having herpes zoster, again, it's highly recommended that if somebody had the herpes zoster, they know how painful it is, especially the post-herpetic neuralgia, and we strongly recommend that they should have the vaccine, but there is usually a wait period. So CDC USA says vaccination should be delayed until the acute stage of the illness is over and the symptoms abate. And CI Canada, on the other hand, says zoster vaccination may be considered 1 year after the herpes zoster episode. So this is my clinic where you see that we have our standee, which talks about adult vaccination, herpes zoster vaccination, and it produces awareness among the patients who walk into your clinic. So with this, thank you for your kind and patient hearing. Any questions I'd love to take for them?
I think most of the diabetic clinics of vaccination. So I just invite any questions from the audience. Yeah.
We are seeing a lot of diabetics coming at a younger age. Why is this 50 years time?
That's an excellent question. So there is an ongoing trial in a much younger age group, and we're expecting the results within a very short time. So once we have that, we'll have a label update to use it in younger persons as well.
What is the cost of this vaccination?
So the cost of the vaccination is around 11,000, but there are many schemes, like they have an EMI scheme that is available from the company as well for those who can't afford it. So he's a very renowned senior consultant and dealing with vaccination on a regular basis, and he's going to be talking about adult vaccination. So
I thought that we'll start the discussion from now.
yes.
Thank you, Supratik. We were there in a program of this vaccine, and when Dr. NK is there on chair, they have a recommendation of 2 doses in the younger people and 1 dose in the elderly people. I have gone through the literature. Beyond 60, that will just a single dose is sufficient. And then those who are immunocompromised, younger, 2 doses.
Correct.
And what I feel it should be reverse. What do you comment about that?
So I think instead of making our lives complicated, I feel that 2 doses needs to be recommended to everybody for the best results.
I also agree to that. Thank you. Thank you, sir.
Thank you, sir.
Thanks, Dr. Supratik, for highlighting this very, very important issue. If there are no further questions, now please chair, join here to the chair. Come here.
Thank you so much.
So, next.
So it's an absolute pleasure to invite a senior consultant from Jaipur and in charge of Apollo endocrinology, Dr. Minal Mohit, and she'll be talking on beyond insulin for type 1 diabetes. Right. May I please request Dr. Minal to please come to the dais for her speech.
Thank you, Pratik. Thank you, Dr.
We have not formally introduced you because you are a very known person.
Sir, there are hardly any
Yeah, you are a very well known person to all the conferences. So great pleasure. Please.
So very good evening and thank you so much, Dr. Manoj and Dr. Purvi, for having me here this evening. I don't find any people to listen to the session, of course, but I think the chairpersons and myself and the few audience who are very specifically interested in type 1, we can sit and discuss. So as I was told to talk about type 1 diabetes beyond insulin, I will take you through the session in the next 15 minutes allotted. We have a pointer here. Okay. Doesn't really matter. Fine. Okay. Let's go with this. So type 1 diabetes beyond insulin. I will just take you through first what is a healthy pancreas. A healthy pancreas is one which is secreting insulin in right proportion to the glucose which enters the system. So this insulin acts on the receptor and the glucose is able to enter inside the cells. So we have the GLUT2 for the glucose and GLUT4 for the insulin. So what happens in type 1 diabetes? In type 1 diabetes, there is no insulin. So there is no insulin, completely insulinopenic state. So the receptors are not activated, glucose does not enter. So the glucose is staying in the blood, so there is hyperglycemia. In type 2, there is insulin, but there is resistance. So again, what happens? The receptor is not opening, there is resistance, so glucose is still not entering the cells and there is still hyperglycemia. So this gave us one interesting lesson that when we are dealing with type 1, we are dealing with the condition of insulinopenia. So what we need insulin, right? So the journey began. And right from 1921, we have insulin with us, given to us by Benting and Best. And we have already completed a centenary with insulin. We've journeyed through conventional insulins, beginning from bovine, porcine, human, conventional analogs, and we today have, luckily, something called the once-a-week insulin. So once-a-week insulin that was introduced in the recent past with onward 6 trial where it was tried in type 1 diabetes. Then this is still insulin, and I'm supposed to talk beyond insulin. So maybe think about something adjunct to insulin. So we also tried something adjunct to insulin in type 1. And when we talk of something adjunct to insulin, that means along with insulin. So I'm still not going beyond insulin. I'm still along with insulin, adjunct to insulin. So this was a paper published in Pharmaceuticals, and they have tried all the possible OHAs, that are used in type 2 can be used in type 1 along with insulin as adjunct to insulin. And these are the literature data that has been studied. And we have been using few molecules like metformin, like pioglitazone, like even sometimes we are using SGLT2Is along with insulin, not only in these molecules, but along with insulin, adjunct to insulin, right? So coming back to our father of insulin, Benting. So Benting himself gave us this statement while receiving the Nobel Prize that insulin is not a cure, it is just a treatment. So this was the statement given by father of insulin, Dr. Frederick Benting, that insulin is just a treatment. So we have started thinking, managing diabetes with insulin, but now we are on the lines of curing type 1. In that race still, are we on the journey to cure insulin? Let's see. So we began with something called bionic pancreas. Then we thought of islet transplant, stem cell therapy, gene therapy, immune therapy, and again this cell therapy. Coming to the bionic pancreas. Bionic pancreas were designed to address the basic defect. We had started learning that it's a bihormonal disease, not only dealing with insulin, but also affecting the glucagon. So these were the bionic pancreas. They were designed to address both the defects. So they were also addressing the alpha cells, which were hypersecreting the glucagon, and they were also addressing the beta cells. So that seems something like this, that we were addressing both alpha cells and beta cells, and the setup was something like this, that there was a sensor to detect the blood glucose, then there was a control system, and that control system was actually managing a balance between insulin as well as a glucagon. And by the use of this bionic pancreas, we were able to achieve a quite near normal control in the patients who were on bionic pancreas. So these were the graphs, and we could achieve a reasonable decent blood glucose control by the help of bionic pancreas, avoiding hypoglycemias. So the blood glucose in this literature, in this paper, came down from 159 to 133 decently. And there were no hypos at the same time. So, is this the cure? That was the question. Is this the cure? So this was not the cure, but this was the next best thing that could have happened to cure. So bionic pancreas gave us something next best to cure, but we are still away from the cure. So what were the challenges? The challenges were the bionic pancreas, it's an invasive technology. There are possibilities of that technology going wrong. As we all know, once the technology goes wrong, it's very, very bad. It's a havoc. Then there were no stable preparations of glucagon to manage a hypo. Then insulin time of onset was still unpredictable, and this was not very physiological. So we moved from bionic pancreas to islet transplants. So for the islet cell transplantation, we needed a donor pancreas. We needed to extract the islets. Those islets needed to be separated, and these separated islets needed to be transfused inside the liver. So intrahepatic infusion was required, and that was islet transplant. And these transplanted cells required immunosuppression. So Edmonton Protocol was accepted, it was given, and this was accepted worldwide. It was a glucocorticoid-free immunosuppressive therapy using teclistamab, tacrolimus, or sirolimus. As a result, the blood glucose was significantly controlled. It was insulin independence was also achieved for quite some time. Eventually, there was partial functioning, and then over the period of time, there was graft loss. So, initially, we had good acceptable levels of C-peptide, but over the period of time, we could see a decline. So, everybody was not getting it. Why everybody was not getting it if it is so simple? Because we needed a huge amount of deceased pancreas, we needed islet cells in huge burden. We needed better technology to isolate the islets. Then we needed lifelong immunosuppression. We needed something for the anti-inflammatory response as well. So this is still not the answer. Then we moved beyond insulin and we talked about stem cell therapy. When we talk of stem cell therapy, they had two specific features. One, these cells should be renewing themselves, like they should be undergoing cell division without differentiation. So they should maintain their originality. And at the same time, when given the right signal, they should de-differentiate into the beta cells. So the stem cell therapy begins with the totipotent stem cell. These totipotent stem cells were then converted into pluripotent embryonic stem cells, and these embryonic stem cells were then signaled to develop into the beta cells. So stem cell therapy, the cells, now there were labs who made available At times, there were clusters of islets, they were packaged together, or there were single islet that was packaged. Then there were these further advancements, and specific nanothin capsules were created, and they were packaged. But we are still away. That is not very practical. Then we came to gene therapy. When we talk of gene therapy, the very first concept is we have to stop the autoimmunity because the beta cells are autoimmunely disrupted. So the very first step is to prevent the autoimmune destruction of the beta cells. Then you have to introduce the insulin gene into the non-beta cells because we are trying to make the non-beta cells convert into beta cells or insulin secreting cells. And then of course we needed something called non-beta cells like the alpha cells to be reprogrammed and develop into beta cells. So this was the entire concept of gene therapy, that we need to control autoimmunity, we needed to protect the existing beta cell mass, and the beta cells that were regenerated needed to be further prevented against the autoimmune attack. So first step, preventing the autoimmune destruction of the beta cells. So we were trying to induce immune tolerance to the beta cells antigen, so they are no longer recognized as foreign. Then modifying the residual beta cells to resist autoimmune destruction. Then we were trying to stimulate the insulin gene. The insulin gene was then inserted into the non-beta cells, and we were using virus as the vector to carry that gene. So viral vectors were used in the gene therapy to become alpha cells to get programmed into the beta cells and start secreting again insulin. Then moving from the gene therapy, we are now talking of immune therapies. Now immune therapy for type 1, I'm going back a little. So autoantigens are released from the beta cells, and these autoantigens are presented by the antigen-presenting cells to the CD4 T cells. Then there are cascade of immune attacks which lead to beta cell apoptosis, and as a result, there is type 1 diabetes. Now T cells, these T cells have T cell receptors. Now these T cells are very intelligent. They will internalize the T cells that are already attacking their own system. But when this all is happening, some of the T cells will escape this auto digestion of the T cells by the T cells themselves. And once they are released into the system, there we have another peripheral check. So T regulatory cells are there. These T regulatory cells will further capture them and destroy them. But still some of them will still manage to escape and damage the beta cells. So the immune tolerance, this is a central tolerance at the thymus level, where the antigen presenting cells are presenting the antigen, and these T cells which are stimulated, either they go and get deleted, that is they are phagocyzed, or at times these T cells are released and they escape in the system. When they escape in the system, there is peripheral tolerance. In the peripheral tolerance, there are T regulatory cells. They will further damage the T cells, which are going to attack your own beta cells. But still some of the T cells escape, and ultimately what we face is type 1 diabetes. So this is the entire journey. So by the time we are genetically predisposed, there are immunological triggers, there are immunological abnormalities, and by the time 80% of the beta cells are damaged, we face something called type 1 diabetes. So working on this concept, we have immunotherapy that is slowing the progression of disease, stopping the insulinitis definitely, and restoring the self-tolerance. I'm rushing because I can see the clock. So we had the pharmacological immune suppression that was started with the development of cyclosporine in 1980s. Then we have certain immunotherapies like cyclosporine, radiation. We also have cyclophosphamide, methotrexate. All these were trying to make a balance between the T effector cells and the T regulatory cells. As a result, what we achieve is slowing the progression of development of type 1 diabetes. Now we had certain trial therapies like the glutamic acid decarboxylase. It was tried, it did not work. Then later on, even insulin itself was tried, given orally to the patients. It also did not work. Then we had heat shock protein. So HSP60 was tried, but again, the trial was retrieved by the authors themselves. It did not work. Then newer immunotherapies which are working against the CD28 and CD80/86 co-stimulation, and we have something called teplizumab. And teplizumab is now on the board, and we are having very high hopes that this humanized anti-CD3 monoclonal antibody might help us to prevent type 1 diabetes. So this has shown some good results in the clinical trials. Then beyond teplizumab, we have teplizumab, right? Then we have rituximab, anakinumab, anakinra, girokizumab. Fusion proteins are on the horizon. These fusion proteins are being used to prevent development of type 1 diabetes. We also have abatacept, elifacept, then we have other T regulatory effectors which are working against interleukins. So the lesson learned is that we can manipulate and modulate the autoimmune response and prevent the development of type 1 diabetes. Moving beyond, the immunotherapy is still under trial. So moving beyond immunotherapy, we recently got the FDA approval to something called donislecl. The molecule is donislecl and the brand name is Lentidra. Something sounds like mixture of Lentis and Apidra, Lentidra, but Lentidra is not an insulin. It is the islet cell infusion. The molecule is dormicelacin. It is given intrahepatically as infusion. It has got FDA approval just few months back, given as intrahepatic infusion of 5,000 international units, and they have shown some good results. So that was about beyond insulin. Just one slide about thinking beyond sugars also in type 1. Let's move beyond sugars. Think about the preventing the complications as well. All the same macrovascular complications, including muscle, exist in type 1. The take home is yes, remember the cause of type 1, it is insulinopenic condition. Presently we are here, but probably the future lies in immunotherapy, gene therapy, cell encapsulation, or the cell therapy. So this is the journey, and this is from JDRF. You should know the journey of type 1 also. We know right from risk evaluation and calculation, and at whatever stage you diagnose the disease, you can prevent it by the right appropriate measures. And with all and everything said and done, before anything, lifestyle management stands for type 1 also. So please don't forget that. So a cure is in sight. For more, I invite you all to join me at Jaipur at an exclusive conference on type 1 diabetes. We will be talking anything and everything type 1. Join me at Jaipur, 7th and 8th of December. Thank you so much. Do we have any questions?
Thank you so much, Dr. Minal, and floor is open for questions, if any. If not, then we'll conclude and move on to the next session.
Thank you so much. I think Dr.
Thank you, Dr.
Jain,
Minal.
I think Dr. Jain is looking for the mic.
Enlightening talk, and when you talk of something in type 1, it's always attractive because we are very helpless near those patients. And one question is, how far for Indian patient, say it a immunotherapy or say it a cellular therapy, a monoclonal antibody directed against CD3, how far in our patients, average Indian patients, this is going to be giving them hope and a direction in the future therapy. What is your assessment at the type 1?
So that's a very, thank you for the question, but that's a very bitter question. And I will have to take it with a pinch of salt, because what we are talking in Indian scenario, we are still far from even offering them HbA1c, which is a 500 rupee test with a good lab. Thyrocare and local labs are doing it even in 150 rupees also. So again, that is far-fetched dream still. Even making insulins available and glucometers available is a far-fetched dream. So that is where we are working at present. Because talking of Lentidra, the launch price is 3 lakh USD. Okay, so that is 3 CR or 30 something around that for the Indian patients. So 3 lakh USD is the cost of the molecule. So thinking of the Indian population, Indian patients, as of now, if we can only make them aware and enlightened about carb counting, about the right dosing of insulin, about even SMBG, that would be a great achievement. Then our second step journey would be screening the siblings, or at least offering them and catching early, because these all work when we catch them pre-diabetic, like in the stage 1 or stage 2 of the diabetes. So it's a far-fetched dream, but the horizon is there, like sun is there.
Something exists.
It does, it does.
Yeah, in classification or in management, if we can name few molecules, that's the hope.
It does. Thank you, sir. Thank you, chairpersons.
Dr. Meenal, can I ask one thing?
Sure, sir.
That we have a phase of honeymoon phase in
Yes,
type
sir.
1 diabetes where they have partial remission of beta cells. Can there be any chances or any methodology where we can extend that honeymoon phase in the favor of type 1 diabetes? There are few papers also.
Yeah, very true, sir. Very true. Exactly, that is what we are talking probably. That if we can catch them during that phase, where we still have beta cells, which are not, all of them are not like they're not already gone into apoptosis or necrosis. They are still rejuvenating, and they can be prevented at that point of time. So right now, in Indian scenario, I'm sorry, but yes, looking at these molecules, like there are newer molecules like teplizumab is on the horizon, or the newer molecules are on the horizon, maybe that is the time when we can catch them and we can treat them and give them the benefit and prevent the remaining beta cells from dying.
What I got when I presented this honeymoon phase in Hello Diabetes, when I got in the literature, there was gender bias also. Females suffering from honeymoon phase have a better longevity of honeymoon phase, and up to 13 years to 30 years also honeymoon phase has been seen. If you Google that, 13 to 30 years they have honeymoon phase. So
Very selective cases can be there, I'm not denying, but ideally speaking, honeymoon phase lasting for years is something which is, as of now, I'm not very much aware of it, sir. So very selective cases we all have, one or two exceptions we all have.
Thank you. Thank you.
Right, thank you so much.
Ma'am, I have one question.
Yes.
Actually, I am a GP, so many a times when I come across diabetic readings with the patient who are very young, less than 25, my first confusion is whether it's a MODY or whether it's a type 1 diabetes or whether it's a type 2 diabetes. So I want you to give some message for the GPs because most of the time I have to refer such patients. I cannot start metformin right away. I don't know how to go ahead. And when I send them to bigger hospitals also, they most of the time they just right away start insulin. So what is your message to the general population for this?
Okay, thank you, ma'am. That's a wonderful question, and that is right, actually the clinical scenario question that we should be discussing because this is far like beyond insulin is a very big dream. So very, very correct and very relative, very relevant. So a young patient coming to your chamber with a blood report, with blood glucose, whatever XYZ. So first thing is you will look at the level of the sugars. Type 1 or a LADA variant will have very high sugars as compared to a MODY presenting to you. Similarly, a type 1 or LADA presenting to you will be quite lean, thin, and will be a lot of insulinopenic condition, what you talk of, will be clinically quite obvious. Whereas a MODY presenting to you clinically will be a bit on the healthier side, like well built. You will not be such muscle deprived and a very lean patient. Then coming to family history, if you take, the type 1 LADA will give you a negative family history. Whereas a MODY will give you a very relevant 3-generation history. My father, my grandfather, and all of them having diabetes at the same point of time around 25-30. So that is very, very significant. The moment a patient tells you, my father is non-diabetic, मेरे घर में मेरे पूरे खानदान में किसी को diabetes नहीं है, then you don't think of MODY. Then you think of type 1 or LADA. Then if it is LADA or type 1, then you think of maybe it is not even autoimmune condition, it is just an insulinopenic condition or maybe an early onset of type 2. So if you think that the sugars are not very high and you want to err on the wrong side, like err on the insulin side, then anytime you can switch over to the tablets. Send one in C-peptide level and send one, if the patient is affording, you can also send GET65, the antibody profiles. If the antibody profiles are positive, you have no confusion exists. It is a very clear case of either LADA or type 1. If it is below 8, the child is presenting below 18, then of course we will label it as type 1. If it is presenting in the early adulthood, we will label it as LADA. Then if the antibodies come out to be negative, there can be pan-antibody negative type 1 also. So you keep that in mind, but to avoid confusions, if the C-peptide is very, very low, even if the antibodies are negative, you will treat the patient on insulin only. So
Right.
err on the insulin side.
I think we'll conclude
But
here.
clinical cases over.
Constraint of time, and thank you,
Thank you
Dr.
so
Vinod,
much.
for this wonderful session. And may I now have the pleasure of inviting Professor Dr. Jayant Panda and
correlates. Every 10% increase in time rate is directly related to 0.8% of agency reduction. And how tighter we get into time rate, that is much more important. So this is in the background of guidelines we know what real world as well as the study for they set study which for typhoon is represented they would talk plenty of things to control the agency. In real world, what is it around? Less than 7% in Asia, Eastern Europe, Western Europe, as well as Latin America and Western Middle East. Is almost 1/5 of the typhoon France population. If we see individualized target, even less than 1/5 of the target match. That's why the real what we need to see is really the what are the barriers to achieve this HUNC below 7. So that will be biological challenges, whether it be in insulin absorption or actions, hormone fluctuation during puberty or pregnancies, even socio-economical or environmental changes, that includes access to healthcare, resources, cost of medication or diagnosis, even health literacy and education jobs. These are the barriers to look locally. The psychological barriers, fear of hypoglycemia, diabetes, mental health issues like depression and anxiety. Even technology barriers could be the limited access to continuous glucose monitoring or insulin pump in certain part of the world. And that's why we could be the responsible around. So if you still think of doctors, or is it a person with diabetes, or is it drug or the industries available to the access? But when we thought of what is base glycemic control system in universe, is in human physiology. If we make it to the base action to base physiological factors, that could be much more appreciated to get to the success of A1C reduction by 7%. So what will be the success strategies and innovations? So personalized medicines, individual treatment plans based on socio-economic factors as well as lifestyle and behavioral factors are important in the background. Technological advancements, SMBGs, CGMS, insulin pumps, automated insulin pumps, even artificial intelligence and machine learning tools predicting glucose trends, educational activity and empowerment. So structured diabetes self-management education and support program are in all line. Here support groups as well as psychological counseling. Making this approach, coordinating with all practitioners as well as educators, dietitians and psychologists. So when we talk about diabetes structured monitoring and education support program, then it is primarily required at the time of diagnosis, really, or when the individual is not matching up to the targets, or patient is transitioning from one therapy to another therapy, or even the complications to surgery. So at that time, not only education is important, along with that education monitoring plays a vital role to educate those individuals to further learning. So self-monitoring blood glucose based on individual situation of patient, combined with adequate analysis on diagnostic data, can support therapy optimization as well as desirable behavior changes. And now we have connected glucometers with comprehensive digital solutions. And that is even evidence in meta-analysis as well as systemic reviews that have shown improvement in HbA1c as well as particularly those that have provided feedback loop mechanism with individuals and the doctors that have much better outcomes. So these can be contributed. What are the scientific background we have? Almost 6 months study showing the reduction of HbA1c in this glucometer better way in these individuals. Even the point in range of these individuals has improved over 6 months from baseline, and even point above range has increased in these individuals. There are specific indicators to measure the bigger time and just keeping on that path. What are the glycemic variability and mean blood glucose? Specifically focusing on type 1 individual, mean blood glucose has increased over time as well as glycemic variability also reduced, and HbA1c reduction by 0.3% is much more appreciated by monitoring in these individuals. When we talk about time and range, it's so easy for the patient and directly in a real-time manner they can entering on the up and down. So there is a specific reporting. But when we see the outcomes in real world clinical trials and meta-analysis by using this continuous glucose monitoring system, the A1C reduction by different clinical trials, meta-analysis and real world evidence, even decrease in hyperglycemia, increase in timing range, and decrease in hospitalization, even improving quality of life as well as satisfaction
Please notice, even abstinence has been decreased. So we start of education, then monitoring, now coming to the insulin therapy. We know behaviorist therapy has been pushed forward for type 1 care and that is standardized for all type 1 individuals. So multi-daily insulins, multi-dose insulins with long-acting analog as well as rapid-acting analog or ultra-rapid-acting analogs gives flexibility as well as lower risk of hypoglycemia. Considering that at a base level, when we order insulin pump without optimizing that adds cost, but when we order insulin pump with threshold predicting lower glucose suspension, provides flexibility as well as lower risk of hypoglycemia. When it is hybrid closed loop technology that gives more flexibility and lower risk of hypoglycemia. That adds to the patient level, the compliance and this transition from multiple level decision making to a simpler level decision making is possible. With the transition of technology, the sensor augmented to automated pumps. There is a comparison of real-world observation study for type 1, the different treatment modalities, but multi-daily injections to automated insulin therapy, the time and range has increased, along with the decrease in hypoglycemia and other range increase is noticed. So the transition is significant, and that's why the smart gap technology has played wonderful role for prevention of hypoglycemia and making them to the range by adjusting the basal when it falls and by increasing the basal when it needs. So ultimately, optimization has given the better care for those type 1 friends to touch or to reach near to HbA1c 7. The minimum still 75% of patients or friends with diabetes are still having A1C more than 7. And we have those challenges. So adjuvant therapies for type 1 have been looked on, and this is one of my work from UBMD. The proven as well as metformin, SGLT inhibitor, GLP or triple therapy. When we talk about promoting, it has a reduction of A1C by 0.4%, but it increases peaks in type 1. When we talk about metformin, yes, it is short-term HbA1C reduction, but the initial dose requirement is slightly decreased, not so significant. When we talk about SGLT inhibitor, and we have plenty of trials in the background, when we talk about the direct one study, where we work on the A1C reduction over 24 hours, sorry, 24 weeks is significant. Even the percentage rate of total daily insulin dose is also 10 to 14%. Ultimately, over 52 weeks, the A1C reduction is 0.5% along with weight loss benefit in type 1 adults as well as decrease in insulin dose 10 to 13%, and in the immunities increase in the decay as well as general infection. Now coming to GLP agonist. Liraglutide in type 1 along with insulin. How this CGM shows the impact, how with liraglutide the CGM converts into time and range. So now first prospective randomized control trial immunoglobulin liraglutide in type 1, where then 72 were randomized, 63 completed with A1C reduction with 1.2 or 1.8 by 0.8%. Even the time in range 70 to 160 increased in percentage ratio. Even other range decreased along with insulin dose requirement decreased by 10 to 30 units per day. Post-standard glucagon change in type 1 over 0 to 12 week in 1.8 milligram liraglutide and gastric emptying billing from 0 week to 12 week with 1.2 and 1.8 milligram. So that will be further evaluated with adjunct 1 and 2, and then see that negative versus positive levels for screen and used for, and when we say that see that positive has a better response than negative. Even semaglutide in type 1 evolution and we are documenting it. So triple therapy. Now insulin, GLP, SGLT, what are the steps? Yes, specific trials are required, further regulation with under constant monitoring. Insulin therapy is not sufficient. We know that type 1 to touch up to below 7, SGLT, high risk with decay, GLP-1, clinical benefits but not label medication, all people will be evaluated and for specific C-peptide positive. So I will share a case, different case studies on the line to represent how we can reduce to 7%, different patient profile. A 16-year-old patient achieved HbA1c when he was in basal bolus and shifted to CGMS and insulin pump. So this is in the background when we went through a randomized clinical trial data. where it showed the baseline as well as studies, so observations. So baseline to study for 780G, their time in range improved with 780G much more better than it is monitored. So we shifted this behavior individual with the sensor monitored, the real-time sensor asked him to go down the insulin pump. We continued with the insulin pump and then further changes benefits getting into the range and then automated insulin pump initiated. And that's how he gets into the well 100% time range consistently and improves the average glucose over time. In the pregnancy, planning for pregnancy or lower resource settings, the project is number maintaining with medical social communications, they are taking care in federal level. So these are all different forms of diabetes getting through pregnancy and monitored over time. And that's the background for Make My Life project in our life. So emerging trend and future perspective could be one line in that Dr. Miller has put 100 words in the background. So next generation technologies, innovation, formulation, global initiative, visions, future research directions could be important. DSMEs we need to close. That's it. DSMEs with Project Krishna, evaluating the sensory research which involving the reconditioning. That's what appropriate behavior for sustainable impulse control or sustainable behavior and lifestyle modification have been tried with clinical hypnosis. And this is in one of the line. We know global collaborations of Indian as well as Simplera, CGM, where other than CGMs are other than mechanics are getting collaborated, and further we have here it's a scope. Obviously, Dr. Miller talked about non-elantic and that's all the further scope, but it is how we achieve agency without hyperglycemia is in line. So ultimately, type 1 care is not only patient and doctor. It is a whole health ecosystem and it is consistent effort throughout the life. And there are values of empathy, empowerment, and evidence-based to be put forward, along with all stakeholders pursuing for excellence. So collaborative work in research sharing infrastructures is important in a key note. And the reality check is, yes, those achieve agency may have the right access of tools and support system, but call of action is patient education, advocacy, and equitable access to diabetes management technologies. There is more research and collaboration to make goal achievable, and that's where we all can part into. And final thoughts, HUNC is controllable, control is attainable with continued innovations, confidential care, and patient empowerment. Look forward to it. Thank you.
Thank you, Dr. Patel, for a wonderful session, and because of the lack of time, we will take your questions to close this session, and we invite all speakers to please come up for your focus session. Yes. May we invite Professor Gorex to please come.
Do you want to come on stage?
I'll sit down here. No, I'm okay. Same height.
You were able to see my everyone? Yeah. Would it be comfortable? Now, the chair, our next session, I would like to invite on stage Dr. Devashish Das and Dr. Jayan Pandya. We encourage our delegates to engage further with our speakers. If you have any questions or thoughts to share, please hold on to them until the meeting. Our speakers will be available for further question and answer session. We will compose the inquiries and delve deeper into the topics discussed. Would you want to say over here?
So good evening all. Without any delay, we'll go to the state of the art lecture. You know, the state of the art lecture is not any other faculty than Dr. Bhurashkar. When Dr. Bhurashkar is speaking, it's a legend speaking, it's a heritage speaking, and we are all excited to listen to it. And the topic is also very important and appealing to all of us. We know that vitamin D has made its place. And I remember Professor Shashank Joshi conducting the RSSGI in this property where we had Dr. Holix who spoke about vitamin D, 150 slides, maybe 20 years back. So today, Dr. Bhurashkar will be speaking about vitamin D in pre-diabetes. Like vitamin D has many, the needs of vitamin D is also equal to needs of pre-diabetes. Doubt that what is there in the vitamin C, what is there in pre-diabetes. So correlating both this state-of-the-art lecturer by Dr. Bhurashkar on the role of vitamin D in pre-diabetes. I request Dr. Devashish to introduce Dr. Bhurashkar and start the session.
I don't think we need sir introduction. Everyone knows sir. I think a lot of students of sir are also present here. Dr. Anil works as a very senior consultant physician and diabetologist, has trained a lot of students in the field of diabetology. Over to Dr. Anil works, sir. Sir, please.
Am I audible? I thank the organizers for inviting me to a very important subject. I was going through Dr. Patel's presentation, the previous presentation, and I have to tell you when I tell my students that remember, 90% of the practice, medical practice, is in the hands of 10% doctors. Now, either you want to become one of these 10% doctors, the remaining 90% doctors who are studying. The key to this is a simplicity. If your prescription is simple, understandable, available, economical, then you have all the crowd in the world. If you are very, very scientific, and what Dr. Patel has said is fantastic. I'm very impressed with this. HbA1c and this and all that. I always tell my students, there are 80-90% medical students, they are great writers. They publish in journals. And there are 10% Indians like Dr. Bhurashkar. They have 90% of the practice. So how do you get that? By simplicity. Dr. Rahega and I used to talk about vitamin D 30 years back. And people laughed at us. But today, let me tell you, there are 1,475 registered trials in the United Kingdom
on role of vitamin D in prevention and management of type 2 diabetes. Now, I will give a simple formula that you can follow. Vitamin D is the one which we are from childhood familiar. We knew about vitamin D because I was from a Marathi medium school and the research was called a very phenomenon known as Murgus. But we were so touchy and we felt that we will get Murgus with DRS if you don't take vitamin D. And without any education, my mother, she used to give me corn I used to drink it. Only because the picture was in front of me, Murgus. So vitamin D role has been taught to us for last several years, which is again I am doing that. Very economical medicine must be one of the benefits of this. Now, rural diabetes and pre-diabetes. This slide show, can you put the slide show? Yeah. Put the slide show. Now, role in diabetes, pre-diabetes and associated comorbidity. Very important. You also realize what is going on. Slide show. Now, what is the objective of this presentation? First introduction, role of vitamin D in diabetes, pre-diabetes and associated comorbidities. Daily requirement of vitamin D, you must know that. One of the commonest cause that we see in emergency is people, one very young doctor, 3 sweet usually, tired, shirt, nice coat, but forget to wear his pants. And it was a commotion because he was taking large dose of vitamin D injectable. Because somebody told him, and when he did his serum calcium, it was 14. So after gaining cause of hypercalcemia is excessive dose of vitamin D and particularly injectable. So daily requirement of vitamin D was wrong. Daily vitamin D deficiency wireless outpatients, source of vitamin D serum levels and hypervitaminosis. Now, vitamin D insufficiency is linked to areas insulin release, insulin resistance and type 2 diabetes. Vitamin D levels are associated with lower risk of developing diabetes in pre-diabetic individuals. Vitamin D supplementation can reduce the risk of disease progression pre-diabetes in pre-diabetes individuals. And 3 trials showed that vitamin D supplementation lowered the diabetes risk by almost 15% regardless of initial vitamin D levels. So prevention, treatment and prevention of complication, all the 3 things are achieved by one single medicine, that is vitamin D. You realize that in diabetes and associated comorbidity in the cardiovascular disease, kidney functions, obesity and metabolic syndrome, and immune modulation. Now, vitamin D mechanism of action. First is vitamin D is made in the skin by the skin cells that cannot rely on vitamin D from blood. Because DNA damage and then DNA repair is achieved. Vitamin D3 cholecalciferol taken directly into cells for local conversion and use. Most potent form of endothelial stability, anti-inflammatory, form needed breastfeeding mothers to transfer to baby through breast milk must receive daily dose due to short half-life in 24 hours. It's a short half-life, so you have to take a proper dose. Then, 24 hydroxylation is a calciferol. It's measured in blood as vitamin D status. Taken directly into cells and converted into 125 cholecalciferol for local use as a signaling molecule in muscle cells, including immune, brain, blood cells, heart, lungs, and many more. अभी देखो, see the versatility of this single compound. Alpha hydroxylase, which converts into calcitriol. Now remember one thing. Hormonal vitamin D. Vitamin D is not a vitamin, it's a pro-hormone. That pro-hormone is 125 calcitriol. And it regulated by parathyroid hormone for blood calcium control. Calcium absorption in the gut increases, bone turnover increases, and calcium in the blood rises. This is the most active form of vitamin D, which is a pro-hormone. Now, specific challenges usually absorption in South Asians. South Asians, my mother will not agree, but she said, "Amsa Munga Vijay." This is one terminology when you can't call somebody fair. When mothers like their children to be fair, they will not say, "Ki mera ladka kali hai." Basically, we are all kalis. Remember that. You know, we are kalis. What is this kali? What is the problem of kalis? India is a tropical country, abundant sunshine. In Vidarbha, the farmers are there in the field for 18 hours. Absolutely. Vitamin D, 11, 12. Why? Because the enzyme that converts ultraviolet rays under the skin, that enzyme is lacking in pigmented skin. And then we use tinted glasses, sunscreen, because we have to preserve our complications. Hardly we exposed in the sunlight. सकाळी सूर्याची किरणे आम्ही घेतो 7 वाजता. Yes, sir. You have to stand in the sun at 11 o'clock in the afternoon in terrace. This has boomerang on me many times, because when I go lecture to a very high-profile doctor, CEO of a company, I said, you have to stand in the sun between 11 and 2 in the afternoon. So he made it compulsory to all staff to go up on the stair on the 11th floor and we do physiotherapy exercise. Between 11 and 2, 50% of our girls reside at company. Some people take it too much. When you talk science, you see the opposite person's IQ. Please remember that 90% Indians which is lower than animals. That's why they elect this kind of government. Because the prevalence of vitamin D deficiency is very high in India in spite of abundant sunshine. There is no shortage of sunshine, but we lack that enzyme. Now, the challenge with vitamin D deficiency, it can be asymptomatic. Many times, there are no symptoms. It may cause symptoms of low back pain, headache, joint pain, dizziness, muscle weakness, neuropathy, arthritis. Now, believe me, 50% of my female population have these complaints, which I even don't pay attention to them. When these complaints come, I do 2 things. I do the vitamin D level and I do the thyroid level. Hypothyroidism is a third common condition of obesity and diabetes. And all these weight symptoms, तीसरी डिफरेंस 317 किलो 1 टैबलेट ऑफ एल्ड्रोक्सिन इतना खर्चा करके डॉक्टर हमने सिर्फ 10 रुपए का बिल दिया बिकॉज तीसरी डिफरेंस कॉस्ट फॉर 2 years therapy of hypothyroidism. That's another problem. Now, obviously, algorithm for clinical strategy, managing individual vitamin D, this is for your reference to show that I have studied for this lecture and I am not having that. I am not going to spend much time on that. Now, sources of vitamin D. Vegetarians, milk and humans. Animal, fatty fish, egg yolk. Cheese, mushrooms, beef liver, fish liver oil. Now, it's very interesting. To get your daily requirement of vitamin D, you have to drink 20 glasses of milk and 10 egg yolks. With 20 glasses of milk, even a man will start lactating. And 10 egg yolks, you will start looking like a big fat head yourself. So not practical. It is just not practical to rely on your food resources to give you daily supplement of vitamin D. And therefore, simplest thing, take a tablet and forget about it. Company university where I think they will teach me when I leave this place. Daily requirement of vitamin D, infants, children, adults. So basically vitamin D is given for insufficiency, for sufficiency, for efficiency. Please remember, fracture prevention dose is much higher in elderly. The almost daily requirement is 1500 to 2000. Elderly 1500 to 2000. In elderly, if the renal functions are normal, you have to give high dose. Now, physiological challenge of vitamin D, severe deficiency less than 25, moderate deficiency 25 to 50, insufficient, sufficient, optimal, increased levels of more than 150, usually doctors are 50, no? Overdose more than 250, intoxication 375. It's interesting. I've seen people like that. And many of them are very high profile doctors. Vitamin D dosage. This is the dose standard recommendation. Now, mechanism of action. It regulates beta cell survival, insulin secretion, and calcium level. All three important functions. Protects beta cell from dysfunction. We have ATP, T cells, and B cells mediate the protection. Vitamin D support proper calcium blocks. We also realize that vitamin D status in diabetes risk. 10.5% has vitamin D deficiency. Type 2 diabetes incidence of 16% deficiency. Risk of type 2 decreases as vitamin D increases. Remember that. The risk decreases. We raise the point, Dr. Patel. We can actually reduce vitamin HbA1c by vitamin D. If someone will ask you to type in the vitamin D, insulin को लपड़ा पड़ना था, why? Insulin, monitoring, HbA1c, antioxidants, सब तुम्हारा फायदा तो फार्मा कंपनी का पेशेंट लोग में. Remember that what helps patient is a cheap medicine, no good medicine. Vitamin D status pre and post menopausal women is very important. Vitamin D supplementation, diabetes prevention, combined daily intake of more than 800 units and 1 gram of calcium. A lot of people calcium को लिखा है मतलब दूध, dairy products are fine. Again, our friends, cholesterol lobby is very strong. Statin lobby has got 3 senators in America. Can you imagine that? And this country, statin lobby has been shouting on cholesterol. For what? Cholesterol is a very important product. Again, cholesterol is bad, never ever take it. Sugar may murder you. Make sure to avoid it. So let your life be ordered by each documented fact and have malnutrition that agree with that. We have a pharma impact of vitamin D supplementation and glycemic control, very well known. Vitamin D in pre-diabetes, again a very big boost. Vitamin D supplementation in the pre-diabetes with the individual with pre-diabetes low serum levels can promote further deterioration in glucose intolerance and clinical evidence that I'm not talking through my own head, this is evidence. मेरे देखो मतलब में बाप बापों में तो शब्द कर हमारा बाप है systemic review of meta-analysis, very authentic. Vitamin D supplementation and gastric control, vitamin D supplementation and treatment of hypervitamin, very important. These patients will come to you and the first thing you will do is hydrate the patient, saline then butler, keep all the dairy products out, and you can do calcitonin, specific innovative CP2 and induction of non-specific liver cytochrome P450. Endocrine Society guidelines, multiple, sorry. Hypermetabolic treatment you please lead to me. Now that's however, I want to take the questions at the end. No, you see, no, we will go back to that slide. We can. Okay. Slide. Oh, slide is a public property, that's not my pursuit of it. Slide will give you. Sure. But I'm glad, yeah, thank you. Now, understand society guidelines. Remember one thing. Remember this society's meet, no? Indian society, physicians India, diabetes का कुछ 25 सोसाइटी है मेरे दर्जन करता है कि ये सोसाइटी की मीटिंग में when they will lower the lines between basically 140 80 then say 130 80 then say 120/70 then for the hypertensive severement is 110 please by the time I get there people will call me to the hypertension. You understand? So the society guidelines are only for the office bearer of the society. They are not for you people. Huh? You listen to me. Thank you. Such a lucid and a good presentation. I'm sure there is no question and answer.
Actually, not only Dr. Anil Bhurashkar has told you about the vitamin D, it is correlated with the metabolic problems, especially the pre-diabetes. And we are, as I had started, many things unknown about these two things. One is vitamin D, one is pre-diabetes. We are not sure how much of complication creeps in and what is the risk for developing flying diabetes. And also vitamin D, how much helps us in prevention of metabolic diseases and the dose and all the factors that Dr. Bhurashkar has given. Let us give him a standing ovation, such a senior teacher, and take care the topic so humorously. Thank you. And as Sarah already told you, it was very lucid, very informative, and there will not be any question. No, we can hand for I request the devices to close the session. Thank you, sir. Thank you very much for coming. Now, I will take the pictures. I call all the speakers. So this is only one. We'll give memento to sir. I have to tell you, my friends. You see, actually,
Senior physicians and Indian doctors are also victims of therapy. Today you see me at least walking in the water, but I am an unfortunate victim of my cardiology because I have written fibrillation and a lot of problems hypertension now. Because 80 milligrams of statin. With that, within 6 weeks, I developed a rhabdomyolysis of both my proximal muscles and quadriceps. Then I got a lot of orthopedic surgeons who operated my knee twice for replacement. Statin, particularly, let me tell you one thing. Statin has helped some people, there's no doubt about it. But 80 milligrams of statin with phenylhydrin drugs which are given for liver cell factors is not a safe drug. So you have to revise your statin prescriptions. Be very judicious, use it when required. If you want the yield absolutely low, But statin can cause a lot of problems. And one other thing which can reverse statin-related myopathy is vitamin D. Again, many times when the CPK is high and you have a control muscle of grade 3 power, you use high dose of vitamin D for 6 weeks and actually bring a reversal of this myopathy. So please just forward. Thank you.
Thank you so much. Thank you so much, our respected chairman, Dr. Bhaskar, for this amazing lecture. Now, comments. Now to commence the final session, our final session for today, I'd like to call upon the stage to chair the session, Dr. Varun Punita, Dr. Subhashri Patil, and Dr. Amal Pandey.
Slide. Sir, correct.
Okay, so now we go to the next sessions, and the first this topic of this session, the first topic is measures to mitigate GLP-1 receptor agonist and SGLT-induced adverse events. So we are like SGLT inhibitors and GLP-1 receptor agonist, the picture on the right. So we have to know the adverse events, how we can mitigate the adverse events, and for this we want to speak with Dr. P.T. Singh.
So, very good evening, everybody. Thank you, Chairperson. And first, I would like to thank Dr. Manu and Dr. Purvi Chawla, DRS team, and the WCP for inviting me here. So, today I'm going to speak on material measures to mitigate the GLP-1 receptor agonist and SGLT-induced adverse events. Can you have the slides, please? Yeah. So the floor of the discussion will be positioning of the GLP-1 RAs and SGLT2 inhibitors in type 2 diabetes management, the clinical concerns and adverse effects associated with the use of GLP-1 RAs and SGLT2 inhibitors, poor patient compliance due to adverse effects, and measures to avoid the GLP-1 RAs and SGLT2 inhibitors adverse effects. We know that these are the novel anti-diabetic agents and they will change the management landscape of type 2 diabetes by shifting the focus from a glucocentric approach based on choline and glycemic control to a patient-centric approach based on extraglycemic events, complications like atherosclerotic vascular disease, and the CKD. In addition to the cardiovascular protection and glycemic protection, there has been significant increase in the use of these agents. Not only that, the FDA and the USDA recommendation also suggests that for diabetic patients with cardiovascular risk reduction, along with glycemic lowering, the GLP-1 RAs and SGLT2s are the preferred agents. Even for renal protection or in patients with CKD, these classes are recommended. Additionally, the scope of the use of SGLT2 inhibitors are also used in patients with prior heart failure symptoms. We know that GLP-1 is a class of injective as well as oral now in India, antibiotic drugs that improve the glycemic control and many other atherosclerotic related parameters in patients with type 2 diabetes. However, the use of this relatively new class of drugs may be associated with certain adverse effects. Concerns have been expressed regarding the effects of these drugs on pancreatic and thyroid tissue, since animal studies and analysis of drug databases indicate an association of GLP-1 with pancreatitis, pancreatic cancer, and thyroid cancer. Several meta-analyses have failed to confirm a cause-effect relationship between these two and the development of the adverse effects. So these are the principal adverse effects of GLP-1 mainly, most of the patients have GI disturbances, which are nausea, diarrhea, vomiting, dyspepsia, and constipation. There are disturbances of hypoglycemia, especially when it's combined with insulin or sulfonylureas, because of the potential accompanying of the GLP-1 insulinotropic effect from its glucose dependence. Elevated pancreatic enzymes giving rise to potential inflammatory responses in pancreatitis, injection site reaction, and pre-renal acute kidney injury. Gastrointestinal disorders were the most frequently reported adverse events during the clinical trials of GLP-1 Among these, nausea and diarrhea were very common, whereas vomiting, constipation, abdominal pain, and dyspepsia were relatively common. The frequency of these adverse effects was more pronounced at the beginning of the treatment and then decreased gradually as the therapy continued. Nausea is one of the most common adverse effects reported with the GLP-1 up to 50% of the patients being affected. And most of these patients have mild to moderate episodes of nausea, which seem to be dose dependent and diminish with ongoing treatment. This is the burden of GLP-1 adverse events. Several phase 3 clinical trials of semaglutide had patients had occurrence of nausea almost 11.4 to 20%. Sustained sleeps also reported semaglutide showed a nausea of 5.1 to 23.2. And almost 20% of the patients discontinued semaglutide because of GI complaints. Meta-analysis by Sun et al. Showed nausea and vomiting up to 37.13%, and 11 post-hoc analysis of liraglutide also showed the discontinuation rate of 1.4% for nausea and 0.7% for vomiting and diarrhea. The real-world study by Young, that is the data from FAERS, showed a proportional reporting ratio for malignant pancreatic neoplasm related to GLP-1 that was greater than 2. There is a possible association of GLP-1 against treatment with pancreatic inflammation and pancreatitis. And evidence from animal studies indicated the potential harmful effect of these drugs on the pancreatic tissue. Generally, there is no direct cause and effect relationship that has been shown in GLP-1 in pancreatitis. There is several recent studies and meta-analyses that fail to show an increased risk of pancreatitis with the use of GLP-1 and meta-analysis of 55 randomized control with almost 32,000 plus patients showed no increase in the risk of pancreatitis with the GLP-1 as compared to the controls. So this is the data from 7 seniorities which included 56,000 plus patients in patients with type 2 diabetes, which looked out for acute pancreatitis and pancreatic cancer, and this suggests that there was no observed increased risk of pancreatitis with the GLP-1 except that cell harmony in the uterine tract showed that liraglutide and aldehyde. Again, hypoglycemia again, the combination of GLP-1 and metformin has not been associated with an increased risk of hypoglycemia. However, in humans with sulfonylureas and insulin, although the risk was very low, but nevertheless it was increased compared to placebo. Diabetic retinopathy is one of the very common complications of diabetes. The progression and development of diabetic retinopathy is associated with several risk factors, including the duration of diabetes, poor glycemic control, and poorly uncontrolled hypertension. The effect of GLP-1 on DR is controversial. On the one hand, it has been shown that GLP-1 receptors are expressed in the human retina, and studies have suggested neuroprotective effects of GLP-1. On the other hand, certain GLP-1 have been likely to be associated with an increased worsening of DR, which is a common phenomenon of paradoxical worsening of DR upon initiation of the therapy. So, sustained trial with semaglutide showed a high rate of retinopathy. So, these are the propensity score matched, unmatched odds of DR progression of GLP-1 versus SGLT2, and both showed no significant difference in the worsening of the retinopathy. Very uncommon, but the GLP receptors revenge trials report after respiratory UTI. Nasopharyngitis, influenza, cystitis, and viral infection are also commonly reported with these drugs. However, again, no cause effect relationship between the two. So the key takeaways is GLP-1 RAs are useful drugs for the treatment of patients with type 2 diabetes. These drugs improve the glycemic control and many of the atherosclerotic-related parameters. However, concerns have been expressed regarding the effects of these drugs on pancreatic and thyroid tissue, but current evidence suggests and meta-analysis do not have a cause-effect relationship between the two. And the ongoing future trials are needed to assess and clarify whether the overall safety of the profile of the GLP-1 receptors. Now, coming to the SGLT2 inhibitors, which are very commonly used, I'm sure all of us are using this. Multiple evidences point to the risk-benefit profile of SGLT2 inhibitors and suggest optimal prescribing of these agents while fully understanding the risk. The benefits being the lowering of the A1C, weight loss, decreased BP, decreased knee incidence, decreased heart failure hospitalization, and renal protection. However, major adverse effects associated are genital infection, very common, DKA, amputations, skeletal fractures, volume depletion, and acute kidney injury. So, a lot of meta-analyses have shown that SGLT2 inhibitors were significantly associated with 5-fold increase in the risk of genital myocardial infection. Fralic et al. And Canvas program again showed a increased risk of DKA in patients with on SGLT2 inhibitors, especially in people with type 1 diabetes, especially in acute stress, illness conditions, and people who are insulin-dependent. Canvas showed a higher risk of lower extremity amputation than those receiving placebo. Of course, the analysis from the EMPA outcome EMPA showed a lower limb amputation occurred in 1.8 versus 1.8 in placebo. So maybe cannabis is more prone. People who are taking cannabis should avoid, especially if they are having peripheral vascular disease or previous history of amputation, should be avoiding cannabis. And skeletal fracture and volume depletion are in higher with cannabis. There is a possible association between SGLT2 inhibitors and acute renal failure. Most reported incidences occurred within 1 month of starting therapy, improved following discontinuation, although some individuals require hospitalization and dialysis. Volume depletion, hypotension, or concomitant use of other nephrotoxic medications could have contributed to the acute kidney injury. An analysis of SGLT2 users and non-users in 2 different cohorts showed that the risk of AKI does not increase with SGLT2 inhibitor therapy. Now, why we are talking about the adverse events is because we know that the patient compliance actually decreases if the side effect profile is worse. So there was a study done on almost 1,21,000 subjects. And the evidence to drug therapy of the first year was defined as the proportion of days covered more than 80%. Primary clinical outcome was a composite of insulin initiation, hospitalization from hyper and macrovascular complication, and all-cause mortality of the first year of drug treatment. In both the groups, evident patients experienced significantly lower incidence of the primary outcome and a significant reduction in hospitalizations were found on adherent patients in the GLP-1 RA group and not so for the SGLT2 inhibitor group. And higher adherence to the drug treatment of GLP-1 RA and SGLT2 during the first year of drug intake is associated with a lower incidence of adverse clinical outcomes in the setting. So this is again reflected by a study by Bryce et al., where we studied almost 4,791 patients, again reflecting the same thing. These are real-world persistent and adherence to glucagon like peptide receptor agonists among obese, commercially insured agents without diabetes. With the lack of time, we just summarize that high rates of discontinuation of non-adherence to GLP-1 RA and SGLT2 inhibitors highlight the importance of addressing the adverse events associated with these agents and implementing appropriate measures to prevent and mitigate them. Now, how do we actually avoid the adverse effects? So, there are basically 3 E's for the GLP-1 RA adverse effect management. That is education and explanation, escalation to the appropriate dose, and effective management of the GI side effects. You need to inform the patients about the potential side effects. Use the non-technical language for explanation. So, you need to talk to the patient in the new language, in the language to understand. Provide reassurance about the mild to moderate symptom. Always tell the patient when you start a GLP-1 RA that these are the expected side effects which will decrease with time. Offer advice on dietary and lifestyle modification. Discuss the potential management approaches. Adhere to a slow and gradual dose escalation. So, if you're using you slowly use 7 and 14 milligram, don't start it right away. Start with the 3 milligrams, step up to 7 and 14 milligram. Ensure the flexibility in the escalation for individual tolerance. Employ patient-provider interaction to reach a tolerable and effective dose, while accommodating for individual patient preferences for dosing frequency, side effects, etc. If they are having a short-term or a mild GI side effect, counsel on the dietary adjustment. Need to tell them to stop having spicy and fatty food. Ask them to have small nostrils, don't take too large meals, don't have too much of water, have some sips of water and to ensure that they do not take huge amount of meals after they take a GLP-1 receptor agonist. Advise on increasing fiber and water intake, monitor and potentially reduce the GLP-1 RA if the symptoms worsen. For a persistent or a severe side effect, you need to pause the dose escalation and consider the differential diagnosis, evaluate other potential causes of the side effects, maintain the hydration and dietary intervention. Even aula or ginger also help sometimes. Pharmacological treatment and consider short-term anti-emetics for GI symptom management. Utilize proton pump inhibitors or H2 blockers for the GERD management. You need to adjust the dose and attempt a de-escalation cautiously once the symptoms are under control. You can stop the treatment if the patient is too bad and switch to another alternative pharmacotherapy or consider alternative pharmacotherapy for obesity, and switching to alternative GLP-1 may be tried. About the genital urinary infection due to SGLT2 inhibitors, antifungal medications such as fluconazole or the application of a topical antifungal cream such as fluconazole or propanazole and specifics for 1 to 3 days is good. There is option of using fluconazole during prophylactic. The symptoms of genital urinary infections and how to respond to this should be explained to the people starting with GLP-2 inhibitors. Female sex and US history of genital thrush are the strongest predictors of genital fungal infection. Very important is to talk to the patients about good genital hygiene and fluid intake. Most of the things are sorted there. Persistent or recurrent infection may necessitate the discontinuation of the SGLT2 inhibitors. Caution is necessary when prescribing SGLT2 inhibitors in patients with abnormal urinary flow or bladder outflow obstruction. About the other side effects of SGLT2 inhibitors, I spoke about a decay. It's usually a glycemic decay, which means that the sugar levels are ordered, but the patient still in decay. But that necessitates a temporary discontinuation of the SGLT2 inhibitors in clinical situations that may predispose the patient to decay. Do not use type 1 diabetes in people who are dehydrated, in people who are having acute illnesses, in older patients, and if people having previous episodes of decay. Patients aged more than 65 years, they are at a high risk for developing DKI. Those who have shown insulin secretagogues or insulin when combined with the SGLT2 inhibitors should be done if the patient has a very good sugar control. If a patient is a known case of amputation or a PVD, appropriate monitoring is required. Occurs in many patients who have a history of peripheral neuropathy or peripheral arterial disease, and also managing hypersensitivity reactions like erythema, rash, pruritus, and angioedema. Discontinue the SGLT2 inhibitors and monitor until the signs and symptoms resolve. So basically, you need to actually talk to the patients while starting these patients on SGLT2 or GLP-1 RA. Have a shared clinical decision making. Be upfront about telling them the expected side effects. Ensure that they are properly hydrated. Ensure that the genital hygiene is very well maintained. Stay away from people who have recurrent UTI infections. They have recurrent UTI is something which is acute infection, 2 or 3 infections in the span of a few months, or at least 2 to 3 episodes of acute UTI which require hospitalization in 1 year. So to summarize my talk, GLP-1 receptor agonists and SGLT2 inhibitors are the novel agents in the management of diabetes and obesity. Empowering patients with knowledge about potential side effects and the importance of adherence can improve treatment outcomes and safety. And regular checkups and monitoring of key parameters can help detect and manage potential side effects. Thank you so much for your kind attention.
Thank you, Dr. Priti, for the excellent presentation. I have one question. Obese type 2 diabetic, 50 years high, already on metformin and SGLT2 inhibitor, higher risk of severe disease. He requires GLP-1 receptor agonist. There is a history of acute pancreatitis 3 years back. Can this patient be again started on this GLP-1 receptor agonist?
So a previous history of pancreatitis, I will be very careful.
Okay.
If the benefits outweigh the risk, maybe I will give it a try with careful monitoring of the lipase and amylases also. So if the patient is tolerating it well, and I start with a very low dose, have a close watch, close monitoring. If the symptoms does recur, I will not give.
Addition of a DP4 inhibitor to an SGLT inhibitor, does it reduce the risk of myocardial infections? Is one of the very good questions many people ask.
Yeah.
And there are, I think, some trials also on this.
Yes, there are few trials which suggest that addition of a DPP4 inhibitor with SGLT2 can decrease the GTIs and the UTIs. But usually, there are few enzymes in the bladder which inhibits the DPP enzymes of the bacteria also, which makes them a little bit less powerful, and which is why the chance of infection if SGLT2 and DPP4 used together should be helpful. Yeah.
Thanks, Shruti. Any more questions from the audience?
They are not those problems, so people have grown up in. The usual side effects, I feel it's because of lack of hydration, lack of poor, good genital hygiene. So that is primary. Although I would say there are 10 to 15% of the patients who bring all the roads still develop. So those patients probably I would withdraw the drug for a while and then restart and see if they develop it again. If they develop it again, probably SGLT2 inhibitors are not to be given to these patients.
Thanks, Shruti. Thank you. He was one of the educationals in various national universities. She has been a special it's really a pleasure now to introduce and work with plan for sometimes was again to introduce and change my talk.
Very good evening to one and all present here. Thank you, Amit, for this kind introduction. So let me at the outset thank Dr. Manoj, Dr. Purvi, and our whole DRS WCPD team for inviting me and especially giving me this opportunity to deliver a little hectic topic perhaps, which I always love to deliberate about. So this hair loss and diabetes. I will begin by saying what Shakespeare had said a number of centuries ago. In his farcical comedy play, The Comedy of Errors, Shakespeare said, there is many a man has more hair than wit. However, in today's contemporary society, some patients, even some people are so troubled by hair loss. Body that they might create good for more hair if given the opportunity. So what is the function of hair basically? If you ask me, the basic function of hair would be to prevent heat loss. But I think most important function is obviously it aids in what we perceive as a sign of beauty, and it gives us a lot of confidence. And measure of us, right? So that's why we have so many songs and stories and everything which has been mentioned, most number bars and pitchy sabun and all that. So that is how it is. So let me deliberate about this under the following headings. I'm sure almost all of you are aware of whatever I've been talking about. This is how it goes. So I'll discuss about in brief of course types of hair and growth cycle. Types of hair loss, also called as alopecia, connection between diabetes and hair loss. Interestingly, alopecia as a marker of insulin resistance and a predictor of early diabetes, also called as pre-diabetes. Then etiology of alopecia in diabetes, drug-induced alopecia, and finally, a little bit about preventive and remedial measures. So we have broadly three types of hair. Communal, intermediate, and gibbous. So communal, all of you are aware. Whatever coarse, large, thick, black or brown or whatever hair that we have over our head, face, eyebrows, etc. Intermediate are generally found in pubic and axillary regions, and village are those very fine hair which are present on our forehead, and nose, and earlobes, and tops of knuckles and toes. On average, we have about 5 billion hair follicles on our body, out of which about 1 lakh are present on the scalp. The rate at which a hair grows is generally about 0.3 to 0.37 millimeters a day. Mind you, everyone you lose about 100 to 150 hair a day. This is not a big deal. This is not hair loss. So please relax. There are some factors which can disrupt this growth cycle of our hair and reduce hair loss or alopecia. So far as hair growth cycle is concerned, we have three phases. Another, which lasts for about 2 to 7 years, during which the hair follicles grow. Caterpillar, which lasts for about 3 months. Here, the hair follicle is stagnant or remains steady, and telogen, the last phase, where hair follicles shed. So this is what it is, anagen, catagen, telogen, and the cycle goes on and on and on. Causes for hair loss in general. There are lots of causes, multiple causes, right from heredity, yes. There is hereditary predisposition. Some people go bad even during schooling or even colleges, early 20s, early 30s. And very interestingly, hair treatment itself can lead to increased hair loss. So we can imagine it happens, yes. Medications, there are multiple medications, antihypertensives, statins, as Dr. Buraskar was already blaming statins for lots of side effects, so this is also one of the side effects. But according to chemotherapeutic agents, which are used for treatment of cancer, they are majorly to be blamed. And there are autoimmune diseases like SLE, type 1, diabetes, thyroid disorders, that are also very closely associated with AGA, that is androgenic alopecia and all that. There are causes such as physical and emotional stress, so most of them are related to hormonal imbalances. Various diseases, aging as a process, it can be severity and not hair. So that is what it is. Broadly, we have two patterns of hair loss, female pattern and male pattern. Male pattern obviously is more prevalent because it is female. So we can visualize here. So what are the basic differences? Let's not go into the details. So far as female hair loss is concerned, generally it is of acute onset. In male pattern hair loss, it is gradual. And in female hair loss, it is generally reflected in wider parting. So the central parting that we have, that's actually I have not kept since childhood. So there is wider parting. And in males, what happens is slowly and surely, gradually, the top of the head. Then any hair is lost. Common causes of hair loss in women. Polycystic ovarian syndrome, PCOD. The women who are on oral contraceptive pills, pregnancy, menopause, usage of hair chemicals in hair color, and we can't do all without it, right? Even I've done that, and I've been doing this since a number of years. Yes. Alopecia areata, androgenetic alopecia, telogen of affluvial and again, flaxen alopecia, and binding of hair with lots of clips and pins and hairbands and tell me what. So all these and nutritional deficiencies of course can lead to hair loss. Broadly, alopecia can be reversible. Irreversible. Reversible is also called as non-cicatricial. So obviously it takes an emotional and physical stress on person's body and mind, hormonal imbalances, and hereditary OHA induced. Because that's very clear because there are no large-scale studies that have actually proved that one particular exercise is responsible for hair loss. There are case reports. So I will let you know about it in a short while. So, etiology behind alopecia and diabetes. blood sugar or very high blood sugar they can end up damaging the blood vessels. The microvascular, as I said. So those small blood vessels which are responsible to the hair follicles, they end up being damaged. This can lead to hair growth which slows down and then hair falls out faster than it can regrow. So this can lead to a notable loss in density and volume of the hair. Important feature is diabetes can trigger what is called as collagen effusion, which is the last stage. So the hair follicle which has to remain for some time, it starts shedding very early and very quickly. And this happens, this leads to excessive weakening and hair loss in collagen phase, which is caused by body's inability to produce insulin. Second cause is insulin resistance. Insulin resistance is implicated in alopecia. Why? Because it can disrupt the signaling pathway which regulates hair growth, which can lead to hair loss and thinning. It can also cause the hair follicles to reach the last phase, that is, telogen phase very early. This can again lead to hair follicles very quickly. In fact, some studies have found an association between androgenetic alopecia, which is called AGA, and insulin resistance. And some experts think that insulin resistance could damage white blood vessels, as I said. So it could be one of the manifestations of microvascular complications of very high sugar. While researching, what I found out was there were actually a number of studies. Well, some scientific studies have actually proposed that hair follicle characteristics, meaning thickness of hair, length of hair, diameter of hair, the thinner part, and so on and so forth. So these can be considered as the early marker for detection of early diabetes and even insulin resistance. Very interesting study, but of course it is beyond our scope of the lecture. Okay, drug-induced alopecia. Several drugs interfere with the normal cycle of scalp hair growth. And medications can lead to two types of hair loss. One is collagen effluvium and the second is anagen effluvium. Collagen effluvium is the commonest form. Generally, it appears within 3 to 4 months of starting the drug which could be responsible. It causes the hair follicles to go into the resting phase. And then hair fall out too early. Generally, people with collagen effluvium usually shed between about 30% to 70% more hair than is normally seen. Anagen effluvium, it occurs during the anagen phase, when the hair follicles are in that active growing phase, when mitotic activity is happening. So generally what happens, and this is particularly seen with chemotherapeutic agents which are prescribed to treat cancer. So they affect the matrix cells which are undergoing mitotic activity. So these mitotic activity that itself gets prevented or prohibited. So anagen effluvium is generally seen within a few days to weeks after taking the medication. It can be very severe. We have already seen so many pictures of it. People who are on cancer drugs, particularly these chemotherapeutic agents, they lose their hair, eyebrows, eyelashes, and other body hair as well. So far as drugs are concerned, metformin has been implicated and associated with hair loss. However, it could be that long-term usage of metformin, which could lead to vitamin B12 deficiency, as we all know, that could be responsible. But another school of thought is it is not the metformin, the drug per se, but disease conditions. And most common conditions here will be hyperglycemia, loss of sugar control. So that could lead to hair loss. Why? Because there are no conclusive evidences found regarding the use of metformin and alopecia. The second group of drugs is gliptins or DPP-4 inhibitors. Again, I would like to say that there are no large-scale studies that have reported any evidence-based association between the use of DPP-4 inhibitors and alopecia, but there are certainly some case reports, and it is a class effect. So whether it is gliptin, linagliptin, sitagliptin, it is seen with all of these. So there was a case of 68-year-old man he was started on July 15, he reported diffuse onset hair loss and it was reversed. Another was 34-year-old man, he was put on Limitlin, again reported acute hair loss, as you can see in the picture also. So this is how that manifested. The third was again 69-year-old man. He was put on a combination of sitagliptin and metformin. And then there was sudden loss of eyebrows and eyelashes, again reversed. Now, so far as real data in our clinic is concerned, we have found 10 cases of DPTI induced hair loss in the clinic. And this has been a class effect. As I said, we have found this with linagliptin, enagliptin, sitagliptin, and vildagliptin, and there was subjective and objective improvement, which was seen after discontinuation. So this was a 29-year-old man, as you can see, with a ponytail in the first picture. And the next we found was he was put on linagliptin, and then hair is gone on the top of his head. Interestingly, I discontinued linagliptin and see, which is what he wrote. After we discontinued linagliptin, hair fall has reduced considerably. It has been like this since 6 years of my hair policy. Hair quality and shine has also improved a lot. So that says a lot about not only linagliptin, but the importance of preserving the hair and patient's confidence. Alopecia areata. It is immune-mediated non-scarring form. Lifetime prevalence is about 2%. Both men and women are affected, but the literature says that women are affected more as compared to men. So both are equal, but women are more equal than men. There is genetic predisposition. About 20% of patients possess at least one first-degree relative with AA. And it could be of as far as severity of grade is concerned, it could be patchy when there are point-shaped circular patches or baldness on the top of the head. Total baldness. You can imagine there is a person not in the audience, but he is very famous actor or actor's father. Yes. Can anyone tell me? Yes. Okay. And universalis. Universalis is along with bald head, eyebrows, eyelashes are also lost. PCOD and hair loss, we all know. Women with PCOD, they have very high insulin resistance and there is vascularization because of excessive production of male hormone testosterone. This can cause male pattern alopecia. So, how to prevent and remedy? Basically, by eliminating the causes. So, normal glycemia, that is low glucose, sugar levels have to be under control by reducing insulin resistance, maintaining a healthy lifestyle, balanced diet, regular exercise, and so on and so forth. There are certain medications and other therapies available. I suppose we all are aware of these: minoxidil, finasteride, betasteroid, and plant-based peptides. Redensil, Procapil, Amagen, and there are injectables and depot hyaluronic acid with peptides. So minoxidil is an adenosine 5-triphosphate sensitive potassium channel opener. It's a vasodilator. Local application helps promote hair growth. However, it must be used indefinitely. So it is not a cure, it has to be continued. Low-dose oral minoxidil is used objective off-label against hair loss and to promote hair regrowth. The second group is finasteride. It is 5-alpha reductase inhibitor. What does it do? It prevents conversion of testosterone into dihydrotestosterone. Yes. And the reduction of why, because DHT is implicated in the development of hair loss in some people. Reduction in DHT results in significant improvement in subjective and objective assessment of hair growth and density. However, there is better perspective, most common adverse effects. I'm sure you would like to know and you would not like to have them. Reduced libido, decreased ejaculate volume, and gynecomastia. Betasteroid is more potent than finasteride. Why? Because it can inhibit both types of 5-alpha reductase, type 1 and 2. So there is 90% reduction in DHT as compared to 70% caused by finasteride. Obviously, the potential side effects are prolonged. They remain for quite some time even after stoppage of the drug. So we need to be very, very careful. There are certain plant-based peptides used in the form of solution for local application. One being reducing is a patented plant-based ingredient. It promotes hair growth. It works by targeting the brain stem cells, hair stem cells and fibroblasts in the hair follicle. Second is procapillation. The major constituent here is hyaluronic acid. It works by targeting the pore circulation. The third is anagen, which is a plant-based ingredient which is derived from pea sprouts. And this stimulates the dermal papilla cells, which are responsible and play a very important role in hair growth. Then again, next is platelet-rich plasma therapy, PRP. Everyone is aware of this. This is effective, harmless, because platelet growth factors are gained from patient's own blood. If they are injected locally, it can treat male pattern baldness. It helps in both prevention and promoting new hair growth. Then deficiency of nutritional supplements. Again, all these have not been tested. So vitamin A, folic acid, biotin. Biotin is much talked about. To be 7 or not to be 7. Why? Because there are no studies in one large-scale study that have proved this. It is only that it may not be influence healthy individuals who otherwise have baldness. That could be only when biotin deficiency is found, and obviously biotin should help. Scalp massages, physiotherapy, laser treatment. Then there are hair weaves, laser, hair growth caps, wigs, and finally hair transplant. So these are some of the hair growth caps. Look better. The last but not the least, low-level laser treatment, LLMT. It is non-invasive, safe, and potentially effective treatment option for those patients with AGA who do not respond or are not following the standard treatment. And this can be combined with minoxidil local application and finasteride orally to enhance hair growth. It has multiple benefits. So this is where the talk begins and this is where the talk ends. I would like to end my talk by saying that love is in the hair. Thank you so much for patiently listening.
Therapy, and we are lucky today that we are having today to speak on laughter therapy in diabetes. Over to you, Jaykumar.
Yes. Oh, that is. Shit. This one. Audio है? वीडियो है क्या कुछ? नहीं, वीडियो. वीडियो है?
Good evening, everyone. Thanks for staying too long. My speech is a bit different and it is more relaxing for you all. I am a dietologist and I am a laughter yoga leader. I use laughter in diabetes treatment because I believe laughter is the best medicine. You all believe that. Let me start with a magic. I will show you magic. I am a magician also. So I will show the benefits of laughter. Think this is your face. Okay, face. I know your face is not here, but just imagine. And this is laughter. Okay, so what we are doing is we are keeping laughter in the face. So you are smiling always. So what will happen? So we have kept only one laughter in the face, but it has multiple benefits. Say abracadabra. And you will get so many benefits if you keep laughter or smiling on your face. It is having so many benefits, which I will explain you. It is having health benefits, and social benefits, and professional benefits, which I will be showing you shortly. I thank Dr. Chawlas for giving me this opportunity. It's a wonderful program, and they smile. I asked them to smile, and they were kind enough to smile. This is a song, famous Raj Kapoor song. It says that you keep people smiling and that is smiling. What I say is, if you have a negative thought and if you start smiling, that negative thought will be possible. So keep smiling. And smiling is contagious. It's okay. So I saw this little boy in the airport, and if you smile, other boy will also smile. Smiling is contagious, and this is the first reflex to develop in us, in human beings. And very few lively people, I mean, living beings humans can laugh. We and chimpanzees and gorillas, something like that. So keep smiling. And smiling makes you attractive. Even God will be smiling. If you see the face of Rama, he will be smiling. They say that Santakaram, Vajrasainam, Padmanabham, Suresham. So keep smiling. Smiling will help you to do things better. And you will be always smiling. And smiling boosts immune system. They say that during COVID time, those people who did laughter yoga, they had better immunity, and we don't have studies, but it prevented COVID. And smiling will lower blood pressure. There are evidence for this. And smiling reduces pain. What happens if you smile? It releases endorphins, and it will help you to reduce pain. And there are studies which show that if in cancer patients, laughter yoga has benefited. And Lord Krishna says he will be always smiling. Madaram Madaram, Vadanam Madaram. If you smile is also Madaram. Madaram means sweet. So smile is sweet, and it is more important for diabetologists. And smiling suggests success. Research has shown that people who smile regularly appear more confident, more likely to be promoted, and are more likely to be approached. So if you smile with your patients, they will like you and they will send you patients. It's happening to me. Try that. And smiling helps you to stay positive. If you smile, things will stay better. So you try, when you are stressed, next time, try to smile. This is a video. Smiling with my kids again. And this is how I started this. We did one program, the first gerontology conference. Gerontology is the study of laughter and its effects on human body and its benefits. Then we published this, laughter therapy in diabetes, with Dr. Sanjay Kalra and my friends. Gerontology, or the science of laughter, is developing as a complementary field of medicine. Then laughter therapy has been shown to have multifaceted physiological and endocrine benefits, which I will be explaining, and is being used to help manage various chronic diseases. This communication describes how to use laughter and to laugh with your patients. This is another article published in Advances in Diabetology, written by Dr. G.R. Sridhar, and this is about gerontology. And these are the various articles which I published. And we did a second conference and we had a wonderful response. We had 1,800 people who participated in this online program. And I thank all these people. And laughter with yoga for stress. And what they say is beautiful laughter as an adjuvant therapy in diabetic care increases HDL cholesterol. So our conference is about complications and diabetes care. So if you can laugh, it increases HDL and it will reduce the cardiovascular complications. Catecholamines are implicated in causing arrhythmias and other things. If you laugh, you can reduce the catecholamines. And laughter is the best medicine of cardiovascular disease among Japanese adults. In these Japanese adults, they found out that those people who laugh, they have less cardiovascular disease. So obesity, I presented this paper in one of the conferences. Obesity will not laughing matter, but laughter helps you lose weight. So if you laugh, it will burn calories and it will reduce the stress, and try it. No need to go to gym and try to laugh. So one of the causes of obesity is stress. If stress is reduced, it will help in obesity control. Stress can be reduced by laughter. Laughter found to reduce stress, in turn reduce obesity. Laughter burns calories. Various studies of this hypothesis were presented. Main aim is to stimulate use of laughter in stress and obesity. And this is the study which I got interested. This is a Japanese study where they found out they used laughter to reduce the postprandial sugar. So this study shows that I tried in my patients and there was a reduction in the postprandial. You try this. And laughter yoga is an enjoyable therapeutic approach for glycemic control in individuals with type 2 diabetes. And this is my favorite song when I was a student.
It's okay. I should not be worried because it's not working. When you are worried, think of his son. Don't worry, be happy. And in life, we expect something. If you worry, it will double. So, and it will make everyone down. So don't worry. And this is a new study, catalyst study. John Gies, I met him in Bangalore. And he says that if you have a diabetic who is uncontrolled with OHS and insulin, you have to think about that. I think stress plays an important role because he's hypercortisolism. So the last yoga in perceived stress burnout, a life satisfaction nurses. During COVID, we were scared to see patients in OP, but these nurses, madam was there from Turkey, she told me, and they studied, and they said that if the nurses practice laughter yoga, who are working in ICUs, and they found out it is useful to reduce stress. And as we said, now they say that diabetes is caused by noxious mind. One of them is cortisol. So you can reduce cortisol if you laugh. So the laughter prescription, a tool for lifestyle meditation. So once a week you just laugh, intensity belly laughing, and time 30 minutes type your favorite sitcom. So try to laugh more. They say that children laugh 300 times per day, but as you become adults, you're not laughing more. And you know, the average woman smiles about 62 times a day, a man only 8. Kids laugh around 400 times. I don't know why women laugh more. We have to laugh more to increase our lifespan and so many things. And even if you anticipate laughter, it reduces stress. So just at least. So what I want to tell you is laughter is free, universally available, no side effects, proven benefits, laugh more, live longer. Spread your smile to your patients who need it most. So if some person or a patient comes, try to smile with him because they come for your smile and suggestion. Remember that. And they are the most needed people because they are paying you money and coming, and if you smile, that will improve the quality of their life and your life also. So laugh with your family and friends. And for everything, terms and conditions apply. So this is a video where we celebrated Laughter Day. Like you should laugh. And if you smile, this lady presented me a present on my birthday. And what I want to tell you is to be happy is a great gift. You owe to yourself. There are the time when psychologists were saying if you are happy, you smile. Now the research shows that if you smile more, you will be more happy. So keep smiling and be happy and make others also happy. Remember that. If you smile more, you will be more happy. Previously say that only people happy are smiling. Now research has shown that. So Indian doctors are smart. There is a doctor, it's a joke. He's put a goal. If I can't treat any disease, I will give you the double fee for what you paid. So if you pay 100 rupees, if I can't treat, I will give 200. So one day comes and he says that I can't taste. So he calls the compounder and says, bring 27, keep it. Put on his tongue. He put the tongue, he says, doctor, this is petrol. Okay, your taste return. Okay, so that fellow has to leave. Second time, he wants to try with the doctor again. He says that, doctor, I can't remember things. Then he says, pays the money, and doctor says, bring 27. Then he says, doctor, that is petrol. Okay, your memory came back. Okay, you pay me. And third time he comes and he says, doctor, I can't see. Then this doctor says that he is very smart. Oh, that's the only thing I can't. So he paid already 100 rupees. So he's supposed to return 200. Instead of 200, he returns only 100. That fellow says, sir, this is 100 rupees only. Then he says, I treated this also, you can see better. So our doctors are very smart.
Smart Dr. Madan Kataria, he is laughter guru. He started this laughter yoga. So I will show you laughter yoga for a minute, then we will close. So what are the steps of laughter yoga? You can join me if you want. Just start with clapping. Clap. Oh, oh, ah, ah. Oh, oh, ah, ah. Oh, oh, ah, ah. Oh, oh, ah. Then what we will do is, as you know, many of us did breathing exercises. Breathing exercise is the thing, what we will do is, we take inspiration, but exhalation will be slow. What they believe that if you exhale slowly, your stale air will go out and we will get more oxygen to the tissues. So what we will do in laughter yoga, we will take a deep breath, hold it, that is normal. But laughter yoga, what we will do, we will take a deep breath, hold it, we laugh it off. When you are exhaling, we laugh. So this is how they say that we will get more oxygenation to the brain and tissues. And third thing is, as I told you, kids laugh more than us 400 times, but we are not laughing. So we will do something like a kid. So try to be. They say that everyone has a kid inside them who wants to come. Okay, so what we will do, whenever you are happy, kids, they are very happy for small things. But as we grow adults, even if you get 1 crore, we don't be happy. So try to celebrate life with small things. For everything in life, what kids should do. Very good, very good. Hey. Do that. Very good, very good. Hey. Very good, very good. Hey. So that's how kids celebrate. And finally, I will ask you to laugh with me for 30 seconds. I'm giving a challenge. Let us laugh together. Okay, start. I know, I told you, laughter is contagious and you will laugh together. So keep laughing for your health and wealth, everything. Thank you very much.
Thank you for giving a wonderful message. Thank you. And so next speaker now.
I want to end with this slide. We are celebrating on Friday, 4th October, Smile Day. Dear President said he will join us in online. I asked him. So I will send you that link. Please come and join and smile together. Thank you very much.
Thank you, sir. So we have next speaker now, Dr. Arvind Jagadish, and we're going to speak on why this sulfonylurea plus metformin combination in the New York.
Slides. Slide. Yeah. Slides. So good evening, everybody. At the outset, I'd like to thank Dr. Manoj Chawla and Dr. Puri Chawla for making me part of this DRS WCPD conference. So today, my topic is on low-dose modern sulfonylureas and metformin FDC in the new era of diabetes care. So greetings to all of you from Bangalore. So this session is sponsored by USP. Thanks for USP team. So the glycemic management, a pillar for reducing diabetes complication. This is the ADA 2024 recommendation. At the bottom of the slide, you can see the lifestyle modification and diabetic education plays an important role in all diabetes management. Then the other part is the glycemic management, blood pressure management, lipid management, and agents with cardiovascular and the kidney benefits. The glucocentric is the cornerstone for type 2 diabetes management. Proven to be beneficial in preventing microvascular and macrovascular complications in people with type 2 diabetes. This is the follow-up UK study which was published this year, which I also emphasize for every 1% drop in HbA1c can reduce long-term diabetes complication, like 12% for any diabetes-related endpoint, 16% for MI, 21% for retinopathy at 12 years, 25% for microvascular endpoints, 24% for cataract extraction, 33% for albuminuria at 12 years. This is another study published last month in Diabetology, which emphasized the intensified blood glucose control will have a long-term legacy effects, which is becoming increasingly evident with the prolonged follow-up. So the early intensive glycemic control with sulfonylurea minimizes the lifetime risk of diabetes-related complications. This is the UKPDS 91, that is 10 to 24 years follow-up study, which was published last year, this May 2024. It says early intensive glycemic control with sulfonylurea or insulin or with metformin compared with the conventional glycemic control appears to confer a near lifelong reduced risk of death and myocardial infarction. Achieving near normal glycemia immediately following the diagnosis might be essential to minimize the lifetime risk of diabetes-related complications. So early intensive glycemic control minimizes the lifetime risk of diabetes-related complication. As per UKPDS 91, post-trial monitoring of RCT of 10 years to 24 years, the early glycemic control with sulfonylurea or insulin with metformin reduced the risk of death and MI and minimize the lifetime risk of diabetes-related complication. This is one meta-analysis, systematic review of a meta-analysis. What it says is early and sustained glycemic control may have a long-term beneficial effects on retinal and renal health. Sulfonylurea remains the integral part of type 2 management of type 2 diabetes across the three eras. On the bottom, you can see the first era is main strategy is to lower the HbA1c to improve morbidity and mortality. In the middle, you can see the second era, the lowering of HbA1c is not enough. The potential role of adverse effects of pharmacotherapy. On the right-hand side, you can see the third era, the reduced cardiovascular and renal complication, largely independent of glycemic control. So modern sulfonylurea remain mainstay across the eras. The usage of glimepiride, metformin, FDC spans a broad spectrum in India for type 2 diabetes management. Sulfonylureas are cost-effective and readily available everywhere across India since many decades. So they are still the most frequently used treatment modality for type 2 diabetes in our country. So do sulfonylureas still have a place in our clinical practice? Sulfonylureas are associated with a good efficacy and durability without excessive weight gain. The new generations of sulfonylureas also appear to confer less hypoglycemia, and their favorable ratio of cost, efficacy, and safety make them affordable for most healthcare economies. So in this slide, you can see the summary, almost the summary of sulfonylureas, the assets in the past,
present, and future. In the left-hand side, you can see it was way back discovered in the laboratory in 1942. Then came the tolbutamide. Then they found the severe risk with tolbutamide. Then the second generation sulfonylureas marketed in 1980 with a better safety profile of new sulfonylureas. Then in 1998, you can see the UK study which showed the CV safety of new sulfonylureas. But no protection. Next came the advanced study in 2008, that the CV safety of the glycoside MR. Then the Tosca IT study, the similar CV effects of sulfonylurea as compared to pioglitazone. Then the most important study, Carolina, which was trying to show the superiority of linargliptin, but it turned out to be a boon for sulfonylurea, especially the glimepiride, which shows it is non-inferior in cardiovascular safety as similar to linagliptin. Next, then the GRADE study, which shows the durability of sulfonylurea. Then the UKPDS 91, that is the follow-up study, once again, which emphasizes the early glycemic control confers a near lifelong reduced risk of death and MI. So the place of sulfonylureas in the management of type 2 diabetes. So sulfonylureas have long been the only alternative to metformin. It remains largely prescribed even in countries where new drugs are available, and in countries where more expensive OADs are not available or not reimbursed. So the modern sulfonylureas in era of new OADs, sulfonylurea accounts for approximately 20% of the newly initiated OHAs. In India, sulfonylureas are the second most prescribed drugs, up to 35%. Third point is sulfonylureas have a long-standing track record of good efficacy, adherence, and tolerability. They are the effective insulin secretagogues, and as an add-on to metformin, could be a good choice for Indian. So modern sulfonylureas are safe and soft, a smart choice for the type 2 diabetes management. So the modern sulfonylureas are the mainstay across the type 2 diabetes continuum. So the benefits of low-dose modern sulfonylureas, higher efficacy with minimum side effects, multiple evidences available on efficacy of low-dose modern sulfonylureas. If you do a PubMed search, there, if you see in this slide, it's an interesting slide to show when sulfonylurea is typed, you get about 26,000 literature about sulfonylurea. That shows the magnitude of this molecule. On the right-hand side, you can see the metformin, that is 31,000. So two commonly searched molecules which have got a profound literature is the sulfonylureas and the metformin. So landmark research on the modern sulfonylureas, as we showed in previous slide, the advanced trial, STAR trial, Tosca IT, Carolina, GRADE study, and the UKPDS. Do you have Indian evidence? Of course, you can see this wall of Indian evidence. There are so many real world studies which has been done with the low-dose sulfonylureas along with the various combinations, mostly with metformin, which has shown the beneficial effect in our clinical management of type 2 diabetes. Next comes the durability. Durable glycemic control with glimepiride versus newer OADs. So glimepiride took 113 days more than DPP-4 inhibitors to reach A1C more than 7%. Means the longer duration of the durability of glimepiride. On the right-hand side, you can see when it compared to sitagliptin, the durability of sitagliptin was 697 days. In glimepiride, it was 810 days. That is 113 days more when compared to the DPP-4 inhibitor sitagliptin. So this is the STAR study, that is a comparative evaluation of safety and efficacy of glimepiride and sitagliptin in combination with metformin in patients with type 2 diabetes. It is an Indian multi-centric randomized controlled study. What it conclude is in type 2 diabetes patients, glimepiride metformin combination exhibited significant reduction in glycemic parameters as compared to sitagliptin and metformin combination. Moreover, there was no significant difference between sulfonylureas and metformins and DPP-4 inhibitors in terms of change in body mass index and the incidence of hypoglycemia. When it comes to sulfonylurea, there are always a discussion about weight gain and hypoglycemia. This is a comparative study which says that newer sulfonylureas are not so much to be worried about hypoglycemia and weight gain. That is definitely it is there, but it is not a big thing as discussed earlier in any molecule, any discussion you take. The trying to snub sulfonylurea is about talking about hypoglycemia and weight gain. If you take insulin, it also has the same side effect, isn't it? So if you take paracetamol, it also has got the weight gain issue. So we should not leave sulfonylurea alone because it is there since many decades in our clinical practice. So this is another study, Zodiac 39. That's a study modern sulfonylurea glimepiride, weight neutral over a period of 5 years. So you can see here there is no significant difference in weight in metformin glimepiride group. So the average HbA1c 1 year after treatment intensification is less than 7%. The strict glycemic control can be maintained with sulfonylurea metformin in a real life setting without relevant weight changes. Another important study published by Dr. V. Mohan, which is the clinical profile of elderly patients, that is over 90 years. Age of 90 to 100 years, that particular age is called as non-age narians. So if you take this clinical profile, they recruited 325 patients aged more than 90 years and 278 type 2 diabetes aged between 50 and 60 years. On the right hand side, you can see 85% of the type 2 diabetes aged more than 90 years were on oral hypoglycemic agents, of whom nearly 65% were on sulfonylureas, 12% were on insulin, and 3% on diet alone. So the modern sulfonylureas and metformin can be used across the type 2 diabetes continuum. This is an important thing. Starting from the left-hand side down, you can see it can be used in comorbid conditions, newly diagnosed type 2 diabetes, young people with type 2 diabetes, sulfonylureas in combination in Ramadan can be used in overweight and obese patients as well. Most important in monogenic diabetes, especially in MODY 1, 4, and 3, in long-standing diabetes, type 2 diabetes complications, used in special populations, non-vegetarians type 2 diabetes. So in so many, nearly 10 groups, almost in every case, in every scenario, the sulfonylureas can be used. So if you see this recent last month publication from IQVA, which says this, among the top 6 oral anti-diabetes therapy by absolute prescription, if you take, the glimepiride metformin is the highest prescribed. You can see the numbers there. They are almost like 290, almost 29 lakhs or more prescription. Not 29 lakhs, it is more than that. So you can see the amount of prescription you can see with glimepiride metformin when compared to metformin, DAPA, the triple combination, Vilda. So glimepiride and metformin remain the leading combinations in OAD prescription in India, maintaining a significant prescription share despite the introduction of newer therapies. So the number shows that the amount of prescription we give in our clinical practice, especially in India. So the treatment de-intensification promising solution to advancing diabetes care. Given that diabetes over-treatment is often linked to adverse drug events and poor medication compliance, de-intensification is the dosage reduction of medicine treatment with an aim to manage more polypharmacy and improve patient outcomes. There are multiple evidence available on low-dose sulfonylurea. You can see nearly 8 articles are there which show the low-dose glimepiride and metformin as a clinical beneficial effect in our clinical practice. The low dose is like 0.5 milligrams of glimepiride with metformin and 1 milligram plus metformin is routinely used in our clinical practice, which will have a good legacy effect in the long run. So the Williams textbook of endocrinology says on the right hand side you can see the small doses of sulfonylurea. Example, 0.5 to 1 milligram of glimepiride or 2.5 milligrams of extended release glipizide are remarkably effective, particularly in patients receiving concomitant insulin sensitizing therapy and are almost uniformly well tolerated. So Indian ways to de-intensify with low-dose sulfonylureas: start with lowest effective dose, regular monitoring, tailored treatment, consider combination therapy, patient education, emphasize the role of medication adherence, and regular review. So Indian diabetes needs Indian solution. Remember the 4 A's: appropriate, availability, affordability, and accessibility. Clinician got reassurance about the CV safety of Winpride, and economy makes it a patient-friendly OAD. We are in the era of choice overload. Modern sulfonylurea is still standing tall in type 2 diabetes management in 2024. Thank you for your patience hearing. If you have any questions,
Thank you, sir. So just one question, one quick question. The choice of sulfonylurea, provide a glycoside.
So it's always a debatable, isn't it? So only thing is that the cardiac safety is always concerned when it comes to sulfonylureas. Ultimately, the glycoside add a cardiac beneficial effect later. But the latest, if you see the Carolina study, once again, the defense emphasizes glimepiride can be used as well. So always the question comes is which to use. It's an individual perspective. Both are good. Both the studies are effective in both the things. But when it comes to clinical efficacy and patient-friendly or clinician-friendly is our glimepiride.
Thank you, thank you. I think there is one more example that we have, because fixed dose combination of 0.5 of glucose with metformin. I think this combination of low dose sulfonylurea, I think there's an added advantage, I think, in our country to prefer low quantity.
Actually, the low dose means it is not only 0.5 milligrams. According to the things is that with 0.5 also and 1 also. 1 also is considered as low dose only. In some articles says up to 2 also. 2 milligram of glimepiride is also considered as the low dose. But in our country, the most popular thing is glimepiride 0.5 with metformin 500. When the newly diagnosed young diabetic patient comes to you, we always tend to put that with a high HbA1c. Instead of putting only metformin, the latest concept is be aggressive from the beginning to get a better glycemic legacy effect in the long run. So we used to tend to use this 0.5 with plus 500. Right.
Thank you, sir. Thank you.
Pizza. If that is a good molecule, which we are not, but I have patients who are using line and rubber for the last. It is less expensive when you compare with. We should consider patients can afford instead of.
Yeah, definitely it is there, but the study is what is the documentation. If you see, these things are more with modern sulfonylureas and glimepiride and glycoside. That is where they score over. If you take the price difference, maybe 2 to 3 rupees difference is there. Earlier it was a big thing. Now price wise also it is better. Yeah.
Thank you, sir.
Thank you.
So now moving on, we have next speaker, Dr. Suresh Dhammadharan, who is going to speak on evolution and management of erectile dysfunction. Over to you.
So every minute you delay, the audience are, we are losing the audience. Good evening, everyone, and thank you very much for the wonderful opportunity. Actually, we got a very thin crowd, and we'll just make it. It's normally it's 15 minutes. We'll try to rush in between. Can you get it, please? I think it's 2 minutes already. It's a electronic dysfunctioning. Maybe even dysfunctioning. So, thank you for that. How do you do? How do you move? It's dysfunctioning. How did you move?
that.
I'm trying. This one? No. This one? Okay. No. Thank you very much. We all see erectile dysfunction probably in our clinics, and it is very, very important that we should know just to get the basics right and just evaluate them and then probably treat them properly. Now, it's a 41-year-old type 2, HbA1c not on goal, hypertension, diabetic dyslipidemia, depression, obesity as well. So you see patients on statin and insulin and also an antidepressant. But I think when he completes the pharmacotherapy workup, he asks instantly, in bedroom and stuff. Basically, the further questioning relatively was so much easy that he's got an ED and he's been having the trouble for almost 6 months with the pharmacotherapy workup and physical examination. He was given a prescription of pill, and was it appropriate, whether we should do anything better than that, and then laboratory assessment, whether we could do anything better. So what is the ED stands for? Endothelial dysfunction, and also how to prevent it, and early detection works, and then early death with most of the electronic, more of the electronic, endothelial dysfunction. So ED is defined as the inability to achieve and also common sexual complaint in the male. And how prevalent it is, it's almost 52% in the male of 40 to 70 experience ED, and most of them have got comorbidities. What is the mechanism behind it? It is very, very clear that it's also has got neural, blood supply and functional aspects. So all the three is there, and broadly it's divided into psychogenic and organic causes. But mostly we all agree it is more going to be for psychogenic causes. So how do you differentiate psychogenic, neurogenic, hormonal, vascular? So whenever the patient comes in, you can describe these are the ways the nerves, hormones, and the blood vessels, and also the psychogenic, and then drug induced and other things when the people are on alcohol abuse, which is very, very common nowadays, and also antidepressant and other drugs. And systemic disease, of course, does affect vascular as well. So how do you differentiate organic and psychogenic? It is so complex, but I think just keep it simple: the acute onset and intermittent course, and a few other things that you need to identify to make sure the organic cause is the first one comes in the list if you don't have any other cause to evaluate. But how does ED different in diabetics? Because it is very common. It comes in early age. Even you've got a 35-year-old diabetics that you get a proper history. They will have it if you've got a history properly, and it's less responsive to treatment, and that's a challenge. So you need to identify the cause. I'll come to the important causes in a minute, but I think these are all the things: microangiopathy, macroangiopathy, decreased libido, and I'll come to the hypogonadism bit in a later stage. So mechanism-wise, you've got advanced glycated end products, endothelial dysfunction. It goes to the nerve depletion, and also irreversible erectile dysfunction happens. So ED screening may be it's very important to know the cause and also to reveal the presence of hypogonadism. I come to a case. But the ED shows distress and depressive symptoms, and it changes the lifestyle of the patient. So it is very important to identify early and then treat it properly. What is the relationship between ED and CVD? It is a sensitive indicator of systemic and endothelial dysfunction. As I showed you in the first or second slide, it is directly almost correlates with the cardiovascular disease. High content of endothelial, this thing, so you can see very clearly the pineal artery size, the coronary artery size, and carotid and femoral artery all gets narrowed in the late stage of the vascular disease like ED. So ED is an indicator for a CVD risk. We can identify early and then treat it. Is clear indication. I'll come to an up-to-date chart of how it works in a minute, but the CVD and meta-analysis shows it's a direct link, and the stroke as well, the macrovascular disease, also directly linking to ED. So this is the one I mentioned about the up-to-date one. So you can see the accessibility, risk assignment, intermediate risk, and when you go to the stress test, you pass and fail, and you go to the cardiologist. But the ED is such an important thing that you go directly for a cardiac screening as well. So the pathogenesis and ED and CVD is common, and the artery size is very important, and ED occurs in a very silent CAD that take cardiologists help as well, because when you start treating and you should identify whether the patient is on nitrate and other stuff. So management wise, you have to evaluate properly. So when the patient has got ED, medical and psychosexual history, and then identify other ED sexual problem, that is very important, and then go to the reversible risk of ED, and then the psychological one, as I mentioned earlier. So penile deformities are not uncommon, Ramsay Hunt penis and few other things, and then the prostatic diseases and types of hypogonadism. Nowadays, a lot of fat, plumpy ones are there. So you really need to look for other causes as well. And cardiovascular and neurological issues can be present, and then you do a lab test. Then you can do for the treatment for glycemic control and also androgen treatment if it's needed. This is the quality of life and how you assess. Actually, there are a lot of ways to assess. How do you assess? It's like a questionnaire. You can do it in the clinic. How do you rate your confidence that you get and keep an erection? That kind of thing. If you do it, and then you can estimate the total score of 22 to 25. And then when you go to the severe ED, it's only 1 to 7. So this is one of the ways to assess. It's a simple way that you can use in the clinic. We don't see that much sexual thing one after another, but when you do see it, if you assess properly, it is very, very important that you can give a right treatment. So coming back to the case, what I showed you earlier, type 2 diabetic with diabetic dyslipidemia on land tests and antidepressant, and she's tried to declare that this thing is has got some sexual dysfunction. On further questioning, ED was there, but the question is whether it's appropriate to give a toddler pill straight away, or what are the possibilities that you would evaluate in the lab test. So whether other etiologies for ED, and then whether PDE5 is appropriate in lab test. So when you order a lab test with this one, this patient, the testosterone was less, and then the LH and FSH is low, indicating hypogonadotrophic hypogonadism. Okay, so ED is one of the problem between marker of hypogonadism. So hypog is prevalent in type 2. That science or that message, if you want to take across, that is a really good message, especially in the plumpy type 2s of our generation now. So this is the hypothalamic pituitary axis controls the gonad through gonadotropins, and the spermatogenesis happens, and how the testosterone works. It converts into dihydro, active dihydro testosterone in the cytoplasm, and works with, which is protein bond. It's very, very difficult to assess the testosterone assay, and these are the things that how do you evaluate and just describe hypogonadism. So primary and secondary, it's no brainer, but primary is from testis and secondary is from pituitary or hypothalamus. So this is one cartoon I want you to take back. So if you see an insulin resistance, you see adiposity and lipoprotein lipase, and that will go to the hypogonadism. If you estrogen level goes up, when you have the inactive form, all the testosterone will be hyperaromatized to estrogen when there is a fat tissue, and the estrogen level goes up. That gives a signal to the pituitary in a wrong way. Instead of testosterone, it gives a signal, and then the hypoc happens because of that. Hope you understand. So the testosterone hyperaromatase to estrogen, and the estrogen excess will signal the pituitary to secrete this thing, and then leptin is the other hormone which will also decrease the GnRH release, therefore the decrease of LH and FSH, therefore leading to hypogonadotrophic hypogonadism. So hopefully you understand that. So that is one mechanism we should all elicit and find out. So erection hardness score, I just skipped that, but I think it is very, very important when you go and assess properly. Vascular imaging, it helps a lot in managing the patient. Treatment algorithm wise, you get a psychosexual counseling, which is very important. I don't know anybody does a sexual clinic here, but I think Mumbai, you will have a lot of people, the young generation especially, working hard in IT and stuff. They got lot of issues with sexual issues. So if you got a psychosexual and couple therapy, and of course the lifestyle modification and with a lot of AI and few other electronic devices, you could do that. And then androgen replacement, as I mentioned, PDE5, you can do it. And there are other possibilities as well if the treatment doesn't work. So when you select the PDE5, a lot of availabilities, but most commonly sildenafil and tadalafil is the drugs that is being used, and there are quite a few contraindications. I'll come to that in a minute. But PDE5 is very, very effective in comorbid conditions as well. And men with comorbid conditions, it's very, very effective, almost 66% compared to placebo. But when you want to maintain the erection as well, it works very well in type 2 diabetics as well. So I mentioned about the contraindication. These are the contraindication, cardiovascular, hepatic, ophthalmic, and concurrent treatment. So when you, I don't know whether how many people have come across when the patients came and said that there is visual problems and headaches when they start on PDE5. Visual problems is one of the common things. The loss of vision, it's called neon. It's almost ischemic ophthalmic neuropathy and hereditary degenerative retinal disorders. It's regulated pigment also, but I think that's all uncommon. But when you have it one time, that it's probably a vascular event as well, with people having eye problems. So non-responders are also there. You will find it, and because the diseases gone much worse and the vascular endothelium has gone much stronger, you don't have any response to PDE5. In practical terms, it's worth trying PDE5 in all the males actually. And then hypog I mentioned, once you correct the hypogonadism, probably it works well as well. And the alternative treatment also works. So combining testosterone and PDE5, currently it is mainly for hypog patients. As I mentioned, if you assess properly, you can get people with hypog diagnosed. So combining testosterone with PDE5, there is some evidence and quite a lot of evidence available when you got a diagnosis of hypogonadism. And these are all the vacuum devices which can be used for ED and also intravenous injections. So in worst scenario, we can use all that, and urologists can help you to do that. And surgical options wise, prosthesis and quite a lot of other hyperbaric and other things have been tried with variable results. So just to summarize, it is a process of vascular, but the neurological things are all there as well, but mainly psychosocial things that need to be assessed. And don't forget that hypogonadotrophic hypogonadism is one of the ways that diabetes works, especially along with the neurological and vascular issues. It's multifactorial. Impairment of nitric oxide production is there. And PDE5 works very well. You can try in most of the men. And then if you are not responders, then you can think of alternative methods. But hypogonadism is an important cause, and psychological counseling is very, very important. And of course, the lifestyle is going to be the key. Alcohol and quite a lot of other lifestyle managements are very, very important. And a few people pretend to be active, but you have to question them in your clinic just to get the history right. But sadly, the patients have got a very good way of finding out the things they don't want to do. Anyway, thank you so much for our patient listening. So just for the time.
Yeah. Only one quick question. Sometimes I've seen urologists writing a small dose of tolafil 5 mg daily.
Yeah.
Does it have any scientific evidence or anything other than the one dose?
I think that people are trying that. It's a low dose, they give it daily. So the idea is just so the vascular endothelium can open up a bit. So the mechanism is phosphodiesterase inhibition. You use it for pulmonary hypertension and other cases. So the idea is just to open up the vascular endothelium. So if you use it for a low dose, and the rationale is that the resistant cases works. So a lot of people are trying that now. But of course, you have to identify other side effects as well.
Thank you. Thank you. Yes. So, moving on to the next, thank you. Moving to the next final topic. We have Dr. Supratik Bhattacharya, who is going to speak on from youngest to eldest. How is going to revolution the change in the hypertension management and type 2 diabetes?
Thank you, Chairperson. And as you can see, I'm all decked up for the big opening ceremony that is happening next door.
We'll keep it very short, and I'm talking about some numbers, the organs, and how to manage hypertension in type 2 diabetic individuals. Can we have it in a slide show format, please? So once again, big congratulations to the entire team. And I'll try and give you some practical aspects rather than talk about details of the theory that we have on board. So I think one very clear message that we have when it comes to diabetic individuals, the first consideration when it comes to choosing antihypertensive has to be a RAS blockade. And we have level 1 evidence, 1A evidences for that. And you have to consider RAS blockade before you move on to anything else. Now, what we are trying to understand again is how low to go, because the numbers are very arbitrary and it keeps changing every year. So it's quite confusing for everyone to, understand what would be a good number. But the consensus has been that 130/80 for diabetic individuals when it comes to clinic blood pressure is a good number to have. Just to set the context, we know that hypertension prevalence is a big concern in India as well. And if you have diabetes and uncontrolled hypertension, obviously the chance of organ damage is very high. You can have stroke, heart failure, renal failure, peripheral vascular diseases, like we have been talking about, including erectile dysfunction, and 72% of the hypertensive patients remain uncontrolled. So that's, again, a big number to consider. Moving on, there are many challenges. So first, to identify, you need to screen. So there is a screening month that comes from one of the hypertensive societies, and we encourage everyone to screen their patients and their relatives, whoever walks into the clinic, to understand what is the prevalence of hypertension in India at the moment. And if you find, incidentally, that they're hypertensive, then you can go about doing whole blood pressure monitoring or ambulatory blood pressure monitoring to rule out white coat hypertension. And if you find that they are hypertensive, you need to work on it. You can't sit on it, and if you see that the numbers are running high, at least 2 or 3 times, you need to be aggressive in initiating a therapy, and just initiating a therapy is not good enough. You need to up-titrate the therapy to reach the targets that we have been talking about. So the challenge is both from physician's end as well as from the patient's end as well. So numerous studies has been done to understand the patient variance, and obviously the number of pills, if they are high, the variance is low. So because a diabetic individual will have a set of diabetic pills, along with that statins, along with that antihypertensives. So if you are trying to escalate, it makes a lot of difference if you can do that with a single pill. So if you have fixed dose combination, that helps in terms of variance. So 2 is better than 1 when it comes to combination therapy, and adding another drug or class makes more sense than increasing the dose of the monotherapy. So that is what we have, and we do have evidences for that. And this is my original research that was published in Journal of Endocrine Society, and we had the numbers from India which showed that a considerable number of patients were not reaching targets with just monotherapy, and they required at least drug or triple doses, drug therapy, fixed doses to attain their targets. So we need to be very aggressive. Again, this is another evidence that you have. As compared to combining therapies, if you escalate the dose of the monotherapy, the combination therapy works better in achieving the goals. So this is JAMA, which says that the concept of initial combination therapy is not new. And like any other treatment, like for diabetes, we are talking about early combination therapies. Similarly, we need to be aggressive in controlling blood pressure as well. And we need to think of early combination therapy, which we want to get the blood pressure to control levels. Now, why combination is required? We know that fixed dose combinations are convenient, better in terms of variance, probably more cost effective in nature. So these are the considerations to be made. And comparison between different hypertensive management strategies, you know that if you start with low dose monotherapy, then gradually increase the dose, versus if you have early combination therapy, the early combination works better than the monotherapy. This is the ESH guidelines, and we have been talking about the first line in diabetic individuals has to be RAS blockade, either inhibitors or ARBs. ARBs obviously have a slightly higher advantage because many of the elderly individuals, they come with cough, angioedema, and this number is less with the ARBs as compared to the ACE inhibitors. So ARBs are a little more popular. And then you have to consider a calcium channel blocker, dihydroteresis calcium channel blockers, or combined L and N type calcium channel blockers, which are the newer generation calcium channel blockers. Then the third line would be a diuretic. So you need to move fast between these groups and combine one with the other. Which combinations are considered end-organ friendly? Again, when it comes to diabetic individuals, all evidences lie on RAS blockade. And along with that, you need to have a calcium channel blocker on board. And if with that, you don't get to the target, then you need to consider the diuretics as well. So they work in different ways, like for example, calcium channel blockers cause arterial dilatation, peripheral edema, effective in low renal patients. ARBs, on the other hand, cause RAS blockade and is useful in chronic heart failure and renal benefits. So you have a complementary mode of action. Which calcium channel blockers will be more end-organ friendly? And we have the older versus the newer generation calcium channel blockers. And the first generation ones were rapid acting, they were strong, short acting, and you had to probably place it twice a day, if at all. Whereas the fourth generation, the newer ones are slow acting, stronger, they last longer, so you can use it once a day. Now coming to the main difference between, say, for example, the newer antihypertensive like amlodipine versus cilnidipine. So amlodipine kinds are pure L-type calcium channel blockers, which does a fair job when it comes to preventing vasoconstriction and causing vasodilatation. Cilnidipine, on the other hand, has a very novel mechanism of action. It works on both the L-type as well as the N-type calcium channels. And blocking this N-type calcium channels has certain other advantages. For example, not only it causes vasodilatation, but it also reduces the calcium influx and thus the norepinephrine release, which could cause reflex tachycardia and also release decrease of renal blood flow and venous secretion. So you have certain advantages of using a combined L and N-type blocker like cilnidipine. The peripheral edema is also less. So the prototype, as we said, amlodipine L-type calcium channel blockers antagonizes the vasoconstriction, which is a class effect. N-type calcium channel blockers, which are more novel ones, not only causes vasodilatation, but at the same time, it blocks the norepinephrine release and thus renal vasodilatation and also less reflex tachycardia that is seen only with the L-type calcium channel blockers and less feeble edema theoretically. And obviously we know that in anyone with CKD or heart failure where feeble edema is a constraint, we don't want to add to the burden, and in those scenarios probably the L and N-type calcium channel blockers fit in really well. So L-type calcium channel blockers, amlodipine, in fact potentiates the glomerular hypertension and thus may not be the right choice when renal protection is the goal in hypertensive patients. We do have certain evidences in terms of reversal of albuminuria stages from micro to normal albuminuria and macro to microalbuminuria with the newer classes of combined L and N-type calcium channel blockers as well. So there is a changing trend in the pharmacotherapy when it comes to hypertension management in India. India now has its own guidelines for management of hypertension in type 2 diabetes patients. And we know that management of hypertension in patients with type 2 diabetes, this is the latest guideline that we have, 2024 API and Indian College of Physicians guideline. And we have many of us here who have been part of this particular guideline. So basically, what has been recommended is that the clinic blood pressure of 130/80. Again, we are emphasizing on combination therapy, early combination therapy as a cornerstone of treatment. ARBs are preferred as the first line when it comes to treating hypertension in those living with diabetes.
with calcium channel blockers to improve outcomes in terms of blood pressure control and organ protection. And we need to consider strongly the newer generation combined LMN calcium channel blockers if required. If target blood pressure is not reached with S or R, then consider using dihydropyridine calcium channel blocker or thiazide light diuretic if needed. So a combination therapy with ARBs and calcium channel blockers are preferred over beta blockers and thiazides. So this is again, and among the calcium channel blockers, simidipine, a novel molecule, is considered to be more effective and safer option for the diabetic hypertensive patients. And in combination with the ARBs, especially those with end organ diseases like CKD, for example, that we had highlighted, which would come with PD by such. Now, the available single fixed dose combination according to the patient's phenotype that we have, if you have uncontrolled monotherapy, RUS with calcium channel blockers, plus statins as the fixed dose, we do have obesity. Again, RUS blockade is very important along with calcium channel blockers. Those with chronic kidney disease, again, strongly consider combined LMN calcium channel blockers along with the RUS blockade. Those with stroke, we have very robust evidence of RUS blockade in preventing future stroke along with the calcium channel blocker. Type 2 diabetic patients, as we have been emphasizing, first you have to consider RUS blockade followed by a calcium channel blocker and a hydrochlorothiazide like diuretic. So with this, thank you, and hopefully this will help you in your practice. Thank you, Subodhi. One question, you have shown that simidipine is better than amlodipine. Any thought on the new molecule amlodipine? So it's pretty much works in the similar lines. Amlodipine is supposed to give you a 24-hour coverage better as compared to amlodipine and cause lesser side effects like the pedal edema. And we have been using both very efficiently in our clinical practice. I think amlodipine works as good as any other calcium channel blocker. It's not any worse than anything else. And what about amlodipine? Amlodipine are the same. Potency-wise? Potency-wise. So I think the mechanism is slightly different. He said one is only blocking the L-type calcium channels, whereas simidipine is blocking both L and N-type calcium channels, which gives you additional benefits. Okay. Thank you very much.